Bismillahirrahmanirrahim. Assalamu alaikum warahmatullahi wabarakatuh. A very good morning to all the delegates who have joined online for this wonderful morning session of our highly anticipated webinar of the year, the 7th annual DPC conference, part 2, organized by Dubai Pediatric Club in affiliation with New Country Healthcare, Whatever Disorders and KZ, and NMC Specialty Hospital. Myself, Tawfiq Ali, Country Business Manager of New Country Healthcare. Before we start, I would like to play the national anthem of UAE in respect for this wonderful, vibrant country, which is going to celebrate its 50th anniversary in a couple of days. So, Mr. Fadi, if you can just play the national anthem. And
good morning, ladies and gentlemen. Thank you very much, Mr. Tawfiq. On behalf of the organizing committee of the 7th Annual Dubai Pediatric Club Conference Part 2, I would like to welcome all viewers from Dubai, UAE, GCC countries, and all countries across the board, especially India, to this conference. This conference is CME accredited and is conducted in collaboration with NMC Specialty Hospital, Dubai. I would like to thank the top management of the NMC Healthcare, especially Mr. Michael Davis, who is our chief guest today, and also the management as well as the CME team of the NMC Specialty Hospital, Dubai, especially Dr. Ramsha Shetty for the help and support. I would like to thank all speakers, moderators, panelists, and chairpersons of this conference for their active participation. Soon in a special ceremony, we will felicitate all of them, both Part 1 and Part 2 conferences. I would also like to thank members of organizing committee, especially Dr. Kalpana Singh Gupta, the secretary of the club, and Dr. Diari Muhammad, chairman of the academic affairs of DPC. I would also like to thank Dr. Joshi, the past president, Dr. Amir Tolemat, Dr. Ayman Jundi, Dr. Srinivas Bandari, Dr. Leila Bahari, Dr. Rafia Wara, and Dr. Khalid Rashid, the members of organizing committee, for their continuous support. Well, I would especially like to thank Mr. Tawfiq Ali, the country business manager of New Country Healthcare and Vitobiotic, for sponsoring this conference. I would like to bring to the attention of the viewers that he has been organizing our annual conferences for the last 7 consecutive years. And a special thank also goes to the members of the Dubai Pediatric Club for active participation in all DPC events. I would like to thank our chief guest, Mr. Michael Davis, the Honorable CEO of NMC Healthcare UAE, for accepting our invitation. We are honored, sir. Now, I would like to request you to deliver the inaugural speech. Please, sir.
Good morning, everyone, and thank you so much for the invitation to open the Dubai Pediatric Club Pediatric Conference today. I'm so sorry I can't be with you in person, but I wanted to send my very personal regards to everyone in the audience today, and particularly Dr. Saurabh and his team for putting together such an amazing conference. As I look across the agenda and I see us talking about pediatric hematology and oncology, emergency medicine, dermatology, and other areas that are going to be discussed and debated today, it makes me really proud to be a member of the UAE healthcare community. Every single day, not just at NMC, but all across Dubai, pediatricians such as yourself, those of you in the audience, put on your lab coats, wrap your stethoscopes around your neck, and you head into your clinics and to your hospitals to care for pediatric patients across the UAE. Every single pediatric patient, whether local, Emirati, or an expat such as myself, gets stellar treatment and world-class treatment here in Dubai. And the reason why they get that treatment is because of conferences like today. My hope today is that each one of you will challenge one another and that you'll listen and exchange ideas and really think of ways to improve your own practice and to take what we learned today and take it back to the bedside. I started my career many years ago in Houston, Texas, in the Texas Medical Center, caring for cardiovascular patients, many of which were pediatric. I spent some time at Tulane Hospital for Children in New Orleans, but if over my entire career, the most rewarding I ever felt was when I was caring for children and caring for pediatric patients, and the joy that I received from being part of an interdisciplinary care team caring for these types of patients. So I'd like to wish you the best of luck today. I hope that each one of you leaves today with something to take back to your practice and take back to your facilities to improve the lives of the patients that you're there to treat. And I send you my very best wishes. Dr. Saurabh, thank you again for your hard work, for putting this together. And I wish all of you a very successful conference. Thank you so much.
Thank you very much, sir. We are really honored. And now I would like to request Dr. Kalpana Sengupta, the Secretary of the club, and Dr. Diari Mohammed, the Chairman of the Academic Affairs, to say a few words before starting the academic session. Dr. Kalpana, please.
Dr. Saurabh, she is not able to join still, so I think we can continue.
Dr. Diari?
Dr. Diari also not able to join still, so I think...
Okay, now we will start the academic session. I would like to inform the viewers that we are having 4 sessions in the morning and 2 panel discussions in the afternoon with eminent, great speakers and panelists. Please stay tuned and don't miss any session. In the morning, we have 4 sessions. Session 1 is adolescent gynecology. Session 2 is oration, pediatric hematology, oncology. Session 3 is pediatric dermatology, and the last session is pediatric emergency medicine. The afternoon session, there are 2 panels, very important, hot discussions. Panel 1 is vaccines and immunization, and panel 2 is MISC with eminent panelists. Please don't miss. Now, I would like to introduce the chairman of the first session, Dr. Leila Al-Bahri, to take over. Dr. Leila Al-Bahri is a senior specialist pediatrician in Real Life Clinics, Jumeirah, Dubai. She is a member of organizing and executive committee. Dr. Leila, please, you introduce the moderator of your session and start the session. Over to you. Thank you very much. Dr. Leila, you are mute. You are mute, Dr. Leila.
Now, good morning.
Yes, yes. Good morning,
Yeah.
yes.
Good morning to all. Thank you, Dr. Zohrab. I will introduce our moderator for first session, Dr. Ruba Rizq, consultant, adolescent physician, Al Jalila Hospital, Dubai, UAE. Welcome to all.
Thank you, Dr. Leila, and thank you, Dr. Sorab. So it gives me great pleasure to introduce our first speaker. I'd like to first thank Dr. Leila and Dr. Sorab. Our first speaker is Dr. Manjula Anagani. She joined us all the way from India. She is the clinical director and head of department of obstetrics and gynecology.
Dr. Manjula, welcome. You start, please. Stay the way you start the session.
Dr. Ruba, it's a pleasure
Hi.
talking to you. Hi. And pleasure having all of you back. I hope everybody is able to join back now. So without delay, I think we should start off with our adolescent gynecology from where we thought we will start. And I'll start sharing the screen. And I thank Dr. Sarab and Kalpana for giving me this opportunity. And the million-dollar question is always about the adolescent gynecology, how much and what to treat, especially with parents breathing down the neck. And when we talk to adolescents, they seem to know everything. They feel they're immune to everything. And there's a long way to talk about diseases. Why do we have to know about anything now? We have long way. We will take it as it comes. We'll cross the bridge as it comes. And then never care for anything in what is happening in the world because the compliance is bad. You tell something, especially with hormones when we are playing, they play with that without knowing the consequences of the medicines which we are going to claim. And they claim to be listening, but they hear to us, they do not listen to us. And their priorities are totally different. So we have to keep in mind all these things before we talk about adolescent gynecology. I would like to take you all about what do we know about adolescent gynecology and what are the issues which we have to tackle, what are the challenges which we face when we are treating adolescents, and the limited little clinical scenarios in the time which is given to us, and the conclusions. So what we do know, right from 10 years till 20 years, it is still adolescence, but early would be around 10 to 14, and middle will be 14 to 17, and late is 18 to 20. And when it comes to issues, just like how we were taught in medical college, it can be from congenital like Mullerian to endocrinological, where we deal with hormones like PCOS, which is increasing, or primary or precocious puberty or menstrual dysfunctions, to infections, to inflammatory conditions like endometriosis, tumors, malignancy, and do not forget the miscellaneous things like breast issues, foreign bodies, and sexual abuse, contraception, very important vaccination, which you guys are going to tackle late in the afternoon. Challenges we face is examination. First, the parents are there. Always keep the mother with us when we are inspecting a girl child, and careful inspection of the child in a supine position with labial extension and retraction will allow us to visualize. But sometimes we do need the frog leg, butterfly. Otoscope is good enough to see the distal vagina when we have to examine. Always look at Tanner staging, both of the breast and the pubic hair, and the knee chest position sometime when we have to look for the foreign body. But when it comes to injuries, sexual abuse, always examine under anesthesia. So I would like to take you all about the common clinical scenarios we are facing day in, day out with these kids, and where do we stand there, and how do we go about it. Too early. When is it too early to have a menstrual cycle? When it is before 8 years, that is where it is precocious. The dilemmas we face is first to diagnose whether it is peripheral precocious puberty or central. And once we know it is saying, there are 3 questions which come to us. We know it is GnRH dependent. Should we go ahead and give LHRH analogs, because GnRH analogs do have their own side effects on the bone and bone densitometry? Second, if we don't treat, are we going to deal with the short stature, which is going to be permanent because of the estrogen where the long bones fuse? Or are we going to deal with the behavioral and emotional issues and the high-risk behaviors, which is going to be there in the form of sexual abuse? One thing which is important is, it is a reality that sexual abuse is going to be higher in girls with the precocious puberty, and the hormones are going to push them towards the high-risk behaviors. So GnRH analog agonists are here to stay, and we do have to give till when? Till about 10 or 11 years, till she's psychologically ready. And please give the add back in the form of vitamin D, and if necessary, estrogen, and if necessary, the calcium tablets. Peripheral, depending on the cause, basically we look at blocking the estrogen receptors in the form of aromatase inhibitors or the SERM. And amenorrhea, when is it too late? 14 years without sexual characteristics, secondary sexual, and 16 years with the secondary sexual characteristics. Then we have only 3 tests, which we always tell them. Do an FSH-LH, get an ultrasound pelvis, and karyotyping. That's it. We don't need gamut of the test. Examine her for the Tanner staging. We do know it is thelarchy, followed by pubarchy, followed by menarchy, with 1 year difference of the each after the adrenarchy. So this is the algorithm which we follow, where we do FSH-LH levels, and FSH-LH is less than 5, then it is hypogonadotrophic hypogonadism. And if it is more than 20, FSH-LH more than 40, then it is primary ovarian failure, that is hypergonadotrophic hypergonadism. In these 2 conditions, we have to think of keeping the secondary sexual characteristics intact and the uterus ready to when the woman is ready for fertility. Next, when we do the ultrasound, if the uterus is absent, then the karyotyping again comes into hand. And if it is XY, we are dealing with AIS, that is androgen insensitivity syndrome, or Swyer syndrome. And if it is 46XX, then it is Mullerian agenesis. If the ultrasound is normal, then we just have to wait and watch and look at diagnose for secondary amenorrhea like tuberculosis or Asherman. And if its outflow is having an obstruction, that is transverse septum or a vaginal septum or imperforate, we treat accordingly. So according to the etiology, the treatment is, so anatomy, you have imperforate hymen, cruciate incision. Transverse septum, surgical removal. Hypoplasia or absence of cervix, you repair the cervix, but if it's not possible, hysterectomy, otherwise they're going to end up with the retrograde fashion of flow and then endometriosis. If there's an absent vagina, we talk about neovagina. Then hormonal, we are dealing with gonadal failure or hypergonadotrophic. Remember, cyclic estrogen progesterone is important for initiation of periods, maturation, and the maintenance of secondary sexual. And also, if the girl is a short stature, never give high dose of estrogen in these people. And according, like I say, it's a 17 alpha hydroxylase deficiency, give corticosteroid and treat accordingly. Craniopharyngioma, do the surgery. Germinomas, according to it is radiosensitive, surgery is not needed. Kalmans, again, we treat with HRT. So everything depends on etiology. So for that, the nomogram is the most important. And I want to talk about a little bit about the Mullerian anomalies, is because the goal is when we talk about restoration of anatomy and preservation of fertility. So anatomy can be got. We can give a cruciate incision or we can create a thing, but function is very important when we are talking about fertility. So that might not be achieved completely. So we need to counsel the girl and the parent about it. Very common nowadays, and we are seeing increasingly, is the Ovira syndrome, that is the obstructed hemivagina with ipsilateral renal agenesis. We have to cut the vertical or the transverse vaginal septum. And if it is imperforate hymen, we go ahead with the cruciate ligament and remove at the level of hematocolpos, because once it leads to hematometra and hematosalpinx, the functional aspect of the lining of the ciliary lining of the tube and the endometrial lining is gone. So this is one neovagina I want to show, apart from the neovagina McIndoe techniques which were given before. This is our novel technique which was published in the JMIG, that is the prestigious minimally invasive surgery guide, the Journal of America. So let me show you this video. I'll run across to that. So this is an obstructed, this is the RK head syndrome. We have the central septum, which we see on either side of the septum, vertical septums. We give the vasopressin on either sides. And then by using the modified Shear's technique, we go on either sides of the septum, we dilate using the Hagas dilator. So by that it is the position of the pelvis which is very important, because vagina is transverse and never vertical. So when we do a we allow the buttocks to fall beyond it and flex the pelvis, that is the hyperextension by 150 degrees of the thigh and the knee joint. This is the position we get. And slowly, once we get the bilateral on either side of the mid septum, we give this thing, and in the middle we cut it. We get the full length of about 9 to 10 centimeter length between the bladder above and the bowel behind. So graded dilatations are done using the single blade speculum, and we reach till the peritoneum almost is reached. So once that is done, then we go ahead and form the mold. What is this is where you can see the complete vagina, the new vagina is created. Now we are inverting the mucosal lining which is there on either side, allowing the mucosal lining to develop between the vagina which is created and the mold which we put. So we intern the mucosal lining on all the 4 edges. Once that is done, Then we are going to form the mold. This is the 4 angles where we have interned the mucosal, normal mucosal lining. So the vagina which is being formed is formed by the lining of the normal vaginal mucosa. So we take a 8.5 number glove and we make a mold with the either the big finger or the middle finger. We put a Vaseline gauze, which is a softer mold. We do not take anything which is hard because no pain. That's the ideal thing which we are doing it. So once we make it, then we try it out, and at the level of the about 9 to 10 centimeters, a liberal amount of antibiotic cream is then applied, and the condom is now put again on it, and we put the air to go into it. We put multiple holes, and then we tie it. And again, we are putting a lot of antibiotic on it. And then comes the interseed. What is interseed? It's oxidized with the regenerated cellulose. So what is happening is that will prevent the addition between the mold and the neovagina, which is formed. So this is then mold is put, and then the vulva is then sutured on the top and the below the mold, which is then created. This mold is left in place for about 5 days. Catheter is placed in place for 5 days, and this is the end of the procedure. So when we finish the procedure, after 5 days, after 1 week, when you see, this is the way the mucosal lining looks. The mucosal lining is the normal, and you can see more clearly. There is absolutely no addition, normal mucosal lining. This is at the end of 4 weeks. This is end of 4 weeks where we can appreciate no pain with the complete speculum which goes in. So this is to date. In the last decade, we have done 58 cases, and of RK syndrome of 53 and AIS of 5 cases. Operating time is only 26, and it's only single surgeon. We don't need any plastic surgeon. At the end of it, it's almost 10 centimeter in length, and there's no dyspareunia in normal sexual life with all the 24 who have been there. They're told to use the dilators with a lot of liberal amount of estrogen so that the epithelialization happen. And we had with the surrogacy 2 babies and ongoing pregnancy 1. So when it comes to, we have finished with the precautions. When it is too late, that is amenorrhea. Then comes the, when is it we deal with the abnormalities? That is what we call now the FIGO classification, that is palm coin classification. PS, structural causes will be polyp, adenomyosis, leiomyoma, and malignancy. Then we deal according to the cause. When it is non-structural, that is when it is coagulopathy, ovulatory dysfunction, endometrial, iatrogenic, and not classified. With adolescent, only 2 conditions come across in front of us. One is anovulatory. That is the underdevelopment of HPO axis. Next comes the bleeding disorder, that is because of von Willebrand disease, which is the most common. With ovulatory, what is it? How do we treat? What are the recommendations? When they're not desiring of fertility, it is always the COC, combined oral contraceptive pills, is the first line of management. Cyclical progestin should not be used as specific treatment. Norepinephrine, initially to understand the diagnosis, the first cycle we do put it. Later, after 1 year, we can reassess. Surgical management is not at all advocated for any hormonal imbalances. Sometimes when the patient is not compliant, we can, and COCs are contraindicated because of any reason, then we have the LNG-IUS, which we use. In adolescent, it is both the hormonal and non-hormonal, which we use when you have an ovulatory dysfunction. When it is a coagulopathy, we again have the hormonal and the non-hormonal option. We give the tranexamic acid initially, and if it doesn't work, that's when the COCs and LNG-IUS we have. But we have to have some consideration. If the still bleeding is there in spite of the hormonal treatment, that's when the specific factor replacement or desmopressin we use, or if there is a surgical intervention to be done, again factor replacement or desmopressin. These are the 2 conditions for the ovulatory dysfunction which we have. Let us go to the next topic, that is PCOS, which is now seen in 70 to 80% of the young girls who are coming to the gynecological clinic or adolescent gynecology. This is the most common endocrine disorder and associated with specific significant morbidity because reproductive health is impaired, psychosocial dysfunction, metabolic syndrome, cardiovascular risk, and increased cancer risk. But the controversies exist. To start or not to start? Should we treat symptomatically or should we target the disease? Because the etiopathogenesis is still non-existent. We don't know about adolescent. Diagnostic criteria is different in adolescent and adult, and the recommendations are different. So 3 sets of diagnostic thing is for adults, that is NIH, Rotterdam, and AEPOS. And then NIH, it is irregularities and androgen excess. This is what we use in adolescent now. Rotterdam, it is always 2 out of 3 of the biochemical, clinical, and ultrasound. Ultrasound is deferred when it comes to the adolescent. So we are basically looking at menstrual irregularity and androgen excess. This is what we look at. So clinical is either we look at androgen excess and menstrual irregularity, that is the acne and hirsutism and the irregular cycles. Biochemical normative challenges are because testosterone levels are not still, whether we are doing a total or whether we are doing specific free testosterone, the levels are still yet to be defined when it comes to adolescent. And in PCOS, it can be what is normal, what is abnormal in the imaging is not very clear. So imaging is differed. And most of the time, the mothers get the kid with the ultrasound picture of PCOS. That's when the problem starts. And what is the physiological adolescence irregularity is still, we don't know. Because the evidence of ovulated dysfunction in adolescent is consecutive menstrual intervals of more than 90 days in the first year, and less than 21 days and more than 45 for 2 or more years. Till 2 years after the menarche, it's still okay to have less than 21 days and more than 45 days cycle. Lack of menstrual menses by 15 years or 2 to 3 years after breastfeeding. All these come under PCOS or primary PCOS when we are looking at, and evidence of androgen excess, that is persistent elevation of serum total or free testosterone, moderate or severe hirsutism, and persistent acne not responding. Imaging should be deferred because every other patient will come to us and first we are doing a transabdominal, transvaginal cannot be done, and we really do not know what we're dealing with. So diagnosis on the day 2 of period, menstrual cycle before 8 o'clock, fasting serum FSH, LH are to be done, and androgen excess is by serum testosterone free or total. Both irregular cycles and androgen excess for minimum of 3 years will lead to risk thing. So treatment is, what are we going to treat? First 50% is only the patient initiative. So symptomatic treatment is what we are looking at, and lifestyle modifications come first. When I say lifestyle, it is each muscle should be contracting. So it is a physical exercise, not just walking. It is it can be Zumba, it can be aerobics, it can be cycling, where every muscle contracts and the insulin receptor reacts. Second, de-stressing. It can be music, it can be dancing, anything which helps the kid. Third, the dietary modifications where we look at low carbohydrate, increased protein, and average fat. So it is a combined OC pills, which is the first line of management where we are looking at, which is a desogestrel based, or we can look at drospirenone based depending on the symptom. The patient has a water retention or the girl has a PMDD, then drospirenone comes first, otherwise drospirenone or desogestrel based OC pill. Or for PCOS, we have the cypriterone acetate based pills. But the combined ethinyl estradiol level is only 0.03, 30 micrograms, which we use in this case. Now, metformin comes only when we do a HOMA IR, and it is definitely superior to it for the weight reduction and improved outcomes. So when we join the COCs and metformin, often we combine with along with the symptomatic, and we're looking at acanthosis or something like that. Definitely the topical managements in the laser or for the hirsutism makes it the superior treatment. Goals are, we are looking not just at that time, but we are looking at the long-term health outcomes in the form of morbidity. Then taking you all to the dysmenorrhea, which is the thing which the girl comes with acute pain and a lot of psychological stress because of that and loss of the school. Primary dysmenorrhea is seen in 85%, which is spasmodic. The $1 million question which I hear from pediatrician is, should we treat, should we give, should we not give? It is very important to treat spasmodic dysmenorrhea, because if we don't treat them, there will be a retrograde flow of the menstrual blood in through the fallopian tubes into the POD, leading to implantation of the thing and endometriosis which comes. So definitely treat them with NSAIDs, which is the first line. Otherwise, next comes COC pills, recently even the LNG IUS. The secondary comes because of a cause, that is endometriosis, PID, fibroid, and treatment is according to the cause, and the congestive dysmenorrhea is what we label it as. So this is the algorithm. First is always give NSAIDs. Then we can also give hormonal treatment and non-hormonal treatment of acupuncture, dietary modifications, everything works. If they respond, just continue that, don't stop it. It's not like how long to take, give it as long as it comes. With primary dysmenorrhea, that is spasmodic, most of the time, once the semen comes in touch with the cervix, it is a prostaglandin gets released and cervix get softened and the pain comes down. But some people, in about 10%, it is the normal vaginal delivery with again the prostaglandin release and the pain comes down. If they do not respond to therapy, think of secondary dysmenorrhea, do an ultrasound. If ultrasound shows something, treat accordingly. If it does not show something, Do not forget, it can still be endometriosis, put in a laparoscope and treat. This is the approach to treat for dysmenorrhea with adolescent. Then comes the dreaded disease of endometriosis, because it takes on an average 9.8 years for the actual diagnosis of endometriosis. In about 50 to 70% of the people, they do not respond to NSAIDs. And in 60%, 66% of adult women who develop endometriosis, the onset is at the level of adolescent age. So high degree of suspicion is what is important, which will take us to the diagnosis of adolescent endometriosis. The mean age of diagnosis is 18 years, and risk factor is important. Uterine tract anomaly is associated in about 40%. So menarche at an early age is also a risk factor, and ovaries are the ones which are involved in 93%, not just the pelvic floor. So this is what we should be looking at. The goals of treatment here in endometriosis in adolescent is, first, symptom relief. Second, we should stop the disease progression. Third is remember the future fertility. So we have to look at everything, but the conservative surgical therapy is the gold standard. So then followed by ongoing suppressive medical therapy till she thinks of pregnancy. So it can be 3 years, 4 years, 5 years. We should just go ahead and start treatment. So laparoscopy is you remove the whole disease, followed by medical management in the form of GnRH analog or the COG. So this is the algorithm. Start treating the pain. If the girl comes with the pain with combined OSA pills and NSAIDs. The pain persists, do a laparoscope. If the endometriosis is not there, then it can be a urological or gastrointestinal pain. If the endometriosis is seen and if a girl is less than 16 years, treat with COC till she thinks of pregnancy. If the girl is more than 16 years, give a 3 cycle of GnRH analog, 3 to 6 cycle with add back of estrogen or calcium and vitamin D, followed by continuous combined hormonal therapy till she thinks of pregnancy. If the pain is still there, then refer her to a tertiary care where good laparoscopy is done with complete resection of endometriosis. This is the most debilitating disease. And I want to just show you one. This is girl, a medical student, where persistent pain was there. And the green line showed a small implant, a white implant of endometriosis. And we removed this implant and send it for histopathology and CD10 immunohistochemistry. Now that came CD10 positive. That means it is endometriosis. And she only responded to LNGIUS, first the OC pills and LNGIUS. Now she's joining gynecology as a postgraduate. So high degree of suspicion. We caught her around 12 years of age and she's on treatment. Next, finally, we have this ovarian masses. They come with abdominal pain. It can be a palpable mass. It can be the symptoms, bloating, irregularity, precocious puberty, whatever it is. How do we go about? It can be ovarian or other, we go accordingly. If it's ovarian, whether it is functional or neoplastic. If it's functional, just wait and watch. In 2-3 cycles, the ovarian cysts are going to disappear. If it's a neoplastic, then again we look at whether it is benign, borderline, or malignant, or sex cord, and treat accordingly. If it's germ cell, most common is again dermoid cyst. Rest all, again, it can be a serous thing, and whether we are dealing with whatever we deal. So the investigation will be ultrasound to rule out between ovarian, non-ovarian. If it's non-ovarian, it is appropriate follow-up. And if it's ovarian, we again look at multiloculated or uniloculated. Multiloculated pre-menarche, look at karyotype. What are we doing with actually PCKD, which is there, or what are we dealing with? Then when we are looking at post-menarcheal or pre-menarcheal, observe for 2-3 cycles. If it decreases, fine. If it increases or persistent, do the tumor markers. And the same thing happens with this. And then if it doesn't come down, it's always the surgery. Now, the commonest being the dermoid. What is very important is the controlled, contained removal of the dermoid cyst so that it does not spill. The second, never remove the ovary. How much ever the big the dermoid is, we still have the ovarian tissue, which we have to save. So in this, we remove a little different technique where we should not touch the ovarian cyst because we don't want it to spill. So we give a small incision only on the top and we go in between the plane and it just comes out like one grape out of the cover. But here, the pressure is never put on the dermoid cyst at all. We go in between, leave some amount of the loose areolar tissue so we can hold, get it out, look at that, and it comes out like one nut which comes out of the shell. So once it comes out, the next thing which comes there is how to remove it. We don't want it to spill. Okay. If it comes, we have to keep it contained. And once it comes till the end, and see it has come, then endobag. Always put the dermoid or endometriosis in the endobag and remove it, exteriorize it through the abdominal port. See, put it. When you're putting also, don't allow it to spill. Then get the whole, this is a homemade endobag which we make. So the cost effectiveness comes. Then once we get it, then close it so that the spillage does not happen, and exteriorize it and remove it through the abdominal port and decompress and remove it. At the end of it, look at the ovary, just leaving the ovary, it won't bleed, or if we have to freeform, we reform the ovaries, get back to their shape. So next comes the torsion. That is the most important thing why we need to operate when we see an ovarian cyst. Because if we don't take care, the most heavy of it being the dermoid cyst, next comes the endometriotic cyst or the para-ovarian cyst, the fallopian tube and the ovary can go into twist, and it is associated with a cyst as much as 46% of cases. The congenitally long ovarian ligaments, excessive laxity of the pelvic ligaments, a relatively small uterus, which gives the space for the cyst and the ligament, which will allow the adnexia to twist. So the most common, like I said, is a teratoma and a cyst. This is the algorithm with which we go. When a girl comes with acute pain, we see the scan, and scan shows adnexal torsion. We have asymmetric ovaries, bigger ovary here, and we have the whirlpool sign, and we look at Dopplers, if the blood supply is lost or not. And immediately we go ahead, no role of diagnostic, operative laparoscopy. And findings which are not suggestive and it's normal ovary and symmetric ovaries and pain persists, then look at other etiology. So once we see, then what are we going to do? Do we think it is necrotic and remove the ovary? No, look at this. This is the twisted ovary. Untwist it first, then decompress the ovary because the heaviness has to come down. Then we have to do oophoropexy. Oophoropexy has to be both laterally to the lateral pelvic wall between the ureter here and the external iliac vessels. So we have to do 2 sutures to the using a Vicryl to the ovary to the lateral pelvic wall. So this is a wrap 1, wrap 2, hold the knot and suture. So once we do that, the next step would be the ovarian ligament plication. That is a shortening of the ovarian ligament. So this is what we are doing. We have got the oophoropexy done here. So once the oophoropexy is done, we are plicating and shortening the ovarian ligament without compromising the vascularity. So this is what we are doing. So then there is no question of ovary twisting again. Prophylactically, we also do the other ovary. When you can see here, the ovarian ligament plication of the other ovary, and then the oophoropexy of the ovary, this other ovary is done because it is a congenital elongation. So once that is done, we get back and we save the ovaries so that we do not, you can see the plication here. It will be an adhesion which will be formed, and then it will be in place. This is the way it looks. Now, does it happen all the time? No, this is a kid who did not attain menarche. She went around doctor and to doctor, place to place, till about 3 months before she landed with us when we saw bilateral ovarian twist. We untwisted, decompressed, and this side we wanted decompressed. Look at the necrotic ovary. So I could not save the left ovary because it was 3 months and it lost its supply. So again, oophoropexy, and like I said, the ovarian plication which is being done. After this, with 1 ovary being functional, she got her menstrual cycle, her FSH, LH came back to normal. She's about 16 years now. So with any sort of torsion, never remove the ovary. After 36 weeks, the human tissue nature is very good and we can save the ovaries. And
Dr.
finally,
Manjula, we have 1 to 2 minutes left. Just letting you know.
Only 2 minutes. And do not forget the vulvovaginitis, which can still come in adolescent girls, sexually transmitted diseases, teenage pregnancies and their complications, and the vaccination. I only want to talk about the Gardasil, and do not forget the Orisavarex, that is cervical cancer vaccine, and give the option of contraception rather than them coming for teenage pregnancy. Thank you all. Dr. Ruba, you were wonderful in helping me with this, and Dr. Zorab and Dr. Kalpana. Thank you all for giving me this opportunity.
Thank you, Dr. Manjula. That was a wonderful, comprehensive and thorough talk over adolescent gynecology. I think you actually went through pretty much most of the things that we see in practice, and I hope some of our audience were able to get some tips. And now I will leave it to the audience. Please let us know, do you have any questions that we can pose to Dr. Manjula? I've already received one from Dr. Krishnamurthy. Dr. Krishnamurthy is a former colleague, and basically what he had asked was whether, in his opinion, he had traditionally treated girls coming in, adolescents coming in with polycystic ovarian syndrome with lifestyle changes and dietary modifications first, and reserved combined oral contraceptives for second line. And he'd asked to comment on that.
Thank you, Dr. Krishnamurthy, for the wonderful question. This has been always the mindset of the parents and even the treating physician, because they were very scared of the hormonal treatments and whatever side effects it comes. But remember one thing, it is always the parallel treatment which works. It's a multi-pronged therapy, which is very, very important, because one alone is not going to work. When there is a hormonal imbalance and the HPO axis is deranged, do the second day FSH LH. On the second day, when it has to, the hormones are supposed to be at the level minimum, the FSH LH ratio should be 2:1. FSH, that is the follicle stimulating hormone, should be at twice that of LH, because you do not see LH, luteinizing hormone then. But if the hormones are altered, LH is more than FSH, 2:1 or more. If we don't get it back to normal, this is not going to come back. And this unopposed estrogen will lead to malignancies of endometrium, which we see in 24-year-old kids also. So we have to worry about the unopposed hormonal axis and the estrogen. And the androgen axis itself will have the lot of psychological and physical effects on the kid in the form of hirsutism and the acne, which the girl goes into a depression, and that itself will lead to a lot of psychosocial problems, and which we all know how it is going to be. Yes, the lifestyle modification is very important, but doing exercise will not help if the insulin resistance is more. After a particular point, they cannot lose weight if the insulin resistance is more. So if you are looking at HOMA-IR more than 2, 1 is normal. Till 2, we do not give metformin. More than 2, we start metformin, because we have to sensitize the insulin receptors. If the insulin receptors are not sensitized, how much ever exercise they do not lose weight. So we have to look at lifestyle in all the 3 forms, that is exercise, dietary, and the de-stressing. Because we do know the stress is the one which starts the adrenarche issues and the hormonal issues. Because cytochrome P450 is at the culprit, where both at the ovarian level and at the adrenal levels. Then we do know HOMA-IR, we check, and if it is more, we start metformin. If FSH-LH is altered, we start the cypriterone acetate base. The reason I select cypriterone acetate base is that most of the time mothers are taking the other OC pills, and they don't want to get worried that the daughters are also using the same OC pills. So I look at Diane or Crimson or something like that.
Thank you, Dr. Manjula, and I completely agree with everything you have mentioned. It's just been always hard to discuss combined oral contraceptive pills with our patients and their families, especially with the cultural concerns that they have here and reservations. So I'm going to move on. We have a lot of questions coming in, all related to polycystic ovarian syndrome. So I'll ask those first, and we'll get those out of the way. So one question coming in is the link between obesity and PCOS. This is from Dr. Kalpana Sengupta. What comes first, they want to know.
Yes, that was the point. That's the reason the topic was how much and what to treat. See, the point, Dr. Kalpana, is it is always, we have the lifestyle changes happening from the kiddo. From LKG, we are putting them on a lot of stress. We are not sending them out. They become couch potatoes. They're using junk foods because we want something easy to come to them. So we cannot say which comes first. It's a vicious cycle. Is the chick first or the egg first? We cannot tell that. But if the insulin resistance is there, but grossly what we saw in PCOS is androgen excess and the insulin resistance are the basic culprits of majority of the problem. The FSH-LH alteration follows next. So if these two are tackled first, the rest of the things can come into thing. But saying that if the insulin resistance is high, how much ever they try to lose weight by doing only lifestyle modifications, it will not come under control if the insulin sensitizers are not put. So if the kids who are not having stress, which is very difficult in today's time because of the exam stress which we are giving them, not having stress, and they do a proper exercise schedules and they play, most of the problems are solved.
What I always tell the parents and the families is it's the chicken and the egg situation. Which comes first? We don't know, and research has not shown us yet. One causes the other, and there's a link, and hopefully we'll find the answer. All right, let me move on. We have from Dr. Mayan Afnan Sharif. Why is PCOS so common nowadays, and what could be done to prevent it? And if it happens, what's the best conservative treatment for it?
Dr. Mayan, that is the thing. We do not see PCOS in, I don't know if I can use this word, but laborers, kids and all who are not having stress on their life. Their work was only to play and eat and enjoy and sleep. They were having a very de-stressful life. But nowadays, we are having a lot of stress on the kids right from the thing to get, they want them to be super kids. They have to get the first or second rank. They have a lot of achievements to achieving the goal. They should not disappoint the parents and their peers. So a lot of peer pressure and all this stress. We do know adrenarchy starts before even the thelarchy and menarchy and pubarchy. So at the level of adrenarchy, when the cytochrome P450 is the thing which is working there, a lot of stress comes. There's an alteration at the level of adrenals, and that leads the initiation of it. So from a 7th, 8th class, if we are not giving them stress, I mean, how much ever you want to read, you read, don't have to worry, go play, then the other factors will not come into thing. So that the stress is the initial culprit. Second, the dietary junk food which they are eating, where the carbohydrates are very, very high, leading to obesity, and that again leading to insulin resistance. Then next comes the couch potato syndrome, where exercise has become zero. So all these three things have led to increased incidence of the PCOS in today's time. And do not forget the endocrine disruptors. The lot of pollution and the plastics which are in the environment lead to development of endocrine disrupting chemicals, which will completely have a aberrant progesterone action. It is the aryl hydroxylate which is getting affected by this endocrine disruptors. So the progesterone which is being produced is not acting well. Initially, we used to think it is the estrogen which is the culprit. But no, it is the aberrant action of the progesterone, which is leading to unopposed estrogen action. And this is leading to, again, the obesity, the fat producing estriol again. So this is a vicious cycle which is happening. Estrogen leads to, again, increase the fat. Fat leads to, again, estrogen. Estrogen leads to endometrial hyperplasia, endometrial cancer. And this again leads to, the fat leads to, again, insulin resistance. So this is all going on. But I think the best is lifestyle modification from childhood and de-stressing them from childhood.
Actually, there is a question about teens with abnormal uterine bleeding and or polycystic ovary syndrome who need hormonal management. Here in the region, may be typically resistant to prescribe combined hormonal contraceptive pills.
Yeah, Dr. Laila, thank you for this question, because now resistance is from the physicians, but if it is explained properly to the patient and the consequences of PCOS, they are open for it, because it is the counseling which makes a difference. So first we need to understand it is important to treat them, otherwise, because they are pediatric patients, so we are not actually seeing the adult, but we are seeing the adults where at 24 years, they come with infertility, they come with endometrial hyperplasias and cancers, and little later they become diabetic, and they can have gestational diabetes and also hypertension, obesity, and heart diseases and cancers. So if it is neglected at the level of the pediatrician, they are going to end up with metabolic syndrome. So the understanding should come from the physician, the counseling should happen to the patient, and the patient attendants are always open if it is told properly. So the COCs is the way to go forward. And with the latest 4th generation COCs, the side effects are literally zero. And only thing is, if there is a prothrombotic action, we do not look at estrogen, but with 30 micrograms They do not have any side effects. And progesterone is the thing which keeps varying between cyproterone acetate to desogestrel to drospirenone. The regular norethanyl, this thing, we do not use it for adolescents usually.
Can you tell me if there is a benefit from progestin-only pills over the contraceptive?
No, absolutely no, absolutely. No. That is why I put evidence-based medicine. Level A medicine is only progesterone should never be given because we are trying to suppress the HPO axis. Here the culprit is coming from the HPO. Only progesterone is allowing the aberrant release of estrogen, which can still act on the fat and cause obesity. We are not looking at only the target organ. Target organ is uterus, and progesterone acts only on uterus. It will not act at the HPO axis. Here, the aberration is at the level of HPO axis, and we are looking at COCs to stop that aberration. And we are telling them, you need to correct yourself.
Okay, thank you. Thank you.
And I'll add one point of that, Dr. Leila, just regarding the progestin-only pills, is in adolescents specifically. We have to keep in mind compliance. It's an issue across all disciplines within pediatrics. Once they hit the teen medicine, the teen age, it becomes so hard to get them to take medications. With progestin-only pills, you really have to take it on time. You really have to take it for a specific amount of days. And getting a teenager to comply with that becomes impossible. So even if they do not have, if we're going to talk about it from an abnormal uterine bleeding perspective, when they're coming in with this uncontrolled heavy menstrual bleeding from anovulation, which is the most common cause, it is always easiest, it is always safest just to prescribe the combined oral contraceptive pill, because it's so hard to get that bleeding controlled with the progestin-only pills for teens. And here in the region, most gynecologists are more comfortable, and families do not realize that whether you go progestin-only pill or a combined oral contraceptive, it's all hormones. Yet for some reason, the push is always towards the progestin-only pills. You can do that for an adult woman. She's more responsible, she's more capable of following the rules, but a teenage girl is not going to do that. So that's why from our perspective, and Dr. Manjula, we always recommend first line, unless there is a contraindication to estrogen, as Dr. Manjula said. And in teens, again, that's really rare that we come about these issues, but caution, we have to be cautious as with everything.
Actually, thank you. Still, we have 2 minutes. I want to ask Dr. Ruba about the HPV-9 vaccine, which recently has been made available in Dubai. But still, we have patients, families resist also for the vaccination. What is your advice for pediatrician to how can tackle this hesitancy for the vaccine?
So you know what, as with all other vaccines, if you trust your physician, and if we as physicians come in and just with our message say that this is a standard vaccine for adolescents, we don't just mention the tetanus booster, but we say as a teenager, it is currently recommended that you get your tetanus booster, your HPV vaccine, and your meningococcal vaccine. When we say it with conviction, and our patients are ours, and they already come to us because they are convinced of our clinical practice, they're more likely to accept it. And also depends on us and educating them. So it's very important for us to inform these families why there's a push. It's our first vaccine against cancer. The comeback always says is, oh, but my teen is not sexually active yet. Why should I give the vaccine right now? Maybe I'm sending my teen the wrong message and they're going to go out and have sex. But this is, again, it's one of the things I always say is, okay, hepatitis B was given to you as an infant, or you provided it to your child as an infant. Hepatitis B is an STD. That's what we're doing, is we're protecting through bloodborne sexually transmitted infections. But that tends to be much more accepted. We educate that the younger they get the HPV vaccine, the better. It's research proven that the immunogenicity and the antibody response that they generate, the earlier they get it, lasts longer and higher antibody levels. So again, delaying it is contradictory. It's contradictory to what the evidence says. Lastly, you want the patient to protect herself against the cervical cancer. And we always tell them that even if virginity is preserved, you cannot always know where your partner, your future partner, has been. And it could be easily transmitted through that means. And sometimes by just discussing this, families immediately become more accepting. And now that we have HPV-9 replacing HPV-4 in DHA in Dubai and the UAE, you know, we are strongly recommending it. And please don't forget the boys. Vaccinate the boys. Although here in the city, they're not yet vaccinating the boys, but it is just as equally recommended so that they can protect their women.
Okay. Thank you so much for this interesting.
Can I ask
and this
one
is
question?
over now. Thank you.
Can I ask one question, Dr. Manjula?
Yes, please.
Yeah. Good morning, everybody. Thank you, Dr.
Good
Manjula.
morning.
Very
nice.
short, Dr. Diari, since we are over, just very short, please.
Just one
Final.
question. Dr. Manjula, thank you very much. I found that one of your cases with the new vagina formation was 46XY androgen insensitivity. So when you decide in androgen insensitivity to do neovaginoplasty when it is 46XY and when you remove the gonads? Thank you.
Every case, gonads have to go. When it is 46XY, gonads. Turner was also something removed. Sometimes we keep it. If it is Swyers, they have vagina, so we don't have to create. But when it is AIS, we will have to create. The purpose is for the gonadectomy is to prevent gonadoblastomas. To create vagina is for them to get married and to go on in life.
Even if they are not intra-abdominal, even if they are the testes in the groin or scrotum?
Yes, we have to remove. Usually it is when we have this mixed.
We can discuss later. Time is over now. I would like to request the panelists, we'll discuss in the break. In the break, we'll discuss this because, sorry, Dr. Diari, we have to go to the next session.
Yes, please.
Thank you, Dr. Manjula and Dr. Ruba, Dr. Laila as well for this wonderful session, very informative. And I know a lot of questions are left unanswered due to shortage of time, but maybe you could type the answers and we will take it up later. We move on to the next very much awaited session, which is the oration. And for this, I would like to invite the chairperson, who's Dr. Sohrab. Dr. Sohrab is very well known. He's the president of the Dubai Pediatric Club, the man behind today's event, without whom nothing of this would be possible. He is also the senior specialist pediatrician at NMC Specialty Hospital, Al Nada. Over to you, Dr. Sohrab.
Thank you very much, Dr. Kalpana, for the nice work. Now, I would like to tell the viewers that this session is oration in the name of the founder of Dubai Pediatric Club, Dr. Cyrus Letkuhi. This oration is given to none other than Dr. Nitin Shah, who will be introduced by our moderators. We have two eminent, well-known moderators, well-known in Dubai and UAE. Dr. Anjan Madusa, senior pediatric hemato-oncologist from Dubai Hospital, Dubai, UAE, well-known in the DPC, who has been our speaker for many occasions, and Dr. Mahmoud Al-Hussein, consultant pediatrician and with a special interest in pediatric hematology from Latifa Hospital. He is also associate professor at Dubai Medical College, Dubai. Now, I would like to request Dr. Mahmoud to introduce the speaker, Dr. Nitin Shah, and start the session. Over to Dr. Mahmoud and Dr. Anjan, please. Dr. Mahmoud, you are mute. Your mic is mute.
Dr. Mahmood, if you could hear us, please unmute yourself first, Doctor.
Dr. Anjan, if he's having problem, you can just introduce, Doctor.
I don't have the whereabouts of, I didn't take it actually because I was not in.
Dr. Nitisha doesn't require an introduction. He's well known. He was the past president of Indian Academy of Pediatrics, professor, head of department, pediatric hemato-oncologist, vaccine specialist, everything. Books can be written and oration can be given on his profile and CV. Why don't know? Dr. Mahmood is not unmuting. Dr. Nitin, I think you can start.
Yeah.
Yes, please.
Welcome, Dr. Nitin. Dr. Nitin has been my teacher and well known in India in the field of pediatric hem-onc. Over to Dr. Nitin. So it's a pleasure to hear what he says today.
Thank you, Dr. Saurabh, Dr. Anjan, Dr. Mahmood, Kalpana, so many other friends from UAE. I'm really honored to give this oration, the title of which I've chosen as the Next Generation Investigations, a boon or a bane. And essentially the next generation investigation that I'm going to speak on is the next generation sequencing. Because that's a tool which is in our hand, which is both used as well as misused rampantly in today's time. And as Dr. Saurabh was saying, I would really like to bow to this great person, Dr. Cyrus, who way back had the dream of starting this Dubai Pediatric Club. And we all know Dubai Pediatric Club, what it is today. It's one of the most popular pediatric sort of association or a forum, which holds very regularly CMEs, which are all archived on the YouTube. And this is the second time that I'm appearing for DPC. First time I did was on the COVID vaccine. And today I have chosen the topic of hemato-oncology. Now you will wonder as to why this. So pediatric hemato-oncology and immunology is my profession, whereas vaccination is my passion. So today I'm going to first talk about my profession, and in the later session, I'm going to speak on the passion when we do the vaccine dialogue. Pediatrics came as a career, came as a God's gift to me, because like I was almost the last student who could have got pediatrics, and there were no seats, but I applied for it, and lo and behold, one more seat got added, and I got pediatrics. And after that, pediatric hem-onc came as a chance, because my teacher, Dr. Lokeshwar, was himself learning hemato-oncology 1985-86. So he is the one who actually introduced me to the Sion Hospital, and I worked there for almost 5 to 6 years as research officer in the pediatric hemato-oncology division. And then later on, I also established HIV OPD there, because that time HIV was mainly because of blood transfusion. So it was the forte of not ID specialists, but of the hemato-oncologists. And then I became the president in the year 2006 of the Indian Academy of Pediatrics. And we brought out these guidelines, and these guidelines had more than 14 of them, of which almost 9 were on hemato-oncology topic. So there were various topics, as you can see here, where we used to have 1 or 2 days of consensus meeting and then come out with the guidelines. And these are the books that then came out during my tenure. The first book on a specialty series on pediatric hem-onc. Then we, through our own effort with Dr. Lokeshwar, we brought out this book on hemato-oncology, and then one on fetal and neonatal hematology. And all of these are very popular and available. And then the greatest opportunity actually was when I joined Wadia Hospital in 2002-2003. This is an epitome of pediatric practice. And what you see anywhere in the world, you see in this institute, which is like a 300-bedded only children's hospital in the city of Mumbai. What I'm going to talk in the next 40-45 minutes is that you should think out of the box when you are pushed against a wall. And I'm going to discuss all this in the form of a case base. So that will be very interesting instead of giving a didactic lecture. I am not going to go into the nitty-gritty of next generation sequencing, because that is the forte of geneticists. But I'm going to show how, if you use this NGS, initially we were doing clinical exome, then we are now doing whole exome. You can even do whole genome, depending upon how much you can spend and based on the need that you have. But over the time, the availability and the cost, both are becoming easier for the patients. I remember years back, we didn't have any of them, and we had to send samples outside the country to some Western countries where they would do the targeted panel. And then gradually the first lab, and then at least 6 or 7 more labs have joined in India, where you get the NGS. And I'm sure the same must be true for the UAE. And the cost, which was exorbitant, like in India, it used to cost 30,000-40,000 Indian rupees, to now it has come down to 15,000. So it's come almost 1/3 over the last 4 or 5 years. So let's start with the first case. And I'm sure Anjan will agree that he also uses a lot of these NGS almost at the drop of hat, especially because many of your patients can afford, but we have to be very careful when you do it. Also, it's not easy to interpret these results every time, because sometimes you can get more confused, then it can come to your health. And all the cases that I'm going to show you are in hematology. There's a lot of use of this NGS in oncology, especially where you have a rare tumor or a relapsed patient, where if you have done an NGS or you do it now and you find out some mutation which is amenable to a specific targeted therapy, then you can have even better cure than what you can have with conventional chemoradiotherapy. So this is a 3-year-old girl who was born to consanguineous marriage. Now, consanguinity is a very important message for genetic disorders, and I think that's something which we must keep in mind. She was a case of congenital deafness which was posted for cochlear implant at a public hospital in Mumbai. A pre-op fitness investigation showed that she was anemic. And then while going into the history, from 7 months of age, she had anemia, she had a breath holding spell, she had received transfusion once on a hemoglobin of 2.5 at the age of 1 year. That time the hemoglobin was very low, the differential looked normal and the platelet looked normal. The indices were not available for review, though the smear had shown that there was macro, micro, aniso, and poikilocytosis, probably some nutritional anemia-like picture, which is not uncommon. Someone had done iron studies and electrophoresis that time, which were normal as a part of the workup of anemia. Over the years, she had received oral iron, multivitamin, but not much benefit. The hemoglobin will hover between 2 grams, which was the lowest, but generally between 6 to 8 grams. And the first CBC done at 1 year, which had all the indices, actually showed that she had little macrocytic MCV 93, borderline high, but otherwise nothing great, normal WBC, normal platelets. So a normocytic to a little macrocytic anemia, which was quite moderate. There was no evidence to suggest the cause like petechiae, ecchymosis, fever, jaundice, or any lymphadenopathy, or any family history of either blood transfusion or a SIP death to suggest a congenital disorder. Now, she came to me because at Hinduja Hospital, and this is what we found: a hemoglobin of 7.3. Again, MC was a little high with a normal WBC, but this time the neutrophil count was a little lower, 25%. It's almost like 1100 ANC, which is a little borderline low. And the platelet also were borderline low at 95,000. And the retic being 0.8, which is, even if you correct it, is much lower. So obviously the marrow was not functioning. The ferritin was normal, LFT, RFT, thyroid function, G6PD, everything was done, which was normal. So we said we must do a bone marrow. So we did a bone marrow aspiration and biopsy. The bone marrow aspiration suggested some megaloblastic changes. The patient never followed up with me, either with the aspiration report or the biopsy report, and actually got admitted into a public hospital because she was not very affording. The biopsy which she had collected was suggestive of myelofibrosis. Now, myelofibrosis in children is very rare, is never primary, is usually following some infection or some such disorder. But there she was admitted in the adult hematology unit, and they started her on steroids for 4 weeks. One day she had polyuria, and then they did the blood sugar, which was 350. So they said, okay, she had diabetes, maybe because of steroid induced. They did the insulin level, which was like almost a little lower than the normal. So normally you won't find that in a steroid induced diabetes. The antibody was also not detected. So which means it was probably not an immune cause. So maybe it was steroid induced, we don't know. So she was treated with insulin and the steroids were tapered and stopped. In spite of tapering and stopping the steroid, the sugars will not return. So that's the time when the patient got frustrated after 1 month and came back to me. So we reviewed. She had consanguinity. She had congenital sensory neural deafness. She had diabetes mellitus, which was not responding by stopping steroid, and she had chronic anemia, which was probably megaloblastic anemia. This was many years back before the NGS was available. So I sent the targeted panel to Dr. Neufeld at Boston Children's Hospital in USA, and what I was suspected, and that's what she says, that Dr. Shah, your patient has what is known as TRMA, or the thiamine responsive megaloblastic anemia. So even then you could do some targeted panel, which is like doing the genetic mutation analysis. So Eureka, it is TRMA. All you need to is give them thiamine. The anemia got corrected. The diabetes disappeared. But what will not correct is the congenital sensory neural deafness, because the hair cells have been damaged in utero and there is no way they can grow again. So the only way you can help the child is by doing a cochlear implant. But while on thiamine, she will remain almost symptomatic free with that cochlear implant. So this was the first test of doing a test beyond normal thinking by doing a mutation analysis. Let's move to the second case. A 5-year-old male born to a child, 5-year-old male born presented with anemia since 1 year of age, and he was treated with hematinics often, as usual people will do, but he would not respond. He was hospitalized 4 times for recurrent respiratory tract infection. So every time it was thought that maybe he has some anemia of infection, on the top some nutritional cause because she's not eating well, so on and so forth. He was diagnosed as iron deficiency anemia, but he had needed transfusion once at 2 years. Now it's very unusual for an iron deficiency to be transfused because most of them are chronic and they are walking up in the clinic even when they have hemoglobin as low as 2 and 3 grams, because really very chronic, and you can treat them with just oral iron supplements. They were from an affluent class, so there was no need for the child to have poor dietary cause of that iron deficiency. And again, child was born of a consanguineous marriage, something very rare in affluent class, at least today in our country. Nonetheless, that is what we keep in mind. His weight was 13 kilo, which was definitely lower for his age. Height was 107, which was in the below 3rd percentile. He was pale. He had just palpable liver and significant spleen, which may be seen in chronic iron deficiency, but unusual for a nutritional anemia to have a 3 centimeter spleen. There was no icterus, petechiae, or any lymphadenopathy. So we did the CBC, which showed hemoglobin of 6.5. MCB is very low, normal WBC differential, and a normal platelet count, and RDW, which is high. Now, if you see only this, I will say, okay, this is typical iron deficiency. I will confirm by a smear, which actually again showed a lot of micro, hypo, aniso, and ovelo. So when you have a micro ovelocytosis, again, you say it's iron deficiency, but we keep in mind that he has not responded to iron in past and in fact had needed a transfusion. We did his general body checkup, all investigation was normal. We did an electrophoresis, said that whether he has associated thalassemia minor, that also normal. Normally, we don't do iron studies in children because iron deficiency is so common, but here, because it was not behaving like a typical, we did the iron study, which showed that actually he has little iron overload, if at all, as the ferritin is high and the transferrin saturation is high. So he's behaving like iron deficiency, but he's not iron deficiency. So this is the table that we have for any microcytic hypochromia, where you have iron deficient anemia, anemia of chronic inflammation, or both together, which is not uncommon, or a thalassemia minor. Now we have ruled all these out except that anemia of chronic infection he can have because he was admitted 4 times for lower respiratory tract infection. So we have a child who's behaving like iron deficiency, but is not iron deficiency, has hepatosplenomegaly, transfusion, and born to a consanguineous marriage. So I would do a bone marrow in such a child and always do an iron stain, because that is the best way to prove iron deficiency if I given a choice of doing one test. So we did the iron and stained for, we did the marrow and we stained for the iron. Of course, the bone marrow was morphologically normal, but on iron staining, it showed that there were more than 30-40% ring sideroblasts. So this was obviously a case of a congenital sideroblastic anemia. Now, when we have this table, we often forget to add that 5th cause of microcytic hypochromic picture, and that is sideroblastic anemia, where you can have low HB, low MCV. Sometimes they may have low serum iron, but most of the time the serum iron may be high if they have been chronically anemic and they have high ferritin, and the only way you pick up is by doing a bone marrow iron stain, which will pick up the ring sideroblasts. Now, this child, then we send the clinical exome, and though it says no pathogenic or likely pathogenic variant found, but they have reported this one mutation, which is his homozygous, which is associated with sideroblastic anemia and a subtle B cell immunodeficiency. So this child had sideroblastic, and you remember he was actually having recurrent admission for lower respiratory infection, probably because he had subtle B cell immunodeficiency. We confirmed by doing a triage, by doing the parent study, which actually showed this mutation there in both the parents. So congenital sideroblastic anemia is usually X-linked, but rarely it can be autosomal recessive, especially this particular mutation is known to be recessive in origin. And again, all you need to do is give them pyridoxine, and 80% will respond. This patient, we put him on 75 milligram of pyridoxine per day, and he never has anemia after that. Liver spleen regressed, growth improved, all the infection disappeared, and now almost 6 or 7 years of follow-up, and the child is completely normal. Third case, a 4-month-old male child presented with fever for which a CBC was done, which actually showed that the hemoglobin is 7 with a normocytic normochromic picture. WBC count was high with high lymphocyte, but again, as you know, an infant below 1 year is always like a lymphoid organ. His platelets were normal. So he had a normocytic normochromic anemia. All anemia workup was done, including a bone marrow, which was normal. He was like thyroid function, creatinine, and you name it, and it was done. He was given symptomatic treatment. Now his fever continued almost daily, needing paracetamol because he would get very irritated when there is fever, and has now started showing failure to thrive. He needed transfusion once in a while, so like 2 or 3 transfusions till the time he came to me. Always the WBC counts was high with normal differential, and sometimes the platelets will dip to almost as low as 70,000, and mind you, the fever continues almost daily. So he was admitted with me. We worked up for PUO, CRP was high, XHS was normal, all cultures done were normal. His viral infections for EBV, parvo, CMV was done, it came as normal. We repeated a bone marrow, which showed some few hemophagocytes, but really not very convincingly saying that it might be HLH. With that fasting triglyceride, which were a little high because 90 would be cut off for such a small child, and a high ferritin. And we also had mildly raised SGPT. So we thought we must keep HLH, mild HLH variety in type. We did a TB workup and a PID panel, the primary immunodeficiency panel, which both came as normal. And we had even done a CT chest and abdomen, which was normal. And the spleen was there. And I'll come back to that. Why am I stressing spleen is there? So we said maybe HLH, let's give him steroids. So we started him on DEXA and the fever disappeared like a magic drug. After 3 months of tapering and stopping DEXA, the fever reappears. And again, a daily fever. Again, you treat, test for all infection, repeated, normal. The ferritin has now jumped to 1400. We did an ultrasound and now the spleen is absent. Now we have a CT scan done at Hinduja before, which shows spleen, and now the spleen is absent, which means he had autosplenectomy. So we did a sickle, and he was sickle trait. So also was the mother. Now I have never seen sickle trait being symptomatic. Sickle cell anemia can go into autosplenectomy, but sickle trait are very unusual to go into autosplenectomy like picture. So we say now we are pushed to the wall. He also had some syndromic face, like they were twins actually. The other twin was completely normal. So we send his next generation sequencing. And what it showed was that it had 2 mutations. One was congenital dyserythropoietic anemia and one was sickle cell, which we know. Now a heterozygous CDA will not present like this, and there was no CDA on the bone marrow done twice. So obviously this is not the reason why he is having all this problem. And you can see he's got that large forehead, large ear, and a flat forehead and a depressed bridge of nose. That was the only syndromic picture we had. So on follow-up, patient has daily fever. Now he's transfusion dependent. So far, what we have, a transfusion dependent anemia child who has undergone autosplenectomy, who is a sickle trait, has an auto-inflammatory like condition with an abnormal facies. So I requested one lab to do his whole genome sequencing because the clinical exam is not picking up. Now, whole genome sequencing when that time was not easily available and it used to cost more than $1 lakh. But through this research lab, I could probably do it free. And also ask them to do the auto-inflammatory panel. So the lab actually sent back the sample to the original lab where I had sent the NGS. And now the original lab says that we are finding a pathogenic variant of hemoxygenase deficiency, or what we call HOX enzyme deficiency. And we do it both in the parents, and the parents are heterozygous. and the child is homozygous. So I asked the lab, I said, I have sent this sample before to you. Now they relook at that, and that time also this mutation was there, but they had ignored it, saying that it was not known in the silico to be cause of any disease. So see how the science evolves, that the same genotype not ascribed to any phenotype, and now after some time we know that may be the cause. Now if you look at the hemooxygenase deficiency, whatever few cases that are there in literature, they were triad of asthenia, autoinflammation, and they have this syndromic phase. Unfortunately, before we could transplant this child, we lost this child because a lot of time was sort of wasted in coming to a diagnosis. So only NGS could prove as to what is happening in this child. So it's an autoinflammatory disorder where there is fever, asplenia. Some of them have hematuria, HUS-like picture, which our patient didn't have. Of course, we have reported this case in one of our pediatric journal in India. Now we switch from anemia to bleeding. There was a 1-year-old male child who presented with prolonged bleeding after he fell and he cut his tongue. He came desperately with hemoglobin of 5 grams. So he had lost a lot of blood. Of course, he had a lot of melina because he swallowed it. We did his bleeding workup. So his PT INR was normal. His APTT was normal. His thrombin time was normal. His fibrinogen is borderline low, 150, and his factor 13 was 105%. Now we don't know the cause of his bleeding. His, of course, platelet count also is normal. He was given transfusion, FFP, local adrenaline pack, and oral tranexamic acid pending this because he was bleeding like a tap from that wound. His bleeding stopped, and fortunately he didn't need stitching for that because we didn't want to dislodge that clot, and he was discharged as query hypofibrinogenemia that we will follow up and do a repeat fibrinogen level sometime. On follow-up, he had skin purpura, which means his problems were not solved. He was investigated again, including repeat fibrinogen level, and now also a platelet function, because that is something which we have not done. And all turned out to be normal, including a von Willebrand factor, because as you know, von Willebrand factor can be low in a lot of people and it may fluctuate. So one time it may be normal, one time it may be abnormal. We did his PS for platelet to see for giant platelets or such thing, it was normal. So now we don't know the cause why he bled that time. We said, okay, we'll follow up. He came after 1 year with epistaxis, not controlled, with nasal packing. So again, he was admitted with me. Again, his bleeding profile was normal. This time I gave him only platelet and without any FFP, and his bleeding stopped. So I knew he has some platelet dysfunction, which is not picked up on the normal platelet function studies, which is the platelet aggregation study. We also do the bleeding time. We look at the peripheral smear and we do clot retraction, and all these tests were normal. So I said, okay, let's send his NGS, and came back the NGS that he has a very peculiar rare type of double mutation in this gene, which actually is known to lead to a platelet type of bleeding disorder 19 if it is either homozygous or a double heterozygous. And we confirmed the same in the parents. He of course had one more mutation, which was of insignificant origin because it suggested an LAD type 3, but he of course did not behave like one. So we did his triage of doing both the parent study, and both the parents also had the same mutation which was there in the child, which was leading to the platelet type bleeding disorder 19. So now we know that he is some rare platelet disorder, functional disorder, and all we need to do is give him platelets when he comes with bleeding and maybe try to control by doing oral tranexamic acid. So if you look at this literature which these laboratories always send you, then these are the rare cases which you can pick up where the patient can be either a homozygous or a compound heterozygous in the mutation in this gene, which leads to anemia, bleeding, epistaxis, and spontaneous hematomas. Okay, one more case of bleeding. 10-year male child presented to me with skin bleeds off and on since 1 month. He had an occasional epistaxis for 2 days. He had no fever, bone pain, weight loss, or a trauma. He was otherwise a well-looking child. His liver was not palpable, spleen was not palpable. He didn't have lymphadenopathy, no bony tenderness. So what we call a well child. So a well 10-year-old child with skin bleed and epistaxis, the commonest thing that will come in mind is an ITP, acquired commonest bleeding disorder in children. His hemoglobin was 9.5, a normal differential and a WBC, and a very low platelet of 18,000. So we did a bone marrow, which was normal, and that's why it's consistent with peripheral distraction like ITP. Okay, let's treat him with steroids because he had epistaxis, because otherwise we will not treat with steroid and just follow up such children. He was started on oral prednisolone. We always give 4 mg per kg for the first 4 days and then taper over next 7 days. So we don't give too much of steroid. There was partial response. The platelet rose to 45,000. The bleeding stopped. So we were happy. Okay, we have treated an ITP, and on the maybe over the 6 months, 1 year time, he will spontaneously recover. He was kept on follow-up. He kept on coming back with platelets counts fluctuating somewhere from 16,000 to up to 80,000, but not bleeding. So we did not do any intervention. Meantime, he developed pallor. His hemoglobin fell to 7 grams. His WBC also fell to 3,500 with a 30% neutrophil. So the ANC around 900 to 1,000. So he's showing now moderate pancytopenia, low hemoglobin, low platelet, and low ANC, and has now developed splenomegaly. And now we are worried whether he's developing some malignancy. So we repeat a marrow, it was normal. So we were relieved that at least we did not misdiagnose a leukemia as ITP. ITP, we did an immature platelet fraction done, which was not high, which is very unlikely to be ITP because ITP usually have a high IPF. I did a direct Coombs test to see whether there is some other immune disorder, which was negative. Now we thought of immunodeficiency, ALS, which all can come with pancytopenia and may initially only behave as ITP, and they may go into then bicytopenia or pancytopenia. So we also did workup for the autoimmune lymphoproliferative syndrome, which you do by doing what we call double negative T cell, between the T cells which are both CD4, CD8 negative. So we did the immunoglobulin profile. It showed some low CD3, but otherwise normal. We ascribed that to the past steroid. We did the double negative T cell. It was little high. We said, is it ALS? But he did not respond to steroid, which was very unusual. Anyway, he was not actively bleeding. So we said, okay, we'll follow up, let the disease evolve. So on follow-up, he would continue to show fluctuating hemoglobin, fluctuating ANC, and sometimes low, sometimes normal platelet. Something is amiss in this child. We send this NGS, and it shows that he has hemizygous for X-linked lymphoproliferative syndrome type 2, not type 1. Type 1 is the one which is dreaded, which comes with an EBV-induced lymphoma, pancytopenia, PUO, and it's an EBV-directed disorder. This was type 2, and we confirmed by doing the mother sample, which also showed the same mutation that the child has. So we proved that this is a pathogenic mutation, which is leading to type 2 XLP. So if you look at this table, then if you see type 2 XLP can come as early as 2 months to 15 years, and they can have an immunodeficiency like picture. They can have pancytopenia, hypogammaglobulinemia, and they have a low platelet, low hemoglobin, low WBC, and low ANC. So they behave like a type 2 XLP. Benign disorder, this child is doing well without any treatment, and over the time his counts have returned to near normal. Okay, which hemolytic anemia are we thinking in this 4-month-old child who came to me with anemia and a gross abdominal distension, and he was quite overweight at that age. He was born to a consanguineous marriage again, so that's something which we will always keep in the back of the mind. Now, mother is a known case of thalassemia trait. This child was 7.5 kilo at 4 months, which is little unusual. 68 centimeter height, which is okay. He was pale. He had 2 centimeter liver and a huge spleen of almost 5 centimeter. There was no abnormal phase. There was no icterus. And this is a CBC. A hypochromic microcytic anemia as MCV 65. WBC and differential are normal for his age, and the platelet count is normal. Now, is he thalassemia major? And that's why he has hepatosplenomegaly and a low hemoglobin with a microcytic hypochromic picture. So obviously we do electrophoresis. HbF is 10%, but mind you, he's a 4-month-old child. So HbF can be up to 10% at that age. We will repeat it after 6 months to be doubly sure. HbA2 is 4.5, which means he is thalassemia trait. He is not probably thalassemia major. Thalassemia trait does not come with anemia and hepatosplenomegaly so early in life. His ferritin was, if at all, low, So he was like an iron deficiency in that, maybe because he had an abnormal weight gain in the first 4 months of life. We confirmed the organomegaly by doing ultrasound, which showed that there is huge splenomegaly. We started him on oral iron, vitamin D, folate, B12 supplement. His hemoglobin improved up to 8.2. His abdominal distension reduced, but the spleen continued to be there, 5 centimeter in size. I thought whether sometime you can have a thalassemia minor presenting a thalassemia intermedia when you have triplication of alpha chain. So it disturbs the balance of the alpha to beta. So I did the alpha chain triplication study, and that was again normal. So that also was not the cause. So I said we must do a bone marrow, but the parents were not very agreeing to do. And I also said maybe we should do a liver biopsy to say whether there is primary portal fibrosis, which is leading to portal hypertension and a splenomegaly. That also they were not agreeing. So I did a sonography and the portal pressure, which was normal. So probably that was ruled out. We did a PID workup and a DNT study. You do a double negative T, always do in a patient with organomegaly and unknown anemias, which was again normal. On follow-up, his distension completely disappeared. His spleen regressed to less than 1 centimeter. He was lost for follow-up for 1 year, and then he came back to me like this, saying that he has got now massive lymphadenopathy all over his in the posterior triangle and the anterior triangle of the neck. So this lymph node would wax and wane according to the parents without any fever. And again, he has low hemoglobin, a normal differential, ESI which is high, and LDH which is borderline high. He said, what are we dealing with? I said, okay, we send his NGS. And there come the NGS, which shows that he is actually homozygous for the gene F-fast ligand, which is very typical in an autoimmune lymphoproliferative syndrome type 1A. He also has beta thalassemia trait, which of course we knew. We do his parent study. Both the parents are heterozygous for the same mutation. So our young fellow has got almost like a congenital or a very early onset autoimmune lymphoproliferative syndrome. So what is this ALPS? Where this double T negative cell, which are CD4, CD8 negative, which are the cell which should now degenerate. They have finished their function. They are old senescent T cell which should die off. They don't die. So they accumulate, leading to organomegaly in the form of splenomegaly, hepatomegaly, and lymphadenopathy. And because these cells are a nuisance in the body, they also lead to autoimmunity. And that's why the patient can come with cytopenia, fever, etc. Usually benign. There are some chance of malignancy later on in the life. All you need to do is give them steroid if they're symptomatic. And once they go into remission, you can put them on sirolimus, which is now the drug of choice. And over 2-3 years, then you can taper and stop and see whether the patient is under control. Okay, next case is a 2-year-old male child presented with skin purpura and epistaxis. So a child with bleeding. No fever, no weight loss, no joint pain, no organomegaly. And again, on a CBC, he shows that probably he has an ITP-like picture because mild anemia, otherwise normal WBC and differential, and a low platelet of 17,000. Suspected ITP. Yes, sir. Yes, sir. I'll finish.
Thank you. Thank you.
Suspected ITP, a bone marrow done, which is normal. He started on steroids. There is no response. Anyway, the bleeding has stopped, so we keep him under follow-up. Now, on follow-up, the skin bleeds have continued. His repeated CBC shows that there is thrombocytopenia with fluctuating HB and ANC. So we admit him for workup. Now, repeat bone marrow shows again an aspiration which is normal. A bone marrow biopsy was done, which showed mild hypocellular marrow. So we said whether he's going into a Fanconi-like picture. We did his chronic viral infection markers, which were all negative. We did Fanconi's workup in the form of stress cytogenetic, which came negative. The same marrow also was sent for MDS cytogenetic, which also came negative. Now, over the follow-up, we treated him with for IVIG, but it did not help. We started him on oral cyclosporine. It did not help. Over the months, his counts kept on deteriorating, and he underwent marrow 2 times. Every time he had more and more hypocellularity than before. So we said, okay, are we dealing with an hypoplastic anemia, which is of a very chronic onset and progressing very gradually? But we were not very convinced that he's not behaving like one. And mind you, again, he was born to a consanguineous marriage. So we sent his NGS. What is the NGS showing? That he has got homozygous mutation in the THPO gene. Now, THPO gene is one which is the thrombopoietin gene, which leads to not only thrombopoiesis but also megalopoiesis and myelopoiesis. So any defect in this THPO gene will come with, is usually an autosomal dominant, can be autosomal recessive, come with pancytopenia. And these children should not undergo transplant because they will do very poorly. All you need to do is to give them mega dose of a thrombopoietin mimetic agent. So this is the parent study which shows the same mutation which was there in the child. So it confirms that he is a THPO gene mutation. All you need to do is to give them weekly romiplastim. We started him on weekly romiplastim, and mind you, we had completely normal count in with 1 or 2 weeks of time, and now he's off all blood support. He has grown well. His CBCs have been last several months almost normal. Now normally you give romiplastim every week. These parents cannot afford, so I tried giving every 2 weeks, every 3 weeks. It works because it keeps the counts within the reasonably normal range, and he is now on follow-up for almost now 2 years and is completely normal. Now, point I want to make, if we had transplanted him without doing this test, he would have done very poorly and he would have not recovered. Maybe he would have died of some toxicity. So, lack of time, I will skip this last case and come to my final concluding remarks. What is not covered by clinical exam? Remember, introns are not covered in a clinical exam. You need to do a not a clinical exam, but a whole exam, which will include intron and extron both. Mitochondrial genes, which are extracellular, like they are there. So most of the genetic disorders covered in the NGS, but the X-linked mitochondrial gene, which are in the not in the gene of the in the nucleus of the child's genes, are not covered, and you may miss. And many of them actually present with a lot of lactic acidosis or succinate acidosis or congenital metabolic disorder, which are maternally derived, and those are not picked up. You have to specially tell them to do that, and they will charge you extra for that. Many labs in past never used to do somatic mutation. So many of these patients of ALPS had not genetic mutation, but somatic mutation. So they were not picked up, and you have to specially request them, and they will probably now. Nowadays, they are doing also somatic mutation. Of course, large deletion, insertions, translocation, NGS is not the best way to do. You can do karyotyping, or you can do some other thing. Copy number variations, again, are not easy to pick up. Gain of function variation are not easy to pick up, which are typically seen in patients with immunodeficiency. And if you know a case, like you say, you are having, say, hemophilia, and you want to know the mutation, don't ask for clinical exam. It's a waste of money. Ask for targeted panel of only that particular gene. Because remember, when you do clinical exam, they may not do 100% of all the genes. But when you take targeted panel, they will penetrate deep and do 100% of the gene in your sequencing when they do the sequencing. So always better do targeted panel if you know what is the diagnosis that you are likely to have. Last case, not genetic disorder. A 10-year-old girl came with recurrent skin purpura for last 6 months without any reason. The father is working in Indian Navy, and the child is alone with the mother. Her CBC was normal, her bleeding profile was normal, her platelet function studies were done, were normal. All screening tests were done at least 3 times before she came to me. Someone gave her oral vitamin C. Nothing was helping the child. This is the way she came to me. She had this funny purpura all over the body. And while I was looking at her, I told the child, I had made up my diagnosis. I tell the child, you just wait outside. I want to talk to your mother. And after speaking, I brought the child back, and she had one more fresh purpura on her arm. I said, mind blowing, this is something great. These are multiple linear purpura, all on accessible areas, on deep penetration of the history. There was a past history of fainting attacks on the road. So the child wanted to sympathy of the mother. She doesn't like the yoga teacher at school, so she doesn't want to do yoga. Friction with the mother on a day-to-day basis. Missed dad, who is away for months because he is in Navy. Teacher was quiet. So what I did was, I told you admit the child, will do quietly a photography and a continuous monitoring, and they refused. So I asked the teacher of that child that you observe. So teacher observed through the window without the child knowing, and she could see that she was pinching herself to bring out a fresh purpura. And then when that was proven to her, the child stopped doing it. of course, we did the counseling of the child and the mother, and then everything happily ended thereafter. So sometimes these difficult cases don't need sequencing. All they need is common sense and a common thinking to say that this was a case of fictitious purpura, and so many tests unnecessarily were done which did not help, and all you need is a good observation and counseling which help the child to recover completely. Well, these are the small bundles of joys. Our patients who come back with drawing, they are so happy. Even when we poke them multiple times, they do all sorts of decorative pieces while in the hospital, spending their time more useful rather than looking at the stupid flat screen on their mobiles. They do these pictures and bring it to you as a gifts. Some of them write nice words for you that they are very happy and thankful to the hospital. One of my patients who was almost on the deathbed with B-cell lymphoma, the brother came and put this on the bed saying that this is my motto, not to give up. And that really gave strength to me also to be more vigorous, and the child survived thereafter. Well, you should do some charity in your life. I'm a founder, trustee of this NGO where we did help for child cancer and women cancer, because I think child and women are the two under privileged part of our society. We are students for life. So we learn from our students, from hospitals where we are attached, from our undergraduate and postgraduate fellows, our young patients. So these are all the young patients who teach us. Every time a patient comes, I'm sure Anjan will agree, we need to open our books and read to understand better and better what we are dealing with. And remember, you can never be successful in life without the help from your parents and from your teachers. And I would dedicate this talk to one of the two greatest teachers that have really trained me. On your left is Dr. Lokeshwar, who is Helen Hardy even today, and I was very fortunate to be his first PG student and to learn hemato-oncology from them. And the next on the right is Dr. Zinat Karimba, who unfortunately died just 2 months back. She was the first board-certified pediatric hemoncologist. She worked at Wadia, and she has literally hand over held and shown us all the cases and make us understand the integrity of pediatric hematology oncology. I will just quote Gandhiji to say that to give pleasure to a single heart by a single act is better than 1,000 heads bowing in prayer. And I think that's so true. You don't go to a temple, doesn't matter, but you help someone on the road, which is going to be helping more than ever. And the best way to find yourself is to lose yourself in the service of the others. And I would say that is the service of the humanity. I thank you very much for your giving me this opportunity and for your patient hearing. Thank you
very much, Dr. Nitin, for the excellent presentation. We'll keep the video and watch 100 times. We are very sorry it is today Friday and we are forced to having COVID time. We have just 5 minutes time for discussion. I know Dr. Anjan and Dr. Mahmoud. Welcome. Just in 5 minutes, please start the discussion. Thank you.
Thank you, sir, for this excellent presentation. And then these were real eye-opening cases. In my experience, like mostly we almost do two NGS versus your whole exome sequencing for my patients every week we have, because most of our cases come as complicated hematology cases and all. Right. Now, recently we had a similar case like you, like the fourth case which had with bleeding. The only thing, this child has been like, they recently came from India with this girl being 11 years with severe menorrhagia and has been treated outside as a ITP. And then they had the sisters too, they were treated in India as ITP. The moment this child came in, the only thing which I saw that it had a large platelet actually. The platelet volume was 12 or 13. And with this, and then some gave steroids and then there was no increment in this platelet count. So the very large volume of these platelets gave us an idea that it is not an ITP. And then I went ahead to do a whole exome sequencing. Although what happens is that sometimes you know that this is a problem. Either it is a giant platelet syndrome like a MYH9 or a Bernard-Soliers one and all, but then you do a one panel and then it takes about 2-3 weeks to come. So we just go with a whole exome and within 3 weeks we had an answer that it is a Bernard-Soliers syndrome. Correct. So the management becomes totally different in this.
Absolutely.
So,
So I think a good peripheral smear is not a substitute for NGS. It has to be
good
done
peripheral
first.
smear is there. But then if there is a large volume, mean platelet volume can even be in a ITP, but there are so many other disorders which can actually pick up. So for us, whole exon has been, this new generation technique has been a boon for us because we have lots of complicated hematology cases, and we generally use in our malignancy cases too, like if we have a myeloid neoplasm, like an AML, JMML and all, this is very handy to pick up these rare mutations.
Right.
Now, just to give an example, I don't know whether many of them are aware about acute myeloid leukemias and all, but the basic thing now is a FLT mutation which needs to be picked up actually. Now, generally what they do is that they do a FISH for the FLT3 mutation, and then it has a particular exon where it is picked. Now, the thing is that when you do a cytogenetics, it did not pick up the FLT mutation, but when we did an NGS panel for the myeloid NGS panel, it picked up because it was on the other exon area which was there. So these are some of the cases which helps us actually. So as you said that many of these cases, even a plain iron deficiency anemia can have a different mutation which can actually picked up by a whole exon. But the clinical history, even if you order a whole exome or a whole genome which is there, you need to give a the best history and a probable diagnosis for us to pick up actually.
Absolutely.
Mahmoud, can you give your comments also?
Actually,
in the beginning.
it's a very interesting presentation. And if you look, as Dr. Nathan mentioned, I mean, these are common presentation for the pediatrician actually. Anemia, probably iron deficiency, bleeding, thrombocytopenia, but at the end, when we are stuck, really the whole exome is helping us. We had also many similar cases, which at the end only the genetic study which showed what is the underlying thing. For example, I had one which was all the time iron deficiency, all the time, but he's not responding. We thought, no, probably we are dealing with something else, which tend to be iron refractory, iron deficiency anemia, which you can pick it only on the genetic studies. Same thing, for example, we had one who had all the time bleeding, nasally bleeding. We thought probably it is a platelet dysfunction, which is unidentified. Then when you do the other investigation, actually it tend to be not. It tend to be hereditary hemorrhagic telangiectasia ectasia. Management is absolutely different. And I agree that whenever we are stuck somewhere, although it is the presentation is common, and you did all the job, then the genetic study is really helpful.
But one
just a word of caution that it's a very dangerous.
Definitely.
It's a dangerous tool to play with. If you don't know what you're asking for, you can be more trouble than hell sometimes. So nowadays, a fashion. A lot of people, general pediatricians, physicians are doing NGS at a drop of a hat. I think that also should not happen. So while you do it when you are pushed to the wall, but try to apply your common sense and common investigation first, because 9 out of 10 times you are able to crack it without the NGS.
Yeah, you are absolutely right, because whenever you are asking for this, sometimes you are getting something which was not expected, and it is not explaining the condition actually. Then you are moved somewhere else.
Right.
Yeah, 1 minute, but in the last minute, one comment, if you give any one of you, because we have to go to the next section.
Yeah, Anjan wanted to say something. Yeah, Kalpana, sorry.
No, I was just thinking the cases that you presented, definitely they were the rare cases that you come across.
Right.
And obviously, like you said, pushed against the wall, you think of this and you do it as a last resort. So maybe in the future, the correct timing of asking for this would, be important, because invariably they will go through so many investigations and then you will come up. And obviously there are so many genetic diseases or disorders still left to be diagnosed, and what are their implications. So the correct timing for every future.
So Kalpana, today immunology is so advanced, and the number of PIDs which are picked up every year new are so many that almost is believed that there is a genetic cause for every disease.
Absolutely.
There's an outbreak of meningococcemia. Why only 10 people died and 20 got and remaining 100 didn't get? There's a genetic cause behind. Like that, why did you develop severe flu? Why did you develop severe COVID? There is a genetic cause for everything. So I'm sure in the next 50 years, the whole paradigm of looking at a disease is going to change. Maybe you are born and they will do an NGS and then they'll tell you this is the way you will live, this is what you eat, this is how you're going to die.
Also, for example, in your fourth case,
allows me, we will have a soon webinar on hematology panel. We will ask you and a genetist, no really. Because
You have Anjan with you. You can do it with him every day. He is my boss.
No, boarding topic, only a panel with genetics and discuss. So I'm very sorry today.
No, no
really,
problem.
we had some problem in the connections also. We end here. I'd like to request the viewers the questions we will send to the Dr. Nitin and answers will be sent. I would like to thank Dr. Nitin, Dr. Anjan, Dr. Mahmood. I'm very sorry there was interruption today.
I don't know why it was there.
No problem. No problem.
We will have a complete session on hematology and we'll request you to join us in that. We discussed it. Thank you very much, all of you. Now we go to the next session. It is pediatric dermatology. In that, we have a great speaker, Dr. Ashraf Reza. Our chairperson is Dr. Rafia Overa, Senior Specialist Pediatrician at Prime Clinic Jumeirah. She's member of the Executive Committee. She's branch manager there also. Welcome, Dr. Rafia, and I would like to request you to introduce the moderator of the session, Dr. Fatima, please.
Welcome. Thank you very much, Dr. Sohrab, and congratulations for the very successful, as usual, conference, Dubai Pediatric Club. And it's my honor to be one of the members in Dubai Pediatric Club. And today, now our session is pediatric dermatology, and we will introduce Dr. Fatima Al-Breki. Dr. Fatima is consultant dermatologist, chief of dermatology division in Tuam Hospital, Al Ain, UAE. Dr. Fatima, you are welcome to our session.
Thank you, Dr. Rafia. Thank you for the invitation. I'm very happy to be between you this morning, and I'm enjoying all the lectures so far. So let us start our session, pediatric dermatology, and we have an eminent speaker, Dr. Ashraf Reza, who is a very close friend and colleague to me. Dr. Ashraf Reza is a consultant dermatologist at MediClinic WellCare Hospital, adjunct clinical associate professor at MBRU in Dubai. He is a great speaker in a lot of national and international conferences, and he is going to take us through a journey in pediatric papillosquamous disorders. So Dr. Ashraf Reza, you can start your presentation. Thank you.
Good morning, everyone. It's a great pleasure for me to participate in Dubai Pediatric Club Conference. And over the next half an hour, I will be talking about selected pediatric papillosquamous disorders. So this slide you see now on the screen has a collection of some papillosquamous disorders. All of these disorders have in common the presence of erythematous papilloplaques, as you can see here, and they are erythematous and they are covered by scales. Looking at these pictures, you find that there is great overlap. Maybe you can identify one or two photos and you can know the diagnosis, but there is a quite overlap between these diseases. And it's very important to differentiate these diseases from one another to come with a specific diagnosis, because they are different in etiology, different in prognosis, and most importantly, different in the management. So in this presentation, I will discuss selected pediatric papillosquamous disorders. I will discuss psoriasis as the prototype of this group of diseases. Then I will highlight some of the important differential diagnoses that can be seen in the pediatric practice. I will try to make it as simple, as practical as possible. I will not go through the details of the etiopathogenesis, just the clinical aspect of this disorder. So let's start with psoriasis. Psoriasis, as we all know, is a skin disorder, the classic example of papillosquamous disorders. However, we do not consider psoriasis as skin diseases anymore. Psoriasis is a systemic inflammatory disease, and it can affect the nail, it can affect the joints with psoriatic arthritis, and it can also have a variety of comorbidities like hypertension, diabetes, obesity, and others. So it is not only skin disorders, and when we treat severe cases, we have to keep this in mind. Pediatric psoriasis is not rare, although I'm sure that in pediatric practice, you might think that we don't see that much of cases. It is 0.5 to 1% prevalence, which is quite high percentage. The reason why you do not acknowledge this percentage, because many cases are undiagnosed or misdiagnosed with other common or more common dermatologic disorders, as we will see. So if we look at the classic presentation of psoriasis, then we can see that this picture is very typical. You see there are papules, there are plaques. One of the important features of psoriasis is that the lesions are very well defined, as you see here. You can easily identify the border, even you can draw a line clearly between the normal and the diseased skin. The color of the lesion is erythematous, lightly erythematous. We call it salmon pink in color, and it is covered by silvery white scale. The lesion can affect anybody, and it can affect...
1 minute.
It can affect any part of the body from head to toe. The classic one here you can see on the trunk, the typical well-defined lesions. It can affect the scalp, one of the common location. Also, involvement of the knees and elbows, very characteristic location, and the hand and feet. When psoriasis affect infants below the age of 2 years, we call it infantile psoriasis. The most common location here at this age is the face and the scalp, and you can see that the typical lesions with the salmon pink color and silvery white scales here also on the face. When the scales are not very evident, like this part here, it can be easily missed as atopic dermatitis, which is more common disease, but still the color is different and the well definition of the lesion differentiates psoriasis from eczema. A common location with infantile psoriasis is the involvement of the napkin area. These cases are usually misdiagnosed as erythema napkin dermatitis or candidal dermatitis. The main reason for missing the diagnosis here is that psoriasis in this location lack the characteristic features of psoriasis. The color is not salmon pink. You can see here in this slide, in this photo on the right side, it is more deep red, more inflamed, and this is because of the friction of the lesion in this location. Also, you don't see scales because humidity in this area masks the scale. So we need to differentiate it from erythema contact dermatitis by urine or stool. And in order to differentiate, just look at the skin fold in this area. Try to open the skin fold. If you find the skin, the deeper part of the skin fold is spared, then this is erythema dermatitis. If it is involved, then you have to include psoriasis in the differential diagnosis. Of course, finding psoriasis in other parts of the body will help making the diagnosis in this case. Childhood psoriasis from the age of 2 years onward and during adolescence, this is the typical chronic plaque psoriasis, erythematous scaly plaques. It can affect the nail. It can be mild pitting of the nails, or it can be severe total dystrophy of the nails, as you see here. This is a subtype of psoriasis. We call it gutted psoriasis. I just put here on the left side the chronic plaque psoriasis to be differentiated side by side. This gutted psoriasis has the typical features of psoriasis, the salmon pink, well-defined lesions covered with silvery white scales. The main difference is that the lesion here actually is monomorphic. It is not variable size like what you see on the left side. It more or less like 0.5 centimeter to 1 or 1.5 centimeter, all have the same appearance, usually appear on trunk and the proximal extremities. Gutted psoriasis usually follow upper respiratory tract infection or sometimes urinary tract infection by about 2 weeks. patients here has to be investigated to see if there is streptococcal sore throat, and the treatment will be accordingly to this finding. We can treat the patient with antibiotic to eradicate the streptococcal infection with a very good prognosis. A clue to the diagnosis of pediatric psoriasis is to find this kind of linear lesions. This is caused by what we call Koebner phenomena. Koebner phenomena is normal skin, which due to scratching or injury, the patient, when healing occur with psoriasis. This is not exclusive for psoriasis, but it can help with the diagnosis. Another bedside test that you can easily do in your clinic is Auspitz signs. You can see here those very thick scales covering the psoriatic lesions, even masking the erythematous patch. And if you get a glass slides from your clinic and start simply scratching these heavy scales, it will be removed layer after layer until you get this pinpoint bleeding, which is characteristic for psoriasis. So that's a very easy test you do in your clinic to differentiate between eczema and the other conditions. The management of psoriasis will depend on the age of the patient, will depend on the extent, location, and severity of psoriasis itself. Usually, milder cases are treated by topical treatment, and this can be done in the pediatric clinic. The moderate severe cases needs a specialist or consultant dermatologist, and we use ultraviolet light or systemic treatment. We have different topical treatment options. I will just briefly go through them. Topical corticosteroids is the first line treatment. It is the mainstay for treatment of psoriasis. They are effective. In pediatric age group, we usually use only the low to medium potency topical corticosteroids. There is no place for ultra potent steroid like clobetasol or dermovate. So low potency like hydrocortisone, mid potency like mometazone or fluticasone. Side effects can occur, although not common, but one of the important side effects is hypopigmentation, and this can occur around the lesion itself. If a patient apply the steroid beyond the lesion itself, the surrounding skin may get hypopigmentation. That's why we always advise the patient to limit the application of the topical steroid to the lesion itself. Also, after healing of the lesion, there might be some hypopigmentations. Atrophy can occur, but we avoid this by using the low to mid potency steroid. Stopping steroid abruptly can lead to rebound of psoriasis. So psoriasis will come back very quickly and can be even worse than it were before the treatment with topical corticosteroids. That's why we always advise patients not to stop the treatment once healing or recovery occurs. We advise for proactive treatment. We reduce the frequency of application from once daily or twice daily application into twice weekly application of the topical corticosteroids, and the patient can maintain this twice weekly application even on healed skin, and this can be maintained for a longer period of time, several weeks or even months. We do not apply topical corticosteroids over large surface area of the body, say more than 20 or 30% of the body surface area, to avoid the hypothalamic pituitary adrenal suppression. Topical calcineurin inhibitors, we all know them. We have pimecrolimus and tacrolimus, and they are licensed for atopic dermatitis, not psoriasis. In psoriasis, we use them as off-label indication, and we use them specifically on face, genitalia, and intertriginous area. We do not use topical calcineurin inhibitors on other parts of the body because they are not effective, but they are effective in this location where we call it thin skin. It's very important to use topical calcineurin inhibitors in this location to avoid the use of topical corticosteroid, which can lead to atrophy of the skin. Usually, topical calcineurin inhibitors are very well tolerated. Some patients may complain of burning or stinging sensations. Usually, this is temporary, usually in the first week of use, and we advise the patient to continue use the treatment. Topical vitamin D has been used as a monotherapy for many years, calcipotriene, calcipotriol, or calcitriols. But these days, in most markets, not all, but most markets, you find it a fixed combination, topical vitamin D and the betamethasone dipropionate. The FDA approved this fixed combination from the age of 12 years and older. In the Gulf region, it is approved from the age of 18 years. So you have to follow your local guidelines. We do not apply this fixed combination on the face, genitalia, and intertriginous area. Again, this area, the preferred treatment is topical calcineurin inhibitors. We do not apply this product over large surface area of the body because it can lead to hypervitaminosis D and hypercalcemia. Emollients are not a specific treatment for psoriasis, of course. However, we can use them as monotherapy in infants if they are not suffering from itching, because at this age group, we don't like to use topical corticosteroids. In adults or children, we use emollients as adjuvant treatment with other topical treatment because they reduce the need for topical corticosteroids. So the more emollients the patient is using, the less amount they will use with the topical steroid. Topical salicylic acid is indicated in patients with very thick lesions like the one I'm showing in the photo. If a patient with a very thick lesion like this one apply any preparation, topical steroid or topical vitamin D, the treatment will not go through, will not be absorbed. So we need to remove these scales and we use the topical salicylic acid. However, we do not use it in infants, and in preschool age, we limit the concentration to 0.5%. Also, limit the extent of use of this medication because of a risk of systemic absorption and salicylism. Moderate to severe cases are usually treated by specialists or consultant dermatologists. We use ultraviolet light for moderate to severe cases. Narrowband UVB is the standard treatment these days, 2 to 3 sessions per week, usually well tolerated, erythema, burning, pruritus, and blistering. There is no specific age of use, but usually we don't use it below the age of 5 years, although there are some data from the age of 3 months. Severe cases may require systemic treatment. In the past, we used conventional systemic treatments, methotrexate, cyclosporin, retinoids. They are effective. However, because of the risk of severe side effect or black box warning, many dermatologists are not prescribing these medications, and many parents actually refuse to use these medications. Nowadays, with the availability of biologic and systemic treatments, we have quite few of them, as you can see here in the list. They are approved from the early ages, from the age of 4 or 6 years. And if the patient has a good insurance or the patient can afford the very high price tag of these medications, we put them as a first-line systemic treatment. So now I'm done with the psoriasis, and I'm going to go through some of the differential diagnosis. You have now 2 pictures side by side. You can easily say they belong to the same patients, but different location. This one on the left, a picture of the back, and this one from the leg. However, they are actually 2 different conditions. This is a guttate psoriasis, and this is another condition called pityriasis lichenoides chronica. This condition, pityriasis lichenoides chronica, is not very common, but it is more common in younger adult and children, and we don't know the exact cause. There are some theories like viral infection reactions or lymphoproliferative T-cell disorders, but the exact cause is not known. Again, this is side by side. The one on the left is the guttate psoriasis, and this is pityriasis lichenoides chronica. We can differentiate the 2 conditions on a clinical background by looking to the color of the lesion itself. On the left side, the guttate psoriasis, it is pink color, salmon pink color, while here it is more reddish brown color. The scale on the left side is silvery white scale, easily removed as flakes, while here it is very thin layer of scale that can be peeled off easily. We call it mica-like scales, which is a mineral that have very thin layer that can be peeled off. So on clinical ground, we can differentiate them, although sometimes we need skin biopsy, which show a very characteristic pictures under the microscope. Pityriasis lichenosis chronica can persist for months or years. It is not harmful, but usually most patients require treatment. We start with topical steroid or topical tacrolimus, but most cases actually require systemic treatment, tetracycline, erythromycin, or azathioprine, which has to be used for 2 to 3 months. Of course, tetracycline cannot be used below the age of 8 years. Some cases also may require narrowband UVB. Another condition that may mimic psoriasis, the one on the left, of course, is a typical chronic plaque psoriasis affecting the knees, while the other conditions have some well-defined lesions, erythematous with some scaling on top. This condition is pityriasis rubra pilaris. It's not common conditions, but can get into the differential diagnosis of psoriasis or papillosquamous disorders. There are many subtypes. I'm not going to go through the details of these subtypes. In general, the name is self-explanatory. Pityriasis means scales, rubra means red color, and pilaris means hair follicle. So this disease have a common features of follicular hyperkeratotic papules and palmoplantar keratoderma. You can see here, this is erythematous papules around the hair follicle, which has follicular plugging. The color here is actually orange-red. In dermatology, we do not say erythematous usually. Usually, we put another qualifying color. So we say salmon pink color, we say reddish-brown color, like pityriasis lichenosis chronica, and here we call it reddish-orange color. Also, the hand has a yellowish hue. If you can see here, there is keratoderma, thickening of the palms, with a yellowish hue. So all cases of pityriasis rubra pilaris has this feature. In addition, the patient has extensive erythematous scaly patches over the body with one characteristic lesion. You can see here this erythema everywhere, but in the middle of this erythema, there are areas of sparing, area of normal skin, which are characteristic for pityriasis rubra pilaris. This is another variety we call the circumscribed variant of pityriasis rubra pilaris, well-defined lesions on elbows and knees, in addition to the thickening of the skin on the hands and feet. Pityriasis rubra pilaris is a chronic problem. It may persist for years, but it's only skin disease. There is no systemic involvement. Because of the negative impact on the quality of life of patients, most patients will require treatment. Gradually, some patients may get spontaneous resolutions. The main treatment is involved is emollients, keratolytic agents, topical corticosteroids, which can be helpful in mild cases, but severe cases will require systemic treatment. We use systemic treatment like oral retinoid or methotrexates. Again, the main problem is the potential for side effects. And nowadays, we can use also biologic treatment that are effective in psoriasis, like the interleukin-17 inhibitors or ustekinumab. Another conditions which can mimic psoriasis, especially when the lesion is limited to the scalp. You can see here, the one on the left is psoriasis with its characteristic silvery white.
Doctor, please, 5 minutes. 5 minutes
Okay.
left.
Sure. With the psoriasis, silvery white scale, and this is, you can see, yellowish, greasy, adherent crust. So this is the main differentiation. Seborrheic dermatitis occur in the first year of life due to transplacental transfer of the maternal hormones. Then it disappears by itself. Then it reappears during adolescent phase. So this is a biphasic age distribution. The exact etiology is not known, but malassezia, which is lipid-dependent yeast, is thought to play an important role, either by productions of lipases and oxygen species, reactive oxygen species, which leads to irritation of the skin, or due to host immune reaction to the fungus itself. That's why we can use antifungal products to treat seborrheic dermatitis. This is the characteristic yellowish, greasy, adherent scales affecting the seborrheic area, the face, the scalp mainly. The treatment is either topical corticosteroids or topical antifungals. The last condition I'm discussing is also seen here on the right side. This is the guttate psoriasis I showed earlier, and this is again another condition that may look like guttate psoriasis, which is pityriasis rosea. If you look closely here, most of the lesion has oval appearance, not rounded. And the long axis of the oval appearance run parallel to the ribs. This is what we call Christmas tree pattern. You can appreciate this pattern if you step back 2 or 3 steps and you look at the patient from a distance. If you come very close, you will not be able to appreciate this linear pattern that you can see here. It starts with one lesion, which may mimic tinea corporis, but within a week or so, more widespread lesions appear with central scaling, and then the scale open up to become a collarette of scale at the periphery. Pityriasis rosea is a self-limited disease, so we don't need to treat the patient. Usually it takes 1 to 2 months to disappear completely without leaving a trace. Sometimes if there is itching or too much redness, we use topical corticosteroids or oral antihistamine. To summarize the presentation, papilloscomas disorders have an overlapping features of erythema covered by scales. Differentiation on clinical ground is possible. Psoriasis has a characteristic very well defined salmon pink color with silvery white scales. Infantile psoriasis can affect napkin area, which has to be differentiated from irritant dermatitis or candidal dermatitis. Just to look at the skin fold. Pityriasis rubra pilaris has follicular orange-red papules, thickened with yellow hue hand, palms and soles, and erythematous scaly patches on the body with areas of sparing. Pityriasis lichenoides chronica has reddish-brown macules or papules with very thin layer of scales. Seborrheic dermatitis have greasy, adherent yellowish crustaceans. Pityriasis rosea has oval-shaped erythematous papules covered with a collarette of scales in a Christmas tree pattern. I'm not going to discuss the management. It's always important to make the diagnosis. Once you know the diagnosis, then the management will be easy. You can open any textbook, you can go to the internet, but just you need to get a very specific diagnosis. And with this, I would like to thank all of you for your attention.
Thank you, Dr. Ashraf Radha, for the great, interesting talk. I'm always enjoying your talks. Let us look if we have any questions from the attendees. I can't see any question right now, but can I ask you about the most common comorbidities associated with psoriasis that you see it in children?
The most common comorbidities and the most important is one that is linked really to psoriasis, which is juvenile psoriatic arthritis. It has some overlapping pathogenesis with psoriasis. So this is actually, we consider it as a part of the disease, and it can occur between 10 to 20% of the patients. Other than arthritis, I see in the clinic, and many studies have shown that kids with psoriasis are more obese, more hypertension, and even more diabetes.
Nice. Dr. Rafia, you have any question?
If you allow me, Doctor, what is the normal course of psoriasis in these children? Do they go on to have psoriasis in the adult phase as well, or can it be controlled? What is the normal progress?
Some patients have the psoriasis for some years and then it stops. Some of them continue without psoriasis, but some of them relapse after 10 years or 20 years. So when psoriasis is a chronic problem, when the patient has no psoriasis at the time, we cannot say the patient is cured. They can get psoriasis, and we see patients coming in adulthood and they say that we had psoriasis when we were kids, but for 10, 15 years we didn't have psoriasis, then it comes again. Of course, some cases have psoriasis from childhood and it continues ongoing through adulthood without any remission. So it is variable, but some patients do really have remissions.
And what is the psychosomatic link? In adults, there's a lot of stress-related exacerbations. Is it the same for children?
Yes, this is one of the exacerbating factors. And whenever we treat these kind of conditions, we inquire from the patient and from the patient and the parents if there are any stressful situations, whether at home or at school or bullying, that may exacerbate the problem.
Go ahead, Dr.
Sorry, I have one question. Thank you, Dr. Ashraf, for the very nice presentation. I want to ask about the genetic, about the psoriasis. What is the genetic advice I will give to the parents if they have one of their kids have psoriasis?
Of course, psoriasis has a genetic background, and there is a possibility if one parent has psoriasis or if both parents have psoriasis. So there is a percentage, but it is not a must. We don't really scare patients. We tell them or parents that all your kids will have psoriasis. We very rarely see a sibling having psoriasis. We do see that, of course, but it is not very common. So we reassure them that the likelihood of having psoriasis in another siblings is not extremely high.
Dr. Ashraf Rida, we have a question from Dr. Zainab Imara here about the psoriasis and the risk for type 1 diabetes.
I am not sure that we can consider psoriasis as an independent risk factor for diabetes. It can be one of the comorbidities, as I mentioned, but to consider it as a risk factor, I'm not aware of such a strong link.
Yeah. I have another question, Dr. Ashraf Rida, about with the big revolution now in the field of psoriasis. Now we have a lot of advanced biological treatment available for the children, as you already mentioned in your presentation. So if you can just make the pediatrician aware about the safety and the efficacy of those biologicals in very few words, if you can.
Okay, fine. The use of biologic treatment in psoriasis and in the pediatric age group is now almost like 7 to 8 years, and several biological are available with I'm not going to go through the details, but with the newer biological agents which are approved from the age of 4 years or 6 years, the safety profile is very favorable. Of course, we compare with the other conventional systemic treatment, methotrexate or cyclosporin. There is no doubt that those biological treatments are quite safe, and most parents are willing to give this medication to their kids. However, these are an immunosuppressant medications, and the patient has to be monitored throughout the treatment. And even before treatment, we do some tests to exclude latent TB or hepatitis. But overall, the safety profile is quite good.
Yeah, and I'm actually running a big pediatric psoriasis clinic in Tawam Hospital, and I see a lot of pediatric cases with psoriasis, who are most of them, because we are a tertiary hospital, so the difficult cases come to us. So most of those patients are in biological treatment now and for some time, and you can see how effective is this medication and how much this medication changed the life of the parents and the children. So we always encourage you as pediatrician, if you see such cases and you are unable to help those patients, to refer them to us. But if you can tell us, Dr. Ashraf Rida, when the pediatrician should refer the psoriasis patient to us?
Okay, first of all, milder cases, of course, if the diagnosis is, settled, sure, then the pediatrician can start treating the patient if the case is mild case. If the case does not respond to the treatment the pediatrician is using, or if the case is moderate to severe, or if there is doubt, is it psoriasis, is it eczema, is it pityriasis lichenosis chronica, then they should refer the case at least at the beginning. And if it is proved to be psoriasis mild, then they can continue the treatment with the topical steroids.
Wonderful. And we have a question here from Dr. Nuha Ashraf. What about diet, lifestyle, and improvement of psoriasis?
Okay, this is a very big topic about diet. If we look at evidence-based data, so there is no really very strong data linking any food. Although if you go to the internet, you will find too many claims of many food items that can help with psoriasis. Medically, there is no specific food that can make psoriasis worse or that can really make it better. Although we hear patients saying that I stopped eating meat completely and my psoriasis gets better. This can be individual experience. I cannot deny it, of course, but as a physician, I cannot recommend it to every patient we see.
Good. We have another question from Dr. Sumaya about the relationship between psoriasis and anemia.
Not very sure that there is a link, unless Dr. Fatma, you have another opinion.
Yeah. And we have a question from Dr. Abdulaziz. Please, I ask about any herbal therapy in psoriasis.
See, alternative medicine is something that we don't study much, and the data are not enough to recommend it for patients. Of course, patients who are desperate for treatment, when they use steroid and they don't get better, they start to using other alternative treatment, but there is no, again, evidence-based data to use herbal treatment.
Yes.
5 minutes only left, doctor. 5 minutes left.
I just want to take this chance while we are in this pediatric gathering and to ask you, Dr. Ashraf Rida, about the steroid phobia, because we also encounter these things with the pediatrician, the steroid phobia, not only the families, but also some of the doctors who deal with our patients. So if you can just give us some comment on this.
Okay, this is very important question, because we see patients not using steroid, they are afraid, and we see even physicians are afraid to write corticosteroids. In general, topical corticosteroids are very safe if not abused. So if we give good instruction to the patient, we choose the right strength of the steroids, the right location to use which steroid at which location, and we specify the duration of the treatment, and then we follow up with the patient. These days we have the proactive treatment. We use it twice weekly, which has proven to be very safe. If we really follow all this step, we don't see those pictures that you see, like with the stria distensi, atrophy, thing like this. It is quite safe if used properly.
Good. Any question? I can't see any question from the audience, but maybe we can end up with this question. Your approach to family and the child who suffer from psoriasis psychologically? How do you approach them?
Okay, that's important part of the consultation at the beginning, because some parents are not really aware of the impact of the disease on the psychological aspect or the psychological well-being of their child. So sometimes the child has very severe psoriasis and the parents are saying, no, we need only topical treatment or no treatment is required. We explain to them the psychological impact. Many patients with this psoriasis, especially if it is moderate to severe, have depression, have an anxiety, even some they might have suicidal ideations. And we explain to them that it's very important, especially during school age, to have a clear skin so the child can really engage with his peers, having sport activities, not to be away from them. So we explain this and most of them start to appreciate the significance of this aspect and they go for really effective treatment, whatever we offer them.
Thank you very much. The topic is so interesting, exciting. We have prayer during the Friday, really. Now I'd like to request Dr. Rafia to give the vote of thanks. Dr. Rafia.
Thank you very much. Thank you very much, Dr. Ashraf Rida, for the very nice presentation. Thank you very much, Dr. Fatima Aplik, for this very nice discussing with about the important questions that you speak about it. And we will move to the other session. Thank you very much. And you are always welcome to Dubai Pediatric Club.
I would like to request Dr. Diari to introduce the chairperson of the next session, please.
Thank you. Good morning, everybody. Thank you, Dr. Ashraf and Dr. Fatma, for this nice talk. I am glad again to introduce Dr. Amir Tulaiman, which is senior pediatrician in Emirate Hospital Clinics, to chair the next session in emergency pediatrics. Dr. Amir, please.
Thank you, Dr. Diari. I am pleasure to be one of this event. Okay, my sound is here.
Yes,
yes. Okay, go ahead, Dr. Amir.
Okay, it's my pleasure to introduce Dr. Imran Khan in the fourth session of this event, which will be about the pediatric emergency. Dr. Imran Khan is head of emergency service, pediatric emergency and point of care ultrasound at Al Jalila Hospital in Dubai. He is also adjunct clinical assistant professor of Mohammed bin Rashid University, Dubai, UAE. Dr. Imran, the floor is yours.
Thank you very much. Sorry, can you hear me?
We can hear you, but there is a lot of.
I think you have joined by two systems.
Okay, is it better now? Yeah.
Yes. Go ahead.
Okay. Thank you very much for your introduction. This is a great opportunity to be a moderator for this session. So I'm just going to, without wasting time, going to introduce our speaker today, who's going to talk about the common pediatric emergency in the office pediatrics. So we have a speaker, Dr. Mahir Sarkar, who is associate professor. He's also a head of pediatric intensive care unit at Medical College, Kolkata, from West Bengal. So it's a great honor to have him as a speaker, and he's going to talk about the common pediatric emergencies in office pediatrics. So I will let him start the session, please.
Thank you, Dr. Imran, for this nice introduction. For the onset, I want to thank Dr. Saurabh and Dr. Kalpana for giving me the opportunity to present in front of this August gathering. So is my slides are visible?
Yes,
visible. Yeah.
Okay. Yeah. So thank you. So all of you know who works in the pediatric emergencies know the pediatric emergency is an ocean. So there is no end and there are many aspects. So that's why I prefer to talk on this common pediatric emergencies in the office practice, because the primary care pediatrician do see the emergency cases, and the parents are often bring the life-threatening children with the life-threatening situation to the primary care pediatricians because they have a long trust in them. So our point of discussion of today's talk will be on how we can recognize the emergency in the busy OPD, and we can do the triaging in the OPD, and how we can prepare ourselves to deal with the emergency. Then we have some case discussions on pediatric emergencies and how we can learn, because in the busy OPD we can do some errors, and how we can learn from the errors. And I will display some videos, and I've taken the permission from the parents of these children. So if you look at the background, you can see that one of the studies in the USA that shows that the pediatrician sees at least the 24 emergencies per year, and at least 2/3 of the pediatricians sees one emergency per week. But the contrary is that only 16% initiated the resuscitation at the office practice. So that indicates that we are not prepared enough to deal with the emergency in our office practice. So if we look at the ultimate conundrum and the spectrum, that are some children will be very sick and they require the immediate attention and resuscitation. We can identify them very quickly, but there will be some children with vague and non-specific symptoms, and these are the potential source that the error that we can make in the busy OPD. And some children will be looks normal but is not, like a patient with the poisoning with the paracetamol, or that iron poisoning, or patient have blunt abdominal trauma. Just in the initial phase, they may not have any such symptoms, but they can develop over the next few hours. So we have to keep in mind that. And some children will be normal, like the patients coming from the vaccination or the well baby clinic. So triaging is very important. So the patients who needs the emergency, have emergency signs, requires the immediate attention and resuscitation. And the children with the priority signs needs to come in to the doctors very early, and they need admission or some observation at least. And some non-urgent patients, like I already told, the patients with the requiring the vaccination or the well baby just routine checkup. So how can we identify the emergency? The age-old PALS guideline says that whenever the patient is coming to the emergency from the doorstep, without touching the patient, just seeing the patient, you have to assess this pediatric assessment triangle, or the PAT triangle, which has the appearance. We have to assess the work of breathing and the color of the circulation of the skin. So in appearance, you have to just notice if the patient is conscious or unconscious. If the patient is conscious, is this irritable, drowsy, or totally limp? In work of breathing, we have to assess if the patient is breathing at all, and if the breathing, then there is any added sound or distress, or there is some obstruction. And in the circulation, the color of the skin, you have to see that the patient has pallor, the mottling, or the cyanosis. On that basis, you can categorize the patient. If the patient has shock, the patient has circulatory insufficiency and abnormal appearance. And in patient with respiratory distress, will have only this respiratory problem, but with respiratory failure, patient also have this heart function will be depressed, and the appearance will be also deranged. And if all three parts of the sides of the triangle is abnormal, then patient is cardiopulmonary failure and required immediate cardiopulmonary resuscitation. So WHO has given us these 7 emergency signs that we have to identify very quickly in the emergency, and these patients require resuscitation, like obstructed or absent breathing, severe respiratory distress, the patient with signs of dehydration and severe dehydration in case of diarrhea, patient with severe shock, central cyanosis, convulsion, and coma. These patients require emergency resuscitation. And after primary assessment triangle, then we have to go for this primary assessment pentagon, that is popularly known as PALS, that A, B, C, D, E. What does A indicate? A indicates the airway. That means that the airway, you have to look and listen if the airway is clear, or it is maintainable, or is not maintainable. Is there any sounds like hoarseness, cough, stridor, or snoring, or gargling sound? And in the breathing, you have to assess the work of breathing of the patient, severity of respiratory distress, and oxygenation status of the patient. In circulation, we have to check the circulatory status, and blood pressure sometimes very difficult to check in the emergency and in the OPD practice, because the child has become irritable and sick. It takes some time, but without checking, because the blood pressure is the last sign that is to drop after the inpatient with circulatory insufficiency. So before that, we'll get the abnormalities of all other signs. Then disability, you have to look at the GCS or AVPU score. You have to look for the pupillary response to light, and the patient have posturing or convulsion. And in the exposure, if there is a history of trauma, burn, poisoning, then a bite, that you have to assess. So if we look at these videos here, this patient having this patient, you can see have respiratory distress along with the grunting, and the patient is an aorta sensorium. The patient have respiratory failure. And if you look at this here, the patient here have stridor with the patient is aorta sensorium. This patient have respiratory failure and patient have upper airway obstruction. But if you can see here, in this video, this patient have severe sternal retraction, but there is no tachypnea. This patient have laryngomalacia, patient have severe obstruction during the inspiration, but the patient don't have any signs of respiratory distress. So we have to assess in the emergency what the category of the respiratory distress patient is coming from and what type of treatment the patient is requiring. So in circulation in the busy OPD, just touching the hand of the patient, you can assess these 5 signs. We call it 5-in-1 maneuver magic touch, or CCTVR, that you have to touch the hand of the patient and you can look for the color, CRT, temperature, peripheral temperature, pulse volume and pulse rate, and you can assess the circulatory status of the patient. And mind it, during the checking the capillary refill time, you have to place the hand and the nail pad to the just above the heart of the level of the patient. And what are the priority signs? These are this mnemonic. You can remember the 3T, P, R, and MOB. That is, if the patient is tiny infant, small infant, less than 2 months, high grade temperature, 104 degrees Fahrenheit, patient have trauma or urgent surgical conditions. And for P, patient have severe pallor or history of poisoning and severe excruciating pain. And the patient is respiratory distress, restless, or patient have rash, especially hemorrhagic, like in patient in dengue or the meningococcemia, and the patient with malnutrition, edema of the feet, and the burns. These are the patients have priority signs, so they should jump the queue and should come your clinic urgently, and your assistant, the front desk staff should know it and they should send you directly. So these patients should jump to the queue and come to your clinic directly if they have these priority signs. So now we'll go to some case scenarios. Like this patient is a very common scenario. So we give the vaccination in our clinic. So 9-month-old 8 kg came to the MMR vaccination, and it is sitting in your clinic. And after 30 minutes, later the patient has become irritable, had noisy breathing, stridor, and the erythematous elevated skin lesions. So these are the skin lesions appear. So what do you think? Is this an emergency? And what can you do in your clinic? So from here, you can see that the patient have developed anaphylaxis, has this urticaria like rash, and patient has airway obstruction, patient has developed stridor. So this is an emergency and you have to manage it, because if you send the patient to any emergency department, or it will take some time, you have to manage the patient immediately. So algorithm is that you have to provide some oxygen to the patient. You have to lie down the patient, because due to anaphylactic shock, the patient may have circulatory insufficiency, go to syncope and arrest if your patient is the standing position, and you have to immediately give the adrenaline intramuscular injection. And if the patient have the complete airway obstruction, you have to open the airway and do the back mask ventilation. If the patient have partial obstruction, then you have to go for nebulized adrenaline, and you have to repeat the adrenaline again, the second dose. So you can see this condition is creating a crisis in the clinic, and you know that you cannot handle this situation in a single-handedly. You need help, and you need some equipments and medication that you should be prepared for. So this is the dose of adrenaline for anaphylaxis. This is, you can put this chart in your OPD so that you have a ready reference. You don't have to calculate that. And if the EpiPen is available, then it is great. Then you can directly put it, inject it. But you have to check the expiry date and how, if you're not, don't have the EpiPen, then duration of stability of the diluted adrenaline, you have to check for, it should not be kept more than 7 days. And if it is undiluted, the check for expiry date. So this questions this arises from this case scenario is that are our non-medical trained staffs are trained to handle this emergency? Do we have necessary equipment and medications needed to manage this infant, and are they readily available? And who will call the emergency number during such situation? So we have to be prepare our staff. We have to have develop a written response plan. We have to pre-assign the role of the resuscitation team, then train the receptionist and front desk staffs to how to identify the sick child and how effectively call the emergency medical service. And it requires some training like BLS and running the mock scenarios again and again to reinforce it. And this is very important. Again, we need some equipments for maintaining the airway, providing the breathing support, circulatory support, and eliminating the convulsion and some other drugs. So I'm not going to the details, but American Academy of Pediatrics gives a list of this equipment that should be in your OPD. And the minimum drugs that you can keep is the albuterol, epinephrine, 25% dextrose, corticosteroid, atropine, midazolam, and there's a spray or lorazepam and sterile water. So your nurse staff and users should be, where are the medications are they diluted, what are the expiry date, and you have to check if the stock is available or not. So that is very important. So you have to be prepared. So regarding the identification, stabilization of the patient, regarding the equipments and drugs. So unaware is okay, under-resourced is okay, but under-prepared is not at all okay. So if we look at this child have this 3-month-old having cough, cold, coryza, and now having breathlessness for 1 day. And you can see the child type of breathlessness this child have. Child have subcostal, intercostal retraction and the tachypnea. So diagnosis is bronchiolitis. So what do you do in your emergency with this child? So because the patient with the bronchiolitis, the problem arises with the patient if there's a moderate group, because in the mild group usually requires the home care or some, but in the severe group, we have to admit the child. But in the moderate group, we are sometimes confused whether to admit the child, how to monitor the child, and what therapy should we give. So this moderate group of patient, with the patient having the saturation 90 to 92% in the room here, and moderate chest wall retraction or nasal flaring or decreased feeding, that you have to better to admit the patient, monitor the child for a few hours, see the response. If the child is improving, that you can discharge, otherwise admit the child. And what are the therapies that work in bronchiolitis? Yes, this systematic review of the 32 guidelines, mind it is the review of guidelines, says that all the supportive treatments are recommended by the guidelines, like the oxygen, CPAP or HFNC treatment, airway clearance, and the hydration and nutrition and prevention of the nosocomial infection. But if you look at this nebulization therapy, only these 8 studies recommend the hypertonic salines, and regarding the bronchodilators and nebulized epinephrine, very few studies are recommending. And if you look at the recommendation against, most of the studies recommend against the routine use of these nebulized medications. So moving to another common case scenario in the here. So this is 18-month-old, 11 kg came for DPT booster. The next day fever started 102 degrees Fahrenheit and patient started throwing convulsion. Then it persisted for 5 minutes in the home, and after that it became drowsy, didn't regain the consciousness. Now when the patient parents brought the child to your clinic, again the generalized motor seizure started. So now this question is, will you call it a status epilepticus? So what are the priority and management of this patient, and what are the options do you have to control seizure in this patient in your clinic? Because mind it is in your clinic, it is not the hospital emergency. And the parents started blaming that you are the responsible for this crisis because you have given this vaccine. That's why the patient have this convulsion and emergency. So you have to have a crisis situation. So you have to handle it. You have to talk to the parents. You have to both. You have to secure the airway breathing of the patient, circulation of this patient. I have to control the convulsion, and you have to counsel the parents. So you have to do the multitasking. So management of the status epilepticus, always you have to maintain this airway breathing and circulation. Check the blood glucose. If it is less than 60, you have to give the bolus of 10% dextrose as 5 ml per kg. And if facilities available, check the electrolytes. And in the OPD setting or clinic setting, what we can do, it is highlighted in this box. We have the options of IM midazolam. If it is available, dose is higher, it is 0.2 mg per kg, or readily available the intranasal or the buccal midazolam spray. You can apply and you can just stabilize the patient and send the patient and transport the patient safely to the emergency department. Now the case 4 says the child is non-asthmatic, came to you with the 11 a.m. And difficulty in breathing and speaking in the single words. He was well till 6 a.m. when he woke up, though he was coughing since the middle of the night. Previous history of PICU admission with the similar episode and required intubation. The patient have severe distress, subcostal intercostal retraction, and the saturation is somewhat maintained with the 8 liter per minute oxygen. So you all know the management of the status asthmaticus. I'm not going to the details, but the question is the emergency, the clinic physician, the OPD. So you have to know that our patients worsens very rapidly within few hours. So does this have any importance? And what are the red flag signs which would suggest be aware and act fast and have to rapidly refer this patient to our emergency department? So this asthma acute exacerbation can have 2 types. This is type 1, that is gradual deterioration over 1 day or 2 days, and type 2, that is the acute asthma that's got rapid onset asthma, have severe bronchospasm. So in this group of patients, if we don't administer the appropriate medication and therapy immediately, then the patient can go to a cardiac arrest, may need intubation. We do not want to in patient in acute severe asthma. So act fast in this patient because this patient can deteriorate very rapidly. And red flag signs, yes, these patients have some red flag signs, like the first is that requiring intubation and mechanical ventilation. In this is one of the red flag signs that this patient have. If the patient required hospitalization within last 1 year and patient requires systemic corticosteroid, or patient have some psychological disorder, non-compliance, or the air pollution, family history, then these are the red flag sign. As a primary care physician, we have to keep in mind. So another common scenario, this fall from bed is very common. So 15-month-old child cried for 15 minutes, then vomited 2 times. Frontal bruising is there. There is transient loss of consciousness for 5 seconds. Now the GCS is 15/15 at your clinic. So this question is, should we go admit the child or should we go for the CT scan of the child? And this guideline says, this current guideline for the pediatric head CT rule, that this defines the children below 2 years and younger and above 2 years. If the children have the altered mental sensorium or GCS less than 15 or the signs of skull fracture, then you have to go for immediate CT scan and admit the patient. If they don't have these things, then you have to go take the other history, then history of loss of consciousness in children 2 years or older, or history of vomiting, severe headache, or severe mechanism like this, like the patient having the road traffic accident or some heavy object falling on the head, then you have to go for the urgent CT. And younger children, if the patient have loss of consciousness more than 5 seconds, non-frontal hematoma or not acting normally or severe mechanism, then you have to go for CT scan. Then another scenario, this adolescent girl came to the history of ingestion of several tablets of paracetamol, and with the mother, she is anxious and nauseated in your emergency, has tenderness in the right upper quadrant of the abdomen, thus hemodynamically stable. Then what should we do? So what should I ask is the dose, toxic dose, that is the 150 mg per kg, but you have to keep in mind that the stated dose and timing is often unreliable. So if the child has taken several tablets, take it as a toxic dose. And then what should I do? If the child has came to you within 1 to 2 hours, have taken the sustained release preparation or enteric-coated preparation, then you can go for activated charcoal ingestion. And if it is coming beyond that time, there is no role of that, then you have to send child start the N-acetylcysteine, have to admit the child, you have to do the blood paracetamol level, liver function test, and you have to start the N-acetylcysteine infusion. Next, another scenario, there's the 2-year-old child brought to you with the intake of dishwasher detergent, some around, and there are something at us in the mouth, and the patient is asymptomatic and physical examination is normal, including the oropharynx. Now the question is, what are you going to do? If the child is asymptomatic totally, should you give the reassurance to the parents and send the child to the home, or give the gastric lavage, or what? Because the caustic and the acid, this clinical scenario, there may not be any injury in the oral mucosa, there or maybe the little burn, but the inside the esophagus or stomach may be burnt out. So we have to admit the child. Then you have to give the minded that do not give any lavage, do not give any activated charcoal. You can give some dilution with the water or the milk at the initial, but you have to immediately send the patient to the gastroenterologist for the, if needs some endoscopy to examination and NG tube administration. So what is the difference
only
between
5 minutes? 5 minutes, please.
Okay, thank you. So this is the acid burn and the alkali burn. The acid burns usually cause the stomach injury. You can get the gas under the diaphragm, and alkali burn is because the esophageal injury. You can see the pneumothorax in this patient. So that's why this need does urgent endoscopy within the 24 hours. If it is delayed, then you cannot do endoscopy and needs the nasogastric tube insertion. Steroid route is controversial. Antibiotic is needed if there is some complication like pneumonitis or the perforation. Another common scenario is the child is a 2-year-old child present with the ED with a complaint of something in the nose. You and your assistant tried to, but not able to remove the foreign body, and recommend the child to visit the specialist in next few days. But when they went to the otolaryngologist, the radiography obtained, and you can see this picture. What is seen in the picture is a round metallic foreign body, but here you can see there is a nice rim in this foreign body. So this is a button battery. So button battery is you can to differentiate it from the coin. It is the coin don't have any rim, and thus inside lateral view it will be straight, but in the lateral view in the button battery it will have a ridge. So, but this patient requires complicated course and perforation nasal septum and require extensive surgery, because the whatever minuscule charge may be there in the button battery can erode the tissue within 2 hours and cause the dangerous situation. So button battery is dangerous. So we sometimes miss the children feels in appealing to put it in the mouth and ingest it, and it can produce a lot of complications like and life-threatening situations. The next scenario that sometimes we miss in the ED, the child have pain, come to the 10-year-old child from while returning from the school, have severe pain abdomen, and it is persisted for 12 hours. There's nausea, but no vomiting. There was a right lower quadrant pain, but there's no concerning when you examine the child. Now, advice for home support, but it didn't relieve. And now the child has came to the emergency on thorough examination. His testicular examination revealed his swollen and tender testicles. So this is the testicular torsion that can be missed in the busy OPD, and you can see the testis is totally necrosed and it is lost. So we can miss testicular torsion may present like only pain abdomen, and studies have shown that it may be missed in the emergency, and delayed diagnosis can lead to the catastrophic result. So next case, there's the 9-month-old extremely irritable child having the diarrhea and vomiting for 2 days, and has low stool and vomiting, and diagnosed as gastroenteritis, and stated as if the home management style didn't improve, went to the emergency department for the not improvement, and there the parent shows this picture. So what is this? You can see this is a red currant jelly-like stool. So diagnosis is confirmed is intussusception. So this blood in the stool can be intussusception. It has acute presentation. If it is repeated presentation, it may be Meckel's or it may be the duplication cyst. So if the intussusception, if its diagnosis is delayed, then it can we can miss the whole length of gut if it is necrosed and delayed. So you have to be very cautious in emergency, and you can do this a point of care ultrasound. You can find this target sign or the pseudokidney sign. This is the kidney and this is the intussuscepted part, the pseudokidney sign. Now, last two patients, these patients have the influenza-like illness and improving 5-year-old. Now on day 4, having severe pain and few episodes of vomiting. Pain is not localized. Now child went to the emergency and there was ultrasound was done for pain abdomen, and there was some probe tenderness in the right iliac fossa, and the probable appendicitis was suspected and planned for OT. But the parents did not admitted the child because they didn't believe the child may have the appendicitis, but they didn't relieve. And after a few times the child deteriorated, and when they went to the emergency again, then the child, we can see then examination, thorough examination, the child have only the bradycardia, the blood pressure is low, and ECG shows. How can you recognize the ECG? So this is the complete heart block. So the child needed intubation, temporary spacing, IV immunoglobulin, then the normal rhythm regained after the 72 hours. So learning points is that the cardiac dysfunction and circulatory insufficiency may present like pain abdomen. Invest some time for examining an irritable child. It will pay you back, and check the pulse rate for full 1 minute. The last patient is the 5-year-old patients having the infant is having the history of lethargy, poor feeding, and having some fever and cough and cold, and child have tachycardic. It is heart rate is 240. Even sometimes in this emergency and irritable child, we can miss this tachycardia also. So invest some time on this irritable child. The child has become mortal and thready pulse and cold extremities. The lung fields have crackled and liver is enlarged. That is, the child have cardiopulmonary insufficiencies and the left heart failure. And this ECG shows this. So you can recognize this is the narrow complex tachycardia without absent of P wave, and there is no other variability. So this is the patient have supraventricular tachycardia. If the child is coming to your emergency, then what you can do, the child is unstable, you have to rapidly send the patient with the emergency with doing the vagal maneuver. In between, you can do the, if the child is stable, then you can do the vagal maneuver whenever you, in the time period when you can send the child to the emergency. So in vagal maneuver, you can do the, older children can do the Valsalva maneuver, or you can put the ice pack over the forehead, not on the eyes. Never do the bilateral carotid massage, and do not waste time with the Valsalva maneuver or the vagal maneuver if the patient is unstable. So we have to, in the emergency, you have to administer the adenosine very rapidly. You have to put the IV cannula near to heart. You have to take this 2 syringe technique, push 10 ml of NS rapidly after pushing the adenosine to reach the heart rapidly at dose is 0.1 mg per kg. So in summary, the consequence of being underprepared are serious, and initial treatment provides in the office may mean the difference between the life and death, and appropriate stabilization and timely transfer to an appropriate facility is of paramount importance. Thank you.
Dr. Amir? Yeah, Dr. Imran, please.
Yeah, thank you very much, Dr. Mahir. This is very useful information, actually, and I quite like the emphasis that you have put on the office pediatrics, because it's one of the areas where there is a lot of hesitations and myths about the pediatric emergency. So I'm going to have a couple of questions to discuss. I think I'm waiting if there are any questions from the other participants. My first question to you is about the role of, you talked about the triage, and I think the effective triage is extremely important in any pediatric office or in pediatric emergency. You give a very good example of the pediatric assessment triangle, the PAT. do you have any comments or experience about triage versus streaming, which is an emerging concept nowadays in the pediatric emergencies or in pediatric offices? How do you feel that can actually help to identify these kids, actually, especially in a busy offices or emergency departments?
Yes, thank you, Dr. Imran. So it's a very important question, because now the concept of streaming is coming again. In a busy OPD or in a hospital, or maybe in the OPD or in the emergency or any situation, that streaming is like if it is crowded, if it is totally crowded, then the dividing the patients, whatever the care according to the need or the care they require. Suppose in the emergency department, the child whenever coming, that first you have to do the trials to identify who require the resuscitation emergency and who require minor care and who require the priority observation. So according to after that, you can do streaming, like some patient with injury just requiring a stitching or a small dressing, so they can directly go to your dressing area. Some patient require observation, so they can go to the observation area. Some patient requires monitoring, so they can go to the HDU. So this is called after triaging, you can go to the streaming. And also in the OPD, so some patients like requiring the rheumatology care, like the dermatology care, like the cardiology care. So according to that, you can divide this crowd and you can reduce this crowding there in the OPD.
Thank you very much. That's very useful. I think that's a very good point, that streaming actually it's a visual assessment, and then you try not to waste more time actually to do a full assessment. And actually, if you can identify the children who needs probably an urgent attention, then they should be identified and actually isolated and then be given the attention. So thank you very much. I have a question from Dr. Zainab. She has asking why IV immunoglobulin is given for suspected appendicitis after diagnosis of heart block. I'm not sure she's asking about this case. Or...
Yes, so I think that appendicitis diagnosis was done because it was a wrong diagnosis, because the patient is irritable and the patient was at some probe tenderness. That's why the primary care physician's diagnosis could be appendicitis. But the learning point is that the patient with this myocarditis ultimately going to the heart block due to the cardiac insufficiency, the patient have severe pain abdomen. So that was the case. So the immunoglobulin was given for this myocarditis, not for the appendicitis. Appendicitis was a error that we can do in the busy emergency if we do not invest some time in a child who is very irritable.
Thank you very much. I hope that answers the question. I also have a question from Dr. Jamal, that after surgery for interception, when you start feeding the child and when you tell the mother to start a normal diet at home.
So this will be the answer by the surgeons. I am not a surgeon. So, so after I think this could start after 48 hours. I don't know exactly.
I think Dr. Diari can answer this question much better. Actually, I guess that if as a pediatric surgeon. Okay. All right. So I think, and as a pediatric emergency, if the kids have air enema reduction, which is fortunately one of the common mode of treatment, and not a significant amount of children require the surgery. So if they have a reduction of interception by air enema, actually it's pretty quick. And after that, we can actually start the fluid straight away after the procedure, or when they're feeling better. If it is a procedure was straightforward without much complications, then we encourage them to start. And there are some trials actually happening in the hospitals where there has been a trial of observing with a short period of time for up to 6 hours after the air reduction enema. And if the children are taking orally, feeling comfortable, they can be discharged with a safety net, because unfortunately there's a small incidence of reoccurrence of interception in these children. So that is something we just have to be mindful. But for the surgery, I guess the surgeons can answer that better. I think it depends on the individual cases, how significant it has been the necrosis. Yes. Or and that will actually dictate to you how soon you will establish the enteral feeding and stabilizing the child. That's great. I think when we're talking about the focus, so Dr. Meir, you talked about the point of care ultrasound, which is obviously one of my specialty and my interest. So Tell us what you think about how useful the point-of-care ultrasound in diagnosis of interception, and how quickly something which can be learned. Obviously, we're talking about the office pediatrician. Is it something they can acquire the skill and can practice in the day-to-day practice? If you have an experience on that as well.
Yes, so for office pediatrician, I think it is difficult because sometimes it is the availability of the equipment and expertise. But for the emergency physician, I think it is must. For emergency and ICUs, the point of care ultrasound is one of the, now people are instead of stethoscope, they're using the ultrasound probe in the emergency and ICUs to identify the cardiac, just having the idea of the myocardial function, having any pulmonary lung ultrasound for pulmonary pathology. You can do this EFAST technique in a past patient with the trauma. So if there is some blood, the collection in the abdomen, and in case of intussusception test, you have told that if the patient have with the Stargardt sign and the pseudo kidney sign that it can be shown in the emergency, then we can immediately identify the patient and triage the patient and call the help of the surgeons to immediately intervene. So there are a lot of roles in the point of care ultrasound in every system, from the cardiovascular to respiratory to GI system, for renal systems, and now is coming. So it is the emerging, and it will be helpful for at least the management, triaging, and detecting the severity of the patient.
Okay, thank you, Dr. Sarkar, for your excellent, informative presentation. I have two questions from the audience. One of them about the adjunct treatment in bronchiolitis.
Yes, so the bronchiolitis, as I have shown this, the systematic review of the 32 guidelines is basically the supportive, give the oxygen if it is required, or other respiratory support like HFNC or the CPAP. If the patient has severe distress, give the patient proper hydration and nutrition and clearing of the airway. That is the most of the things required. But other therapies, like the patient requiring the nebulization adjunct therapy, like epinephrine or the bronchodilator or hypertonic saline, we are still not in a consensus, because the most of the guidelines, out of these 32 guidelines, the 8 guidelines says that we can use the hypertonic saline, and others says for other therapies like the nebulization and with the epinephrine or the albuterol, they do not recommend, and most of the says recommend against. But as an individual practitioner, if we look at the individual patient who are in front of you in the emergency, and then my practice is that we can give a trial of the hypertonic saline or the epinephrine. If the patient is improving or showing some improvement, tolerating it, then we can continue for a short period. Whenever the distress or the retraction or the oxygen requirement is decreasing, then we can immediately stop that. So this is how we practice, but the guideline and therapy is the only hypertonic salines is the recommended by the few guidelines, but the others are not still recommended. And also the antivirals and the other antibiotic steroids are not recommended.
Okay, the second question is, what is the biggest challenge in batteries diagnosis in children?
Yes, so this is a very good question. So the button battery, you can see that it is often mistakes, and the children finds is very applicable, they are very fond of this because it is a very glistening and the small object. They put it in the mouth and sometimes ingest, and then it is sometimes not noticed by the parents what has been ingested by the child. So, and if it is not identified earlier, then it can do the catastrophic effect that I have shown, that it can do all the perforation of the esophagus and even the erode the vessel. Even it can erode the airway if it is going to the airway and the nasal septum, the case that I have shown. So the minuscule electric charge that the button battery are sufficient to erode the tissue. So that is the biggest challenge, that we sometimes miss it, and missing it can lead to catastrophic effect.
Thank you. I think this is a very good point about the challenges with the button battery. We recently did an awareness campaign from Jalila in Dubai as well. I think looking at the data, the button battery ingestion is majority of the cases are unwitnessed. So this is obviously this is another challenge, as you mentioned, about differentiating between the coin and a button battery. But even though they are unwitnessed. So the physicians, including the pediatricians and emergency physicians, should have a high index of suspicion. The second, obviously, we again come across the cases like you mentioned about a foreign body in the nose. Actually, we had a recent case, and unfortunately, the information a lot of time has been held back by the nannies, the carer, or the siblings, with the obvious fears that they will get into trouble. And this is extremely vital, that what exactly it is. And obviously, if someone has witnessed, they need to be reassured that they need to come up with the with information so that the right treatment can be provided. As you rightly mentioned, there's a huge difference in diagnosing a button battery or there any other foreign body in the nose. You probably can give a couple of days, and if with a specialized assessment. But a button battery is a time ticking bomb, unfortunately, where you really have to intervene quite urgently. So that's a very good point. I think we have some more questions. Oh no, I think.
Dr. Since it's Friday and prayer time, we can take one or two more questions.
Sure.
Dr. Kalpana, if you have, please.
Thank you, Doctor. Very nice presentation on individual cases. I have a general question on fluid therapy in ER. Couple of comments I would like both from Dr. Sarkar and Dr. Imran. Do we have to be cautious? There was a study sometime back linking giving excess fluids to increase mortality, especially from Africa, but your comments on that.
Yes, so you are right, madam. So this is the first trial that changed our idea of giving this bolus in the emergency. The study, initially this PALS guideline and the surviving septic shock guidelines is to say that we have to feel it, the patient is shocked, give the bolus 20 ml per kg, then reassess, then again 20 ml per kg and up to 60 ml. But this first trial has shown the African child, but there are some controversies that the child was anemic and malnourished. So this child, after giving the bolus, a high amount of bolus, more than 30 ml per kg, so there's reversely they have the higher mortality than who child who's didn't get bolus, just usual fluid management. So this that we have to take it a pinch of salt in our day-to-day practice, because we have to assess it. If the child you are suspecting the child have some myocardial dysfunction, if the patient is extremely tachycardic, or the patient have a palpable liver which is tender, has gallop rhythm, then outright from the beginning we can restrict the fluid. But if the patient does not show the signs of the myocardial dysfunction, then start the fluid and meticulously monitor in the bedside. If the patient is becoming more tachypneic or tachycardia is increasing, or the liver size is increasing. And also the Dr. Imran was talking about the role of the point of care ultrasound here is very important to assess the cardiac function, the lung ultrasound to list the interstitial edema, and also the IVC collapsibility if it is the patient is fluid deficient or not. So that is becoming important in emergency, how we can assess both clinically and with the point of care ultrasound and can do the judgment in this patient.
So the consensus still would be that it has to be individualized. We cannot take it as a gospel truth and stop following the case-to-case basis.
I think it's a very good point that based on the common consensus and the practices, actually the fluids has been underutilized in the emergency department than overutilized. So I think some of these papers have put a lot of reservation for the physicians, and we come across situations where the kids are severely dehydrated, and even the physicians are very reluctant, and sometimes they're giving 10 mils per kg bolus. So I think the important point is the reassessments, and the reassessments are extremely important, which is obviously starting from head to bottom after one fluid bolus. And again, the POCUS role is extremely useful. Since we obviously got the POCUS in the practice, actually, we feel extremely comfortable and confident. Then it's a very simple to learn, looking at the myocardium, looking at the IVC, and looking at the child in general, and actually feel like, no, actually we are safe to proceed. Because a lot of time, the common issue we have is actually we're not giving them enough fluid rather than overfluid.
So in your experience, doctor, how many hours of or how many sessions of training is required to be good at this? Because that would be important.
So actually, that's a very good point. I'm not going to much time on that. The POCUS actually has been becoming extremely useful modality. There are multiple studies actually shown that some of the applications are pretty easy to acquire. actually, I'm currently, we're actually finishing a trial where actually we're showing teaching a lung ultrasound to the nursing assistants, in some of the developing countries to diagnose pneumonia. And so far the results has been pretty satisfactory. And there are a couple of studies actually shown the focus skills acquired by the medical students, and it are also shown. So I think it's all depends about, the important step is about getting into learning the skill, but then looking into the pathologies. I think the biggest challenge is that, for example, you get one interception maybe in 2 months' time in your ED. So it's a matter of like someone who should be feeling confident, he probably should have seen more than 20. And that's what we use to consider in some of the criteria. I mean, there are different parameters where you can look for the competencies. And then keeping the skills with somehow either using some of these CPDs to trying to get refreshing their knowledge as well. Coming about the focus for interception, there's a recent study published from Korea where they look at about over 500 children, and the sensitivity and specificity by pediatric emergency physicians were nearly 100%. So, and that was just based on after a brief period of training and teaching. Obviously, they had an opportunity to show them quite a lot of pathologies and cases, either by videos and then showing them the hands-on practice. So it's a regarding the next question, Dr. Mahir mentioned about the cost of the equipment. So people need to know that there are a lot of handheld devices now available in the market. I think they're probably going to be heading towards Asia. They're already up in the Europe and North America, where you can have less than $2,000 probe you can attach to your iPhones and Android phones, and actually you can do the scanning, and then actually one probe can cover all the frequencies. So I would say that in the next 5 years, there's going to be a time that if you can't avoid, like a stethoscope, I think you have to get used to the probes and ultrasounds as well.
Yes, we are also using this point of care ultrasound in our emergency and ICU. Now we have just completed one research on this point of care ultrasound versus the clinically guided fluid resuscitation in septic shock. So in the process of publication now. So our residents, with some amount of training and identifying the pathology and regular retraining, they will be comfortable with doing that, and their assessment is pretty good after some training sessions.
Thank you.
Can we conclude? Because we want to go and ask questions, but the prayer time is there. We have to stop. On behalf of all, I'd like to thank Dr. Sarkar for an excellent presentation, Dr. Imran for moderating the session, Dr. Amir for chairing the session. I thought Dr. Amir has gone for prayer, so I took Dr. Kalpana, our secretary. I would like to thank all viewers, 600, they are staying still listening to us on Friday. I would like to thank all our viewers, and I would like to request the viewers, we will start 1:15 again. We have 2 panels, very important, vaccines and immunization with experts, Dr. Nitin Shah, Dr. Krishnamurthy, Dr. Fatma Ulama, and we have Kawasaki MIC panel, very famous panelists, Dr. Hassan, Dr. Parveen, Dr. Asrar, and
Dr. Walid.
Dr. Walid.
And
So
Dr.
I call
Devadatta.
him the Kawasaki of Dubai, So they are there, Dr. Kalpana and Dr. Diari. They will be moderating the session with Dr. Joshi. Please join us. It will be very exciting panel, question, answer. Thank you very much. Once again, see you afternoon, inshallah.
Thank you.
Thank you.
Thank you.
Good afternoon. Welcome to the post-lunch session. So, Dr. Saurabh, if you can come over and take over the session.
Thank you very much, Mr. Tawfiq. First of all, I would like to thank Mr. Tawfiq for sponsoring this wonderful webinar. This is the 7th consecutive year that he is sponsoring. I would like to welcome all viewers once again to our afternoon session. In afternoon session, we have 2 panels. First panel is vaccine panel and second is MISC Kawasaki panel. Eminent panelists are there, well known, not only UAE, in India, Indian subcontinent, and all over the world. We have eminent chairperson and moderators. Our first session moderators are Dr. Kalpana Sengupta, Senior Specialist Pediatrician, Head of Department of Pediatrics at NMC Specialty Hospital, Dubai. She is Secretary of the club, and I would like to thank her for, spending a lot of time for this conference. Dr. Rajendra Joshi, our past president, Senior Specialist Pediatrician, or say Consultant Pediatrician at Prime Hospital, very well-known Begaram personality in UAE. They are the moderators of the session. In a short while, they'll be introducing the panelists who do not need introduction. They are our speakers. Over to Dr. Kalpana, please start the session.
Thank you, Dr. Saurabh. Dr. Joshi, you can start by inviting the first 2 panelists. I think you have to unmute yourself, Dr. Joshi.
I don't see Dr. Nitin and Dr. Fatima on the panel. I think Dr. Krishnamurthy is there, so you can introduce him first, and I will introduce Dr. Nitin when he's visible.
Okay.
Dr.
Krishnamurthy needs no introduction. He was with us till recently in Dubai. He is the ex-consultant pediatrician at Al Jalila Hospital, and he was an adjunct professor at MBRU. And he is the one we all go to for expert advice whenever we are stuck with cases. So thank you very much for your cooperation always, Dr. Krishnamurthy.
Thank you.
I think I see Dr. Ghassan and Dr. Waleed have joined in this session. They are for the next session.
This session, of course, I would like to bring to attention of the viewers, Dr. Nitin Shah. He doesn't need an introduction, although he's a professor of pediatric hematology oncology, but he's an expert in vaccine, and especially the new Dr. Nitin also has joined us. Okay, the Dr. Joshi, please welcome Dr. Nitin.
Hi.
Yes, Dr. Joshi will introduce you. No?
Yeah, good afternoon. It gives me a great pleasure to reintroduce Dr. Nitin Shah, because he has taken the oration in the morning and everybody knows him very well. He's a professor and consultant of pediatrics and pediatric hemato-oncology at Wadia Hospital and also at Hinduja Hospital. On a personal note, both of us belong to Bombay University, same batch. And if he remembers, both of us shared the same marriage anniversary. Next week. And the other, and the other panelist is Dr. Fatima. I don't see her. She is the consultant pediatrician and head of the child health section at Dubai Health Authority. She will be throwing some light on the local scenario about the vaccines and immunization. So we'll start the discussion with Dr.
Dr. Joshi, just one small line.
Yeah.
Dr. Fatima is also adjunct professor at the Dubai Medical University, Dubai. Sorry, I just added this.
Thank you.
Thank you,
Dr. Saurabh.
Oh, Dr. Fatima has joined.
Thank you so much. Really, from morning, I did not leave the PC because very, very excellent topics, or moderator, panelists, really. We have to give a good prize to Dr. Saurabh because really he's making us updated in all knowledge, Dr. Kaplan, all of your team.
Thank you.
So thank you for inviting me.
Eminent panelists and speakers that we are proud, really. Thank you.
Okay, we'll start with the first common question, starting from BCG and then polio. The question is about the BCG. What is the efficacy of the present BCG vaccine? What are the controversies, and is there any research going on in the BCG vaccine? Maybe Dr. Krishnamurthy can start.
Thank you, Dr. Joshi. Regarding BCG vaccine, I would say that this is one of the oldest vaccines, and unfortunately is one of the vaccines that has run into major controversy. The controversy arose as a result of a study that was conducted in Chingalpet in Tamil Nadu, where they said that the vaccine efficacy was in single digits. And unfortunately, that was not a study that was well conducted. That is what research has shown subsequently. Research all over the world about BCG vaccine has shown that BCG is certainly effective against higher forms of tuberculosis, particularly miliary tuberculosis, tuberculous meningitis, and all that. And the efficacy runs close to about 80%. So TB being a treatable disease, if you get it even after vaccination, you don't have to worry about that. But if you get disseminated TB, then that is the time that you may not be able to do anything about it. So for that reason, BCG still holds the test of time, and it is something that needs to be administered. That is the first part of my answer. The second part is BCG conventionally is given in different parts of the world at different ages. And this is essentially because the World Health Organization has divided the world into different zones based on the endemicity of tuberculosis. India, UAE, and most of the South Asian countries fall under high endemicity areas. So much so they say, give BCG as soon as you can get hold of the child. So technically, we give BCG on day 1 or sometimes even on day 0. Whereas if you go to the UK, they give BCG to people who are of the Caucasian race. They do the Manto test or the PPD test around their secondary school entry, and if it is negative, they administer BCG. Otherwise, no. But for ethnic minorities, they do administer BCG within the first 3 months. So it varies depending on the endemicity. And one more thing that I would want to point out here is US has taken a bold step in saying that BCG is not needed because our people are not prone to tuberculosis. I don't know how much we should believe in that, because the world is a much smaller place, with travel becoming more possible now and possible ever before COVID. So much so, diseases that are present in some parts of the world certainly can find their way into other parts of the world. And it may be a bit foolish to say that, you close your eyes and say that our population is immune to tuberculosis and we shouldn't be giving them BCG. I don't think that is the right answer. But however, that is what the CDC and the American Academy of Pediatrics thinks, and that is the recommendation regarding the BCG. Now, just one last word about BCG again is, the BCG efficacy for prevention of primary tuberculosis is low. That is what has been shown. However, there has been newer forms of BCG, which is called as a recombinant BCG, which is the newer research about BCG, which has been shown to be much more effective. So hopefully in the coming years, there may be a more effective BCG that is available, which may be taken up by the rest of the world. I think Dr. Shah wants to add something, please.
Yeah, I just want to add that BCG does not prevent reactivated tuberculosis, which is the adult type. It prevents spread of the primary complex, which is the problem in children, where they can go into first 3 years, especially if they're malnourished, into TBM, disseminated tuberculosis, miliary tuberculosis. Number 2, there is a recent discovery of invention of finding of not a new BCG but a new TB vaccine that's known as M72. It's a recombinant vaccine containing 2 subunits of M tuberculosis, and that is tagged with the famous ASO1 adjuvant of the GSK. GSK, has this unique ASO series of adjuvants, ASO 1, 2, 3, 4, like that. So that M72 with ASO1, a recent trial done showed actually that when you give, and this is intramuscular, and these are 2 doses, 1 month apart, and when you give that, it prevents almost 60% of adult tuberculosis in those who are TB interferon positive, TB gamma interferon positive. So it does prevent secondary reactivation TB in adults. So I think it has a different use as compared to BCG, which is more useful in children. Lastly, as Dr. Krishnamurthy very rightly said, recombinant BCG is there, but the recombinant BCG is also used as an oncovaccine, especially in bladder carcinoma, in colonic cancer, etc., where it can be given intralegionally so that it induces strong immune response and helps as an adjuvant to the chemotherapy. And all of you know, very famous before the COVID vaccines came, there were several papers saying that why the low-income countries which are using BCG universally have lower incidence of COVID as compared to countries which are not using, like Western country like USA. And one of the reasons ascribed was that children are exposed to multiple antigen, including BCG, and also measles and MMR vaccine, which were other focus of the whole group. We're saying that the country which have recently given MMR or measles or have been giving BCG in their national program have lost lesser incidence of COVID in the community. Of course, then the trials began, and not one but 6 trials, including in Australia and USA, of giving BCG to adults to prevent COVID infection. But before the trials were unfolded and could be completed, the COVID vaccines came up, so that those trial results are still not like sort of out or have no meaning today. But BCG is known to be a very strong non-specific immune response inducer. So it has a role beyond tuberculosis.
The question for Dr. Fatima is, we get babies born elsewhere, say from born in USA, born in Australia, Europe, and then they come to Dubai. What is the protocol for giving them BCG vaccine? They come at various age groups, newborn period, 4 months, 6 months, and then they ask, shall we take the BCG?
Yeah, if they are coming and their age is less than 2 months, we give them directly BCG. But if they are above 2 months age, we do for them PPT test, and then after 72 hours, we give them BCG vaccine.
Thank you. Dr. Kalpana?
Okay. Yes, Dr. Fatima, I'll start right at the very beginning. In UAE, we see various immunization, charts being followed. Wouldn't it be nice for the whole country to have one unified immunization guideline? And I mean, what is the hindrance there, or when can we see this happening? So if you can throw some light on this.
Currently, it is unified in the government, but some private, they will give some extra vaccine. But at the level of UAE, DHA, MOH, and Abu Dhabi, it is same. It is unified schedule now for the past maybe 3 years. The only difference between us and them that we give them Rotatec and they are giving Rotarex. The rest is all same.
Right. And I think HPV was included in Abu Dhabi for some time, maybe on a
HPV in the school, yes, in grade 8 they will give. Also in Dubai. In Dubai Health Authority now they are giving HPV 9 for all in all UAE now they are giving to the school girl children, only girl, not yet boys started.
Not yet for boys. Okay, thank you, Doctor. Dr. Krishnamurthy, could you let us know a bit on about polio vaccines, because there's a lot of confusion in people's minds, in pediatricians' mind, when they should use oral inactivated. What was the basis, for the various changes that happened in polio vaccine, even to do with the dose and what was the purpose of the pulse polio program? If you can just, in short, highlight these things.
Sure. Thank you, Dr. Kalpana. See, polio has been a disease, it has been a killer disease for quite a few years. In fact, people of my generation must have seen cases of polio, but the newer generation pediatricians probably aren't seeing the cases of polio. And that is the basic reason why there has been questions asked as to should we be giving polio vaccine even at some places. Now, the first vaccine, whenever we use a vaccine, we certainly look at affordability for the vaccine when it is used on a worldwide basis. And that was one of the reasons why the oral polio vaccine was shot into prominence. The oral polio vaccine is a relatively cheap vaccine, which costs just something like 10p, Indian 10p or 15p for a dose of the vaccine. However, it has stringent storage conditions. And if you don't meet the storage conditions, the vaccine loses its potency. On the other hand, the inactivated polio vaccine, it has been there for a long time. However, it is costly. And nowadays, because of issues with the oral polio vaccine, people have moved away from the oral polio vaccine and have gone into inactivated polio vaccine. So when I say problems with the oral polio vaccine, I think I need to elaborate a bit more on that, because the previous oral polio vaccine was a trivalent oral polio vaccine containing polio type 1, type 2, and type 3, of which the type 2 polio strain has been known to be associated with VAP, which is vaccine associated paralytic polio. And this has been proven beyond doubt. And so the recent polio vaccines are bivalent, which contain only the type 1 and the type 3. However, type 2 does exist in nature and they can cause diseases. So how do you protect people from type 2? And that is where the need for the inactivated polio vaccine also has come. So currently, most countries in the world use a combination of oral polio vaccine and inactivated polio vaccine. The oral polio vaccine to foster herd immunity and because of the cost reasons, and the inactivated polio vaccine to offer protection against type 2. Now, do we give a full dose inactivated polio vaccine or do we give fractional doses? It's again, it was driven by cost. However, evidence has shown that fractional doses of inactivated polio vaccine like 0.2 ml has been found to be equally immunogenic as the other one, as the full dose. Therefore, people in India, particularly, fractional doses of inactivated polio vaccine has been used. Just one word about the mop-up vaccination campaign, which is the Pulse Polio campaign. Irrespective of all these, basically, your idea in giving the polio vaccine is to build up herd immunity. And because the uptake of the vaccine in different sections of the population could be variable, and the oral polio vaccine has not been shown to be having any sort of major issues in immunocompetent individuals, there has been the Pulse Polio immunization program that has been advocated by the WHO to eliminate the wild polio viruses. And if you look into the WHO publications, polio is near close to extinction. Except some pockets of the world, polio has almost been eradicated from the world. That is the current understanding, which is certainly good. So to summarize, I would say a combination of oral polio vaccine and the inactivated polio vaccine certainly is the need of the hour, because type 2 has been removed from the oral polio vaccine. Does that answer your question, Dr. Kalpana?
Yes, it does. Dr. Nitin, would you like to add to it?
Yeah, so see, type 2 wild virus has been eliminated from the world for more than 3 decades. Type 2 is the cause of 90% of CVDPV, which is circulating vaccine-derived poliovirus. Now, these viruses are wild-like, which means they can lead to paralysis and they can spread. So they are no more like vaccine virus. They are wild-like, but their origin is from vaccine. So type 2 is the cause for 90% of CVDPV and almost 30 to 40% of VAP. VAP is also caused by type 1 and type 3. And type 2 is very immunogenic. So whenever you give a trivalent OPV, it is the first to take in the mucosa. So because of that, the type 1 and type 3 seroconversion suffers. So looking at this, there is no need because the wild virus is already gone. And because it's the commonest cause of CVDPV, and it is suppressing the response to other two, the WHO said there must be synchronized switch from TOPV to BOPV, and that's what happened in more than 150 countries. But there was a caveat that it has to be done under a mop-up round with an IPV in a campaign mode, because the type 2 immunity has to be boosted, because that was the last chance to give type 2, unless you also give IPV. Now there's a, see, today if you see, there are only 2 cases of wild polio, one in Afghanistan, one in Pakistan. And I think there was one more recent case probably in Afghanistan. And Afghanistan, the way the problem is, may not be surprised that there might be some more cases because of the problem of instability. But even then you see, there are more than 400 cases of CVDPV, which are paralytic, to prevent 3 cases of wild polio. So we are in an ethical dilemma that you are using a vaccine which leads to more paralysis than what it prevents. So the answer is that you have to switch from OPV to IPV only schedule sooner or later, entire world. Sooner you do, better it is, because till then you will continue to have these VAP cases and CVDPV. So that's the reason why we are using IPV. Now, Hungary has shown that if you give even 1 dose of IPV before any OPV, then it prevents any further VAP. So that's the reason why I insist that every child who can afford an IPV should take 1 IPV at least before he receives any OPV. The second thing is birth dose of OPV is safe because it's under the presence of transclaustral metal antibody. So what we suggest that birth dose of OPV primes the immunity to respond better to the subsequent OPV or IPV, whatever you are using, so that you continue. After that, you give 1, 2, 3 IPV as much as the child can afford. In the public health, they give fractional dose, which is a risk mitigation, not risk avoidance. Maybe it cannot avoid 100% chance of CVDPV. It mitigates it to the tune of 70 to 80%. If you want complete risk avoidance, which means the child should not get any paralytic polio, there is no other way but to use only IPV, at least 3 doses before he receives any OPV. So what we advocate is for those who can afford, should take up birth dose OPV, then 3 doses of IPV containing vaccine, whether it is DTWP based or DTAP based, combination or otherwise, depending on what's available. After that, you give any number of oral polio vaccine, including pulse polio, absolutely no harm. And once polio, wild polio is not there in the world for say 3 years, and the world will be certified as wild polio free, the world will have to switch over from OPV to IPV only, because remember there are also IVDPV, that is immune compromised host with oral polio vaccine leading to paralysis, and some of them secrete the virus for 5 and 10 years. Most of them are B-cell deficiency who are kept alive by IVIG, including in middle income country like India. So these are the threats that they will secrete the virus back in the community. So even if you stop all OPV today, you'll have to wait till the last secretor of an immune compromised host also stops secreting that virus from in the intestine. So it's a very complex process. But I think the message to the private practitioner that I would do what I will do for my child to my patient, and I will give all IPV containing vaccine at least 3 doses before I give any OPV, and I would do the same to the children whom I treat.
Right. And what is the scenario in UAE, Dr. Fatima? I would like to ask you, because we went to bivalent, and then it was told that we'll go to monovalent and OPV will be stopped, but then again it was reintroduced. Also, it is not available to private practitioners. It's available in the government sector only. So if you can.
So it was, as per Dr. Nitin, I am happy, and really he was telling that this to give IPV. So we are giving 2 IPV first at 2 months, 4 months. At 6 months, we give them oral polio. At 18 months, we give them injectable and oral. At 5 years, we give them injectable and oral. It's why we are giving, because they are not declaring that. Since 1992, there is no polio detected in UAE, but because we are not declared as free polio, because you know that our neighbor Afghanistan and the other countries, they have polio cases. For that, we are giving them IPV and OPV, and we hope that we will go back to have only IPV for our children. And as you mentioned, private, they are giving only IPV, and it will be more than enough.
I will just add one more thing, Dr. Kalpana, is that, no country can really have a sigh of relief till the whole world is polio free, because there are not one but several examples of polio re-imported in a country after being polio free for 10 and 15 years. 2006, Namibia, 70 cases, all in adults. Tajikistan, 2010, 480 cases for 10 to 15% in adults. Before that, Cape the Word and so many other countries. So you have to be very, very vigilant about your polio vaccination program and maintain a very high level of coverage. Otherwise, you can be trouble. Remember, all of us now are in an era where there is no wild polio boosting. Okay. And whatever we have is the antibody lasting from our last exposure. So there are studies done to show that there is loss of antibody against type 1, type 2, type 3 by 50 years in more than 15 to 20%. And some of them can become victim of paralytic polio if polio comes back. So that's the reason why most of the European countries not only give 5 doses of IPV, 33 primary and 2 boosters, but also give one more booster in the adolescent age as Tdap IPV, which is available in Western countries. So world is moving to giving more and more doses of IPV. Let us also follow the same and not have a mishap of even one case of adult polio just because we are very strict on use of IPV. By the way, WHO recommends Rota, Pneumo. They are so expensive vaccine compared to IPV, which is so cheap otherwise. So why are we so rigid about use of IPV in our day-to-day practice? Whereas we all talk about giving Prevnar and HPV-9, and they're so expensive vaccine, and yet we can afford, but we can't afford IPV. I think that is something which is beyond science.
Can I just add one point here? Dr. Nitin and Dr. Fatma, you are totally right in that IPV is going to be the vaccine of the day for polio. I totally agree. However, the issues with IPV have been, number one is, in low income countries, the affordability, and number two is the availability of the vaccine, because the world has not been able to live up to the necessity for IPV. And that's the reason why we went ahead with the fractional doses and all that. Dr. Nitin was totally right in saying that it doesn't eliminate the risk. It is a risk mitigation strategy. I do agree. But all said and done, we have to, when we don't have enough of the vaccine doses, we have to find out innovative ways of how to cover the whole population using the existing vaccine sources. And
so Dr. Krishnamurthy, I can respond to that by saying that I have interacted with there are 3 manufacturers of IPV in the world. One is GSK, other is Sanofi, third now is Serum, because it acquired that European countries. And all of them say that you pre-order for the next 10 years, 100 million doses, we will make 100 million doses for you. So, that availability being not there was an issue in past, no more.
Okay, that's good news, basically. But the only thing is, it needs to be, I mean, the policy makers need to take up this to say
Absolutely.
that, that is what is needed, which is where the sort of interplay between, health economics, policies, and politics do come in.
I like your last sentence the most, because as I said, beyond science, I didn't want to elaborate, but now that we are discussing openly, this is the only disease where we have not one but 2 extraordinary workhorses, and we prefer to only use one and neglect the other totally, not for science but reasons beyond science. And I will not tell whom and why, we can privately discuss, but all of us know that there was a preference given to only OPV and OPV alone, completed a neglect of IPV. In fact, India was to manufacture IPV along with France government way back when hepatitis B were being made. But somehow that got shelved. And IPV was licensed in India for 4 months from Serum when I just started practice. That's in 1986, 87, I'm saying. But again, the license was withdrawn. So, these are things which we cannot discuss openly, but I can tell you there is something beyond science that is happening, which is keeping this whole world, with polio problem that we are today. It's not just the availability and the cost. You think HPV-9 costs lesser than an IPV dose?
Thank you, Dr. Nitin. It's again, we shouldn't be comparing the other vaccines like the PCV and the HPV, because they, in the developing countries, these vaccines have been included or named as optional vaccines. And that has created much more confusion in the minds of people, because when you say something as optional, people think that, well, even if you don't take it, it is okay. It is optional only for the reason that governments cannot afford to pay for the cost of the vaccine for the entire population. That is the only reason. The efficacy remains exactly the same, and it is certainly useful. That has been proven beyond doubt. And all the vaccines that are available today, the PCV, the HPV, all the other vaccines, the newer vaccines, are certainly there to stay. And world should accept that these are vaccines that change the face of communicable diseases in the world, and everyone should have access to these vaccines.
That's why we now call them additional vaccines and not optional vaccines.
Exactly. The word optional should be out.
Yes.
Even if a nurse
is removed by IAP almost 6-7 years back. We say it's additional vaccine. In fact, now the IAP schedule doesn't even speak of additional. It says this is our timetable for our practitioners for their patient. Government has EPI or the national program, which is the schedule. So, we don't even say that that's why it's additional, that's why it's optional. We don't discriminate.
The EPI should include these vaccines as well, which is where we are entering into a debatable area at this point in time. As and when the EPI equates to the IAP recommendation. That is the time when people will have all the vaccines that are necessary to protect the children from communicable diseases.
Right. And that's exactly what's happening. You see, Rota is included, IPV is included, now PCV is included, then influenza is included for mothers, then HPV is included in 3 states of the country. So, last 5 years, we are seeing a sea of difference.
Now we move to the next vaccine, please. About the pneumococcal vaccines. Dr. Krishnamurthy, is there a preference between the 2 available vaccines and your view on between 3 doses versus 4 doses of pneumococcal vaccines?
Good. Again, the pneumococcal vaccines are here to stay. As I would say, if you look into the history of pneumococcal vaccine, it came as the PCV7, then came the PCV10, and then came the PCV13. Right? The PCV, we don't know whether this is going to be the final vaccine, honestly, because antigenic variation in pneumococcal subtypes have been shown to be the reason why we had to go from 7, 10 to 13, because 7 used about 60 or about 80% of the common serotypes, and then we had a greater disease incidence due to a different serotype, which was included in the 10. We had yet another one which is included in the 13, and we don't know what is going to be the future. But all said and done, PCV13 has been found to be highly immunogenic, and it has been found to be effective in preventing, the higher forms of invasive pneumococcal disease. That is what they say. And PCV13 is there to stay. 3 doses of PCV13 have been recommended in the UAE and there used to be a 4th dose at 18 months, which has been taken away, which is exactly what has happened in the UK also. But CDC still recommends use of the 4th dose of pneumococcal vaccine. And again, these are policies that have been taken for various reasons, right? Apart from scientific reasons. I think Dr. Fatma will be able to shed more light into the reasons why the 4th dose of PCV was taken away from the Dubai schedule.
Yeah, also why the schedule was decided to be 3+0 instead of 2+1. Dr. Fatima, if you can just explain that to us.
This one, we had so much negotiation. They reduce it because there are so many studies going on that 3 PCV13 is more than enough. But why it is 3+0 or 2+1, it was, I cannot tell you now. They started as this one, and then they said after sometimes they will do some study and see if it's enough or no. But if we have a case of children with chronic lung disease, immunocompromised, or any other diseases, for example, sickle cell anemia, those cases with some chronic condition, we are giving them 4. But routinely now we move to 3 only, 2, 4, and 6 months. And the Dr. Karishma, he was telling that we have PCV13 now, there is PCV20 also. And I hear that in UAE they brought, but I don't know it is accepted or not, but they told me companies that they have, and it is already approved FDA and something. And so, this is they are working.
Can I add?
Yes, Dr. Nitin.
So remember, the UK was the first country to try this 2+1, 3+0 with hip vaccine. So there they dropped the booster and continued giving 3 primary at 2, 3, and 4 months. And they, within 3 years of dropping the booster, they started seeing breakthrough hip cases. So they reintroduced hip booster. So when it came to pneumococcal, they said booster is the most important for long lasting. So they switched to 2+1, where they give 2, 3, and then early booster at 12 months, and that helped. That was the PCV7. With PCV13, they continued the same. And now, very recently, they switched to 1+1. They just give 1 primary dose and a booster, but they do give the booster at 12 months. To me, the booster is the most important. So if the UAE wants to drop 1 dose, I would say they should do exactly what UK was doing, 2, 3, and 12, or 2, 4, and 12, whatever is your schedule. Don't drop the booster for long-term immunity. I must remind you here that PCV20 that Dr. Fatma talked about is recently licensed for adults in USA, but it's not licensed for children as of now. Maybe next year it will get licensed for children too. it is 7 more serotype over PCV13, which gives 4 or 5% more coverage in children. But in adults, it's more coverage, because in adults, after use of PCV13 in the national program is such a strong herd immunity, whatever serotype that are left in adults are usually non-PCV13 type. So there, adding those 7 serotype is going to add to a lot of advantage as compared to in children, say in India, UAE, where we still have this children serotype persisting, where the difference between PCV13 and PCV20 will be around 4% extra coverage at an expense of little lesser immune response per serotype and the cost, which we don't know still. And last but not the least, I must also inform you that there is one more PCV, the 10-valent PCV from Serum Institute of India, which is the 10 most prevalent serotypes seen in the developing part of the world and in general in the world, which is launched by Serum in India and a lot of other countries. Is part of the national program in India. We use as 2+1 schedule, where we give 6 weeks, 14 weeks, and an early booster at 9 months along with the first MMR vaccine. And I'm also happy to say that PCV10 of Serum has replaced PCV13 not only in India but in some other countries too, like Philippines and Malaysia. And the Gavi, which supports the vaccination at a very throwaway price for the Gavi eligible country, has made an AMC, that is advanced market commitment, of 10 million doses per year for the next 10 years, which means 100 million doses of Serum's vaccine will be used through Gavi funding in the other parts of the world in the next 10 years. So this vaccine is going to give a serious challenge to PCV10 of GSK and PCV13 of Pfizer. And the difference in the serotype coverage in India is not more than 2% between Serum's vaccine and PCV13.
Do we still have the polysaccharide 21-valent vaccine available in India?
23-valent. That's recently gone out of market, but I'm sure it's going to be available. And I forgot to mention that MSD is very soon going to license. In fact, it's licensed in USA for adults, PCV15. So it has 22F and 33F in addition to the 13 serotype which are there in PCV13. So it's a PCV15, which is, so if you are using PCV15 in USA, then you also give them PPSV23 8 weeks to 1 year later for adults. Whereas if you are using PCV20, then you don't have to give that PPSV23 because there are 5 more serotypes. So that is the status of ACIP and US FDA recommendation in USA. But PCV20 is not available anywhere else, so we can't talk about the same in, say, UAE or in our country.
Thank you, Dr. Nitin. This is where, the changing scenario of the pneumococcal vaccines from 7 to 10 to 13 to 15 to 20 is what is giving a shot in the hands of people who say that vaccines have caused antigenic variation, and you are bringing in things that were rare in the past to become more common now and cause more harm than good. This is something that we as pediatricians will have to convince the people to say that that is not what has happened, but that is essentially the issue where these sort of variations do happen. I think IAP as well as all other pediatric organizations will have a tougher task to get people to understand that the changing scenario of the pneumococcal vaccine is essentially because of increased coverage that is expected. And as you said about adults, this population who have already received the 13-valent pneumococcal vaccine, when they come to the age of about 50, then they won't get the vaccine they won't get pneumococcal disease due to strains included in the 13-valent vaccine, but could get it due to other ones, and they may need a better vaccine at that stage. So this is something that is an ongoing process that we may need to convince the people to increase the acceptability of the vaccine.
So I think we must, the delegates must understand that there is no significant replacement serotype after use of PCV7 or PCV10 or PCV13. So the higher valency vaccines are made not because something is gone out of hand, it is just to increase more and more coverage so that you have more and more benefit.
Right. Moving on to meningococcal vaccine. Now, what is the ideal schedule? What should be followed? Now, UAE market also, we have the meningococcal B, which has joined the bandwagon. So what are your opinions on appropriate timing? Because, what the companies say and what CDC advises is totally different. So, Dr. Nitin, maybe you can continue.
So I mean, if you ask me frankly, talking from Indian point of view, because I don't know the UAE epidemiology, but what epidemiology I know in India, it's an excellent vaccine which is in search of an indication, because we really don't know where to use, how many doses to use. In United States, they know the problem is in adolescents when they go to the university, and especially if they stay in the university hostels, then there are outbreaks of meningococcal disease. In UK, they knew that type C is very early in life, right from infancy. So they included type C as three doses at 2, 3, 4 months, and then now they have replaced that with the instead of only type C, a quadrivalent vaccine. So these countries know their epidemiology, so they can target accordingly the age group. I don't know the epidemiology in India because there are hardly any. I mean, I haven't seen a meningococcal disease for the last 25 years. But there have been outbreaks in Delhi and in the northeastern states. So they have seen some cases. But again, last 5, 10 years, there have been no outbreak again there. So for that to make it as a universal vaccine in a country like India, I think is a completely not a correct policy. So to me, it should be used for anyone who asks it or anyone who needs it, like an immune compromised host. Beyond that, I don't push this vaccine in my day-to-day practice. But if there's an outbreak, it's a good outbreak response vaccine along with chemoprophylaxis. So that's far as my views on the use in India is concerned. Now, you have 2 vaccines, one from GSK, one from Sanofi. Sanofi can be used right as early as 9 months of age. GSK can be actually used as early as 2 months of age, but there are very few countries which have licensed at 2, 4, and 6. Whereas like in India is licensed only beyond 2 years of age, So depending upon your local epidemiology and your local licensing, you will use the vaccine. But again, I reiterate that never refuse a vaccine to someone who asks it, because suppose my patient wants it and I don't give, and if suppose for some reason that child develops meningococcal disease which is life-threatening, then I have no answer to give. So I don't push it, but I don't deny it. I mean, that's my frank opinion on this vaccine.
But do you educate them regarding it?
No, we don't. I don't even open the
one
discussion of meningococcal disease or availability of meningococcal vaccine unless the parents say, is there any new vaccine? Is there something more than what you're given? Then only I will say. Because once I say it, then people will say, okay, I want it. And it's so expensive. And then my question is, if I suppose I give at 9 months and 15 months 2 doses, after that, what? They are exposed for 5 years, 10 years, 15 years, when we don't know. So really speaking, then you have to keep on giving every 5 years, which is not possible.
I would just add one more thing to what Dr. Nitin said. In the UK, yes, they used to give men A and C earlier. They have now replaced that, and they are using the men B vaccination, because men B constitutes or represents nearly 70% of the cases according to the UK studies, and they are using men B given at 8 weeks and at 16 weeks, followed by a booster at about at 18 months. That is what they say. And what studies have shown, according to the UK, Immunization Advisory Committee, is that they say that there is the immunological memory which may help them in the longer run, and you may not need to give these vaccines every 5 years or 10 years. If the risk of meningococcal disease causing death is much higher at any age, but it is certainly more in younger ages. And so that's the reason why UK is giving the vaccine at 2 months, 4 months, and at 16 to 18 months. Whereas in the US, this vaccine is given only around 11 to 12 years of age. And B vaccine, they recommend only maybe, that is what CDC says, you may give it around 16 years, that's it. If you look in the Middle East, people who travel to for Hajj or Umrah pilgrimage and all that, they need the quadrivalent meningococcal vaccine, which is the ACYW135. Again, why is it that B has been taken away from that? Was essentially because B was not available when this policy was launched. Now with the policy of B being available and is known to be causing more outbreaks, possibly that might be included as well in the vaccination schedule, travel vaccination schedule. We don't know.
Right.
May I interrupt here? Last time we had vaccine meeting, Dr. Fatima promised that the meningococcal will be introduced soon in UAE, because we are neighbor of Saudi, and I mean, many people are going and coming. I would like to request Dr. Fatima to comment on this. Will it be in the vaccination schedule soon or not?
We had recently meeting and they said because we introduced in grade 11, so 15 to 16 years old they are giving. So, but maybe now they changed their mind this year, maybe no, I don't know when they will start, but they are telling for our region and country, grade 11 is enough to give one dose for all school children. So they are not planning that to give to earlier, just nowadays.
Thank you.
Is it for meningo B all as well or ACWI?
They are giving AC, there's quadruple and ACW1 is.
And how about meningo B?
Till now, I don't know really.
It is not licensed for use in Dubai as of in UAE as of now. That's my understanding. Dr. Fatma, please correct me if I am wrong.
But Kalpana, we have 15 minutes.
Yes, no, it has recently been introduced, Dr. Krishnamurthy, and I think they must have licensed it.
People using it already.
So yeah, people are using it. However, it still is debatable when and to whom it should be given. And as with all the vaccines, I think local data is very important. So unless until we have that, just to keep on including would be difficult. I would like to now talk about COVID vaccine. Dr. Nitin is here and we should take full advantage of his presence.
You can see the video, which is there on
yes,
YouTube.
Yes, that is the very...
Now, should we go for fifth or not?
That is the most popular video of DPC. However, since your talk, in the last time, there have been some other pointers like Dr. Saurabh is asking about boosters.
Yes.
And then the other thing being the age of vaccination. It's been lowered for FDA approved vaccines. So your comments on these two things.
So first about the booster, Israel was the first country which actually achieved a very quick coverage in the community with 2 back-to-back, almost like a campaign mode vaccination. And then the disease really went down. They opened up the entire Israel, including pubs, gymkhana, theaters, malls, schools, everything, and no mask except in a highly crowded area. They started seeing some breakthrough cases in vaccinated population, so that alarmed them. So they did a quick study of people above the age of 60 years who had taken the last dose of Pfizer vaccine. They use only Pfizer vaccine there, who had taken the last dose of Pfizer vaccine more than 6 months before. And they randomized this population into half receiving a booster of Pfizer and half not receiving booster. And they studied what is the disease pattern in the next 40 days. And they found that those who were vaccinated with a booster, the incidence of COVID disease dropped by 14 factor, that is 14 times lesser as compared to those who had not taken the booster. So based on that, they introduced the booster 6 months after the last dose, starting with people who are above 65, people with comorbidity, and then gradually going down to the entire community. Based on this, the Pfizer applied for a booster in USA, and there the ACIP and the CDC and FDA, they debated, and they said that 8 months after the last dose, they would recommend a booster. Initially, again, the approach was for elderly and at-risk conditions. And now recently, I think few days back, they've said that the entire population is eligible for a booster. So UAE, of course, not booster, but because they were using Sinopharm and the Chinese vaccine, which had 2 problems. One was little lesser efficacy in other countries, and number 2, not enough people who are at risk for severe disease like elderly, diabetic, obese were included in the clinical trial. So they say those who have taken 2 doses of the Sinopharm vaccine can take 1 or 2 additional doses of either same vaccine or Pfizer vaccine, especially when Pfizer vaccine became available. So it's an indirect way of taking a booster. So I have a feeling that the booster would be required for the mankind sooner or later. It would depend on the availability of the vaccine, your local epidemiology, and the need. So all of us will have to take a booster some or other time. Whether you'll need annual booster, I don't think so, because as on today, we don't have anything which has really gone out of hand except the Delta variant. And remember, Delta variant came in India in April when vaccination for general people was not still possible. It was only for the frontline workers. So very recently, 3 countries, South Africa, Botswana, and I think one more has found a new variant. They name it some B.1.3-510 or something, which has got some 40 mutation in the spike protein. And that is the reason they believe that it might go out of hand and even escape the immune response, either natural or antibody. So you may need not only a booster, but a separate vaccine. Generally, you need higher antibody titers to tackle variants. And you can develop only higher antibody titers by taking booster. So that is the science behind booster. Now people ask, in India, the booster is not available officially. What do you do? So I tell them that you do your anti-spike antibody titers. If they are really low or not detectable, and you have taken 2 doses in past, for sure you are the candidate for taking booster, especially if you're elderly and having at-risk condition. But otherwise, wait for the official policy, because taking haphazard vaccination is not correct. So that's as far as booster is concerned. Now coming to children, the children are not really affected by clinical COVID as much. And even if they get clinical COVID, they are generally not very serious or needing hospitalization unless they have comorbid condition like chronic renal failure, diabetes, malignancy survivor, stem cell transplant, primary immunodeficiency, etc. So that's why they took a backseat as far as vaccination for them is concerned. But US and many other Western countries have opened up vaccination for children either between 12 and 18, or some now even between 6 and 18. And there are 2 trials done in India, one for Covaxin, which is Bharat Biotech vaccine from 2 years of age onwards, and other is Zydus vaccine, which has done trial for 12 to 18 years. And both these vaccines have got EUA, emergency utilization authorization for children, but the rollout has not happened. And I believe the rollout will probably happen in January or February. But suppose in your country, in UAE, suppose Pfizer vaccine is available for children, give it, because children may not suffer, but they may be reservoir and they may transmit it to the teachers or staff at school or grandparents back home who may be susceptible to severe COVID. So for that sheer reason, if you're going to open up the market, the theaters, the recreation and the schools, children will at least will be able to get transmission, if not suffer themselves. So for that reason, you can't keep a 30-40% of the population, which is child population, without vaccination, because that is not the way you will achieve herd immunity. So I think children vaccination should start as early as possible. But that should not deter you from starting school. Like in Mumbai, in Maharashtra, where I come from, the government has already given a direction that from standard 1 onward, the schools can reopen from 1st December. So, we are not still vaccinating children. So I think they should not be linked to one another. Yes.
Schools have reopened here.
Yes.
In fact, Sinopharm was allowed from 3 years onwards. I don't know the real numbers, but I don't think that the response has been as good as with adult vaccination.
But I must
People
tell
are
you here
waiting
that
for
both
Pfizer.
Moderna and Pfizer vaccine, when they were tried in the children between 12 to 18 years, the efficacy was 100%. So that is the strong immune response that children develop in general. So I think they should be using this vaccine for children.
And where are we on the Janssen, which was 1 dose? What
So
was
Johnson 1 dose had an efficacy of around 72%. So they also tried giving 2 doses and they found that the efficacy jumps to 85%. So they believe that probably 2 doses may be better than 1 dose. Johnson came a little late, so of course it had its own problem. As you know, Johnson also is a live vaccine in that sense, like it's a vector-borne vaccine. It has the same human adenovirus as the vector, whereas the serum and the Astra has the chimpanzee adenovirus. Both have adenovirus. Now, all these adenovirus vaccines have had their problem of thromboembolism in women after 2nd dose. And the Pfizer vaccine has the problem of acute myocarditis in men, young men, after the 1st dose. So there is no vaccine which is really sacrosanct from this rare side effect. Sputnik vaccine, which I understand, has not shown any thromboembolism so far. And of course, so that's where we lie, that this is the price community pays of having an occasional death following a vaccine, which actually prevents a lot of deaths because of COVID. So it's true for any other vaccine, also for COVID vaccine.
So, in India, it has been approved from 2 years to 18 years, and no mRNA vaccine is there in India.
So mRNA vaccine is given emergency utilization authorization based on their international study. But these manufacturers are not ready to bring the vaccine here, because the essential reason, number one, minus 20 degree or minus 80 degree storage, which is not possible in country like ours. Number two, more important, is a waiver for side effect compensation. So the government of India is not ready to sign that waiver, and that's the reason why they are not coming here, especially when they are selling so much in the Western country and making the money, because they know if they bring to India, it'll be at they have to bring it at a very lower rate. Like today, you can get all COVID vaccine free in government center, and even if you go to private hospital, there's a cap put. Like say for Covishield, you can't charge more than 250 rupees. And for Covaxin, again, not more than 350 rupees. So, where is that vis-a-vis $40 for a Pfizer vaccine?
Thank you. Thank you.
Can I just add one more thing to what Dr. Nitin had already said? See, it is, as Dr. Nitin said, it is well known that booster doses at elderly ages, people with chronic diseases, that is the science to say that booster doses are certainly effective. They increase the antibody levels. However, I think there is a bit of interplay between science and politics here again, and because they want to have higher numbers of immunization coverage back in India, a booster is not still a recommended policy, even though we certainly know that it is useful. And regarding the Pfizer, the issue is essentially the waiver, because the vaccines, particularly when you use in younger adults, as Dr. Nitin already said, the risk of myocarditis has been there, and the risk of thromboembolism has been there. And with a population of pretty high compared to the Western world, and if they use it rampantly, then the risk of compensations and all would be high. And without a waiver, these companies are not willing to bring in the vaccine in India. And that's the reason why we don't have the mRNA vaccines. But
just one comment to add. Sorry, go ahead, sir. Sorry, go ahead.
No, we still have something useful, and which does the purpose, so that is fine.
Right. So I just want to add to that I mean, it's since April now, almost November, 7 months have passed for people to take vaccine. Believe me, in the public sector where the vaccine is given free, there is no taker. Like you walk in and they will be giving you a red carpet to take the vaccine. So people who have not taken the vaccine now are not going to take the vaccine unless they are really pushed. Either they won't get salary, they can't travel, they can't go to the theater, they can't go to the mall, or whatever indirect way of coercing them. So I think, and now we have plenty of vaccine. In fact, the vaccine exports have restarted from India, both for Covaxin and Covishield. So I think the government will have to somewhere think that, okay, people who are not taken even one dose, in spite of 8 months passing, is not because of lack of availability, just because they don't want to take. Only people who are eligible and want to take booster, allow them. So I think maybe in the next 2-3 months, the whole fulcrum of thinking will change. What government is doing today is pushing for the second dose to complete 2-dose vaccination in as many as possible, and induce those who have not taken one dose to take at least the first dose by a campaign mode and by various modes. And that has been successful. So I think next 2-3 months are vital. Maybe after that, even India will start boosters.
So there's one question from audience. Dr. Maria would like to know about vaccine hesitancy or total, there are parents who just don't want to give. So quickly, what are your strategies to convince them, or what do you,
you have 3 minutes only, please.
Yes.
Vaccine hesitancy is a problem world over, and I think the only way is counseling. And you give them example of people who have suffered, children who have died, children who have had chronic morbidity because of the vaccine preventable disease, and to also tell them that how many countries are using, how many agencies are recommending, and it is available free, at least in countries like India and many other countries, through public health. So it's not always profit driven, etc. That will probably shift a lot of people from not taking to taking. There is some who are still not going to take. I don't think so there's really anything you can do about that.
Dr. Fatima, is there any law? I mean, there are parents who refuse totally to give even primary vaccine. Can we force them to? Is there any law? Can it be taken as child abuse or neglect? Dr. Fatima can answer.
Sorry, I did not hear your question, doctor.
Yeah, my question is, there are parents who totally refuse vaccination, even primary vaccines they don't want to take. Is there any law forcing them, or can we put it as a child abuse or neglect?
We have a DEMA law that it is mandatory. All this is one of the child's rights to take vaccine. And if we come to know that any parents are not giving their child vaccine, we are reporting. And we are calling them. There are so many things going on. But as Dr. Nitin was saying, that we are sitting with them, we are counseling them. Always I show them the people who is in wheelchair because of polio, the people with severe due to measles, encephalitis, so many things. And we show them the picture. Most of the time, when they reach our clinic and we counsel them, they agree. And then nowadays, if anybody is going to emergency for anything, all the doctors, they are, this is their duty to check their immunization status, because it is now one system. They can see. And if anyone was not vaccinated, they will report to us. We have a child protection committee, and they will call them, they counsel them, and they will bring them to take vaccine.
Last
I
question.
think there is a
One
lot
thing I
of
will add to
there is
that,
a lot of
in different
chance of mischance of vaccination rather than vaccine hesitancy, which means parents would take it probably, but no one told them, no one reminded them. They said next time, but the next time never came. So every point of contact with a child, whether it's during illness or otherwise, we must keep on reminding about missing doses. Even that itself will convert a lot of vaccination to happen.
Yes,
and
last
just one,
comment by
one
Dr.
more
Krishna.
thing about other parts of the world. I have been in other parts of the world, particularly Singapore, where if you don't offer primary vaccine, if a child has not been given a primary vaccination and contracts a communicable disease which was vaccine preventable, then it is punishable. The parents are punishable by law. They can be imprisoned. This is it. So people have gone from one end to the other. In Singapore, it is a punishable offense if you don't give vaccination.
Thank you very much. Thank you very much. If you see Dr. Nitin told us he's having clinic after this because it is 2:50. I would like to thank all of you, Dr. Nitin, Dr. Krishnamurthy, Dr. Fatima, Dr. Kalpana, Dr. Joshi. It was a really good session. I learned a lot of things. I mean, vaccine has no end, really. Every day you want to hear. Thank you very much. I see even Dr. Asar also intensivist clapping for you. Thank you very much. So, with this, we end this session. Now, it gives me a great pleasure to introduce the chairman of the next session, Dr. Rajendra Joshi, Senior Consultant Pediatrician, Prime Hospital, ex-President Dubai Pediatric Club, genetic specialist. If I go on mentioning his CV is more than CV of all. So, Dr. Joshi, please introduce your panelists. We have eminent panelists, 5 today, and I want to request all viewers to stay tuned because this will be a very good session. I would like to welcome Dr. Devadatta, Dr. Hassan, Dr. Walid, Dr. Asrar, and where is Dr. Parveen? Please.
There I am.
Yeah, Dr. Parveen, I think is going by plane. Please start.
Good afternoon. Welcome to the afternoon session of this MISC, Kawasaki, and similar syndromes. My job is very simple. I have to introduce 2 panelists, Dr. Kalpana Sengupta, who needs no introduction. She is the face and the backbone of Dubai Pediatric Club. She is currently HOD of the NMC Hospital, and she is the General Secretary of the Dubai Pediatric Club. The other panelist, is Dr. Diari is there. He is the chairman of academic affairs of the Dubai Pediatric Club. He is presently the consultant pediatric surgeon at Latifa, now Jalila Hospital. And can I hand over the stage to Dr. Kalpana Sengupta to introduce the panelists?
Sure. Thank you, Dr. Diari will be introducing the first 2 panelists.
Yeah, thank you, Dr. Joshi and Dr. Kalpana. We have 5 eminents in this session, 5 eminent panelists. We will start with introducing the Dr. Walid Abu Hammour. Dr. Walid Abu Hammour, he is really a famous pediatric infectious disease, and he is a close friend. He is the head of the infectious disease, pediatric infectious disease in Jalila Hospital. Our next panelist is Dr. Ghassan. He is also a very eminent and infectious disease, pediatric infectious disease. He is a consultant and head of Department of Pediatric Infectious Disease in Tawam Hospital, Al Ain, UAE.
We also
I will hand it over to Dr. Kalpana to introduce the other.
Thank you. We also have 2 pediatric intensivists. Dr. Asrar Rashid is a consultant pediatric intensivist and HOD at NMC Royal Hospital, Khalifa City, Abu Dhabi. And Dr. Praveen Kilnani, who is the clinical director and senior consultant pediatric intensivist at Madhukar Rainbow Children's Hospital, Delhi, India. And not to forget Dr. Devadatta, who's been so gracious to accept our invitation to be a part of this panel. Dr. Devadatta is a consultant pediatric cardiologist, associate professor, West Bengal University of Health Sciences, and visiting consultant at pediatric cardiologist at Apollo Hospital, Kolkata. We welcome all of you to this much awaited and interesting session on MISC. I think, do we have all the panelists here with us?
Yes.
Yes, okay. So Yes, Dr. Diari, we can start off by.
Yes, we will start. We will open our session by asking Dr. Ghassan. Dr. Ghassan, good afternoon.
Good afternoon. Nice to meet you. Thank you very much for the invitation.
Thank you, Dr. Ghassan. Dr. Ghassan, as we know now, MISC or MIS-C or K became very, we have a lot of cases. So what is the definition? As we know, there is a lot of definitions, WHO, CDC, we have other definitions of this syndrome or this disease. So can you highlight on that one, please?
So we know that MIS is a totally new and elusive, syndrome that have a very similar kind of presentation with Kawasaki disease. And here comes in the, defining the differences between these two entities comes in. And the main two authorities that put a case definition for MIS-C is the CDC and the WHO. And I believe that both of them are very similar in terms of the requirements for both, case definitions. The only difference is perhaps in the timing of fever, because both of them would require an age below the 21 year of age. The fever should be in both of them, but the WHO required more than 3 days of fever, while and requiring more than 1 day, 24 hours. The degree of temperature is around 38, and then having an system involvement alongside with some lab investigations, increasing in inflammatory markers alongside with involvement of at least 2 systems in the presentation, which could be anything like GI, skin, CNS, or whatever. And of course, the epidemiological link with SARS-CoV-2, and here we can do either the PCR, RT-PCR, or the serology to confirm the link, the epidemiological link. And I believe the most important thing all the time with both definitions, that you need to look for any overlapping entity, either an infectious versus non-infectious. So a plausible diagnosis has to be excluded before jumping in and deciding if the patient fits into the definition of MIS-C, either as per the WHO or the CDC.
Doctor, I would like to know your opinion on us following the criteria as they have been set down. Because if we don't, we run into the risk of overdiagnosing MIS-C. But what is your opinion regarding it? Because one of the parameters is that there should be no other identifiable diagnosis. And another one is the relevance of the testing, the antibody testing. Should all MIS-C cases have a positive antibody test, or can we have cases without that as well? So maybe you and Dr. Walid can opine on this. Yes, Dr. Ghassan, go ahead.
Yeah. Okay.
Go ahead, Dr. Walid.
Okay. First of all, thanks for inviting me for this annual meeting. I would like to thank the organizing committee, the scientific committee. Special thanks to Dr. Sohrab, Dr. Kalpana, and others for this great effort. I'm sorry I joined the conference late, but I attended the vaccine session, which is really very informative and very helpful, and we learned from this session. Though I had a few comments, but there was no time to comment on these issues, which is actually controversial. It is not something maybe we can discuss it later on. I would like to thank my close friend, Dr. Diari, for the introduction, and I would like to say hi to my colleagues here in this panel session, and welcome Dr. Ghassan. For a while I haven't seen you. We work together in Trump Hospital. To be honest with you, this is very loose statement that there is no identifiable cause for this illness, which I don't agree on this totally. And we have to remember guideline is guideline and case definition according to the guidelines, and this can be changed in any time. For example, I have seen cases of MISC, and when they did the respiratory biofire, there will be enterorhinovirus positive. So for people, sometimes they'll say there is identifiable cause for this gastroenteritis. But in fact, the whole picture goes with the MIC. It is not really due to the enterovirus. We have seen tons of enteroviruses. They don't present with this picture, with this cytokine storms, with high inflammatory markers. So I don't agree with this. We have to be more specific with the no identifiable alternative diagnosis. What does it mean? Sometimes, as we know, children in winter, they might have viruses, and this, if you do it in 1 month or 3 weeks, still will be positive, but it has nothing to do with the current illness. I had one patient, you know, in at Al Jalila Children's, who literally lives in Al Jalila because of chronic underlying comorbidities, and we are planning to write it to the, you know, to challenge the case definition. He has bacterial sepsis and MIC concurrently. So if I have to follow this definition, I would have missed to diagnose MISC. Though when I treated him as MISC, though the blood culture was Enterobacter and he was in septic shock, but I insisted because I have timeline to follow this patient. He was in hospital. He lives in the hospital. And one time he had respiratory symptoms. We tested him. It was COVID positive. 10 days later on, he was in shock and cytokine storm. Blood culture showed Enterobacter in the central line. However, this child, he has at least 15 central line infections or sepsis. Then antibodies was positive. Echocardiogram showed dilated coronaries. This is very challenging case. If we would have just followed the definition that you have to rule out septic shock due to bacterial infection, we would not have proceed to treat as MISC. So what I want to say, a guideline is guideline, but clinical judgment is very important, particularly in children. Not uncommon to find concurrent respiratory viral infections that it could be 1 month ago, or sometimes mycoplasma IgM, which can be for several months. I think, you know, history and physical examination and clinical judgment is the most important factors, because missing MISC and not treating MISC, the outcome is very devastating. Thank you.
So sure. So Dr. Ghassan, in your opinion, what would be the most important clinical scenarios where a general pediatrician should think of MISC? These are that you would have come across.
So basically, as I think I would agree totally with Dr. Walid, I mean, having an MISC, it's a very unique presentation where you need to think, first of all, we need to think about MISC for many of sick children who are admitted, got hospitalized. And you know, the presentation of MISC is very similar to some extent to Kawasaki disease. So patient might come with the rash, with the conjunctivitis, the GI manifestation, or as I just mentioned in the case definition, when you have the multi-system involvement alongside with the fever. And many of those children will end up in the hospital. So we need to keep low index of suspicion for MISC on many patients, especially in the era of COVID-19, where the temporary association with the severe illness like MISC still existed. So I think keeping those threshold all the time to think of MISC in many cases is the key point in order not to miss a single case, that because as just Dr. Reed mentioned, it's devastating at some point if you miss the case and you just make a diagnosis later. Those patients may end up with very long-term sequelae. So I think we have to think about MISC in the case where the clinical presentation fits in, where the elusive differential diagnosis there, where the picture is not really fitting in a very well-known or common disease, then MISC steps in and we need to think about it.
Dr. Kalpana, if I could add something here, you know, again, nothing replaces clinical judgment, nothing replaces the clinical picture and which time of the year we are seeing patients. Nowadays, everyone has experience with RSV bronchiolitis, which is really, this season is really hard. And I would say, you know, on a daily basis, we admit patients with a bronchiolitis. So definitely they will have fever more than 3 days, respiratory symptoms, respiratory distress, but the runny nose, the condition, the wheezes, etc. You know, we don't have to think of every case as MISC. As Dr. Ghassan mentioned, if you have really sick patient and you exclude clinically, you know, the most common nowadays in winter, it is RSV bronchiolitis or respiratory viruses, we can tell the difference clinically, though sometimes RSV bronchiolitis is really bad. The point here, the American Academy of Pediatrics before the era of COVID recommended that don't do any confirmation for RSV bronchiolitis or metapneumobronchiolitis. And the case definition by clinical and management is supported. However, in the temporal relation to COVID-19, I would say, you know, the utilization of the rapid test, it has a great value nowadays more than any time else. For example, if you are in doubt, we will just do the BioFire, RSV there, metapneumovirus there, influenza there, so we have an answer, and we don't have to really think more than this. However, if the patient has respiratory distress, fever, etc., as Dr. Ghassan mentioned, and you could not find by BioFire, which is really very sensitive, respiratory BioFire negative, then maybe you have to go, and maybe Dr. Ghassan will talk about it, tier 1 and then tier 2 evaluation. What I want to say, history, clinical judgment are the most important decision factors in this context.
Yeah. Dr. Ghassan, next question will be regarding the inflammatory markers. So as a general practitioner or a pediatrician in the emergency when a patient coming and clinically suspected MISC, so what's next step for him to start with before referring the patient to an infectious disease physician?
So basically, MIC, you know, it's an autoinflammatory process, or it is an inflammatory process, and we expect that many of the inflammatory markers will go up. So if the patient is under investigation for the possibility of MIS here to start with, then here the thing comes in, you have a time to do the tiered approach. You start with a stepwise, you know, approach by doing the investigation before committing your patient to treatment. And the baseline for any patient suspected to have MIC is to do, you know, the CBC, the CRP, the ESR, the complete metabolic panel, plus minus the SARS-CoV antibodies or the rapid test, as just Dr. Walid mentioned. And according to the clinical findings and these preliminary labs, you can move into the tier 2 versus finding an alternative or a plausible diagnosis that can explain the current clinical presentation of the patient. Most of the time, we expect that the CRP, the ESR, you know, the differential of the CBC will gives you a very good idea about the possibility of MIC in this particular case, as long as the clinical and epidemiological link to MIC is really there. So starting with this baseline investigation will tell us a lot about the possibility of a disease like MIC.
Right. So while we are discussing the diagnosis, the cardiac manifestations form a very important part and parcel of this condition. So I would like to ask Dr. Devadatta what has been her experience, and to go further, whether there is any difference in cardiac manifestations of Kawasaki disease versus MISC.
Thank you for the question, and thank you for having me here today. Usually what we have found is that the Kawasaki disease, there is more of aneurysms common in Kawasaki disease. Am I audible?
Yes, yes, now you are.
Yes. Yes. Giant aneurysms were more common in Kawasaki disease. However, there were less of aneurysms in cases of MISC, where it was more of a mild to moderate inflammation of the coronaries, going up to maximum of 4 to 5 Z-scores. But what MISC had more commonly was a severe dysfunction, severe LV dysfunction, which improved very rapidly after giving the IVIG. And that in Kawasaki disease, the incidence of Kawasaki shock syndrome is rare, is much rare, that presents with hypotension and cardiac dysfunction. Also, could I share my screen if the time permits? If you allow
Please.
me, I can show you a few pictures. If is my screen visible?
Yes, doctor.
Yes.
Yes. Just if I could show you that we had this, because a picture shows like speaks 1,000 words.
Deba, you could go to slideshow. Yeah. Okay.
Yeah. Thank you. So this was a 10-year-old boy who was overweight, had fever for 4 days, and had that typical maculopapular rash, diarrhea, and tachycardic tachypneic, maintaining low, just about 92% SATs. And the COVID IgG was sky high, and the inflammatory markers were high. This child had this is the LAD, which is showing marginal, say about just +4 Z-scores with hyperechoic borders and an irregular inner margin. The function was normal of about 70%, 65%, like that. And after giving IVIG, that hyperechogenicity of this in the perivascular region, it sort of comes down in about a week. But if I can show you the covers in Kawasaki, this was a case of a giant aneurysm. You can see this is the LMCA, which is hugely dilated. And also this is the LAD, and this is the thrombus, which is present here. And so these are the difference that we can find. Overlapping features such as pericarditis, pericardial effusion, those may be found in both. And this is basically a comparison of the MISC and the Kawasaki disease, and showing whatever I said right now, that is sort of enumerated over here.
So, as far as age is concerned, MISC is in a higher age group compared to Kawasaki, but does it become difficult then to diagnose MISC in younger age group? Because they're...
Yes, definitely. In the younger age group, the children come with fever with rash. And fever with rash has got a huge number of differentials. In our part of the world, it's difficult to differentiate it from dengue or scrub typhus or anything. So we will depend on a lot of lab values for that. And there may be also other diseases like Sogia and all. They may also present with fever with rash also. So we really have to keep an open mind and be really vigilant about the progress of the disease. MISC children are usually a little more toxic, and if they present with hypotension and they are like presenting with dysfunction, then definitely our first diagnosis in this situation would be MISC. But definitely that would be a diagnosis of exclusion as well.
In what percentage of cases was the COVID antibody negative? In what percentage of cases of MISC?
We found in all our cases, which we had found, all cases where MISC were COVID IgG positive. Yes, all of them had COVID IgG positive. There were 2 cases where it was both positive, like IgG positive as well as RT-PCR was positive in 2 cases.
Okay. Thank you, Doctor.
Thank you.
Dr. Walid.
Yes, sir.
Yeah, my question to you, just now we were talking about Kawasaki and MISC. Is there any other differential diagnosis that, for example, a patient coming with neurological deficits,
Dr. Diari, you allow me.
Or coming with thromboembolic phenomenon, for example, do you see for such a patient? And what is the youngest case you treated? Because we know you have a vast experience in treating MISC from Dubai and Northern Emirates. So what's, if you can recall, the youngest child you treated with MISC?
You know, if I could recall, I think 1 month old or 3 weeks old with MISC. But I would like to comment here, you know, in the temporal relation with COVID pandemic, the CDC recommended that any patient presenting like Kawasaki to be reported as MISC. Simply because most probably now we know it is community-acquired infection. Even if you don't have positive antibody or PCR, still the patient could have COVID-19, particularly in children. So my opinion here, to be on the safe side, make the diagnosis as MISC rather than Kawasaki disease. Though still I have seen colleagues, they say I have patients with Kawasaki disease. As a matter of fact, this is MISC. So no more Kawasaki disease by labeling as such in the temporary relation with this COVID pandemic. For the differential diagnosis of MISC, if you go to the case definition, they will say, exclude toxic shock syndrome due to strep or staph or bacterial septic shock, which these are the differential diagnoses. But as my colleague just mentioned, it depends where you are practicing and where is the patient coming from, because many diseases can give this quote-unquote cytokine storm and fulminant shock or similar to MISC. Maybe I mentioned to you briefly the day before yesterday, we have a patient, if you allow me to present it briefly. I will, on Wednesday, an 11-year-old African-American child who lives in the United States and went to Kenya with his auntie, stayed there for 2 weeks, coming back, and he started to have fever for 3 days with headache, abdominal pain. He presented to our emergency room with shock. His blood pressure was very low and he went to boluses. And then I was called to go and see the, can you see the slides?
No.
Oh, okay, I don't know.
To share your screen.
I have to share the screen.
Down, yeah, the green bar, the green icon, share screen, down.
Yeah, I forgot to share the screen, yeah.
Yes, we can see.
Can you see?
We can see, but just make it slideshow. Slideshow up.
The view might be having that.
Or slideshow.
Up, doctor, in the orange bar.
More maybe, no.
Slideshow.
I have to drag this here and they will go to the slideshow.
Yes.
Yeah. Yes.
Thanks for directing me.
Got it.
So
not this one. Not this one.
Not this one. Oh my God. Anyhow, I will not waste time. This patient, new share. Maybe we'll go to the new share. Where is the patient? Where is the, yeah, here. This one, right? Or this one? This one.
No problem. You can just.
No, okay. This patient, when I saw the patient, he was so lethargic, severe meningeal irritation signs, muffled heart sounds, respiratory distress, marked tenderness over the abdomen, particularly in the left upper quadrant. And there was a history of rash. And I would like to show you the rash because it is really a new share. I would like to show you the rash. Meanwhile, I'll let you know, in Kenya, the patient was in Kenya, and that's why, it is very important always to look at what the endemic diseases in Kenya. So quickly, as we know, in Kenya, malaria, Lyme disease, rickettsia, TB, leptospirosis, and all of these, can give this kind of clinical picture. Lyme unusual to present like this, particularly he has the skin rash, typical of erythema chronicum migrans, which is early stage of Lyme disease. And when I took the history, he was playing with a dog in Kenya, and the dog has ticks. But rickettsial disease definitely can give this presentation. So here, for example, in the differential diagnosis, meningococcemia or meningoencephalitis, CNS infection, bacterial septic shock with meningitis, meningoencephalitis, rickettsial disease in the differential diagnosis, of course, MISC in the differential diagnosis. So many differential diagnoses can be in this patient. But again, if you go to the first question that you asked Dr. Jerry about definition of MISC, or when you make the, or when you think of MISC, and the first statement that if you have patient in shock or sick enough or shock or pending shock, make sure you are dealing with MISC until proven otherwise. This is in the temporal relation with COVID-19. So having muffled heart sound, hypotension, not responding to boluses, you have multi-system, you have the CNS, you have the respiratory, you have cardiac, abdomen, and urine analysis showed RBCs. This is even before knowing any labs. This is MISC until proven otherwise. So what I did, we asked for urgent echocardiogram, and I started high dose pulse methylprednisolone even before the echo. I told them, do the CBC and other markers and blood culture and start IV cefotaxime, vancomycin high doses, and give also IV doxycycline. Why? Because those are life-saving. I don't want to be fooled that this could be rickettsia. I'm not practicing in Kenya, but I know rickettsia is there, and rickettsia sometimes can give you similar picture. Particularly there was skin rash. So this is a very important case. So we give IV methylprednisolone, echocardiogram done, and as my colleague mentioned, one of the differences in cardiac manifestations between Kawasaki disease and MISC is more left ventricular dysfunction in MISC. So this patient have or had low ejection fraction as well as mitral regurgitation. So we admitted the patient to the ICU. The other issue here, LP and CT and MRI, this is waste of time when you are dealing with really very sick patient who could die. I elected to present this case because this is very unusual case. You have on top of the differential diagnosis here, tick-borne diseases that we don't see. And as mentioned in the aerial session regarding the vaccinations, the world is a small village. In no time, wherever you are in the X point in the world, you can be on the other X point of the world. So
Thank you. Dr. Parveen Khindani and Dr. Asrar.
Yes, doctor, we'll be moving on to the...
Yes, we will move just Dr. Dibata.
Dr. Kalpana, please, because both of them...
Dr. Dibata was raising hand for to make comment, and then we will go to the ICU and
management.
Management. Yeah, Dr. Dibata.
Hi. Thank you. I won't keep you for long, but just to mention that in the recent literature, especially from papers from Vellore as well as PGI Chandigarh and Thiruvananthapuram, it was mentioned that though dysfunction was a major presenting feature, however, almost in 80 to 90% of the cases. However, in our case, in our hospital where we saw almost 63 patients, of them it was the adolescents and slightly older children who presented with dysfunction. In infants, it was more of the coronary involvement of mild to moderate aneurysms. And there were 2 cases where we had to get infliximab, and in both of them, their cases, it was they were infants. So I think infants have a tendency to get more of coronary and more kind of a IVIG resistant disease.
Right. So now we would like the input of the 2 intensivists, that when MISC is diagnosed and these cases are presented to your ICUs, what are the challenges you face? How do you go around those? So Dr. Asrar and Dr. Kilnani, you can comment on those.
Yeah,
I'll let
so I will-
Dr. Shrag go
well,
first.
I was going to say Dr. Praveen go first.
Yeah, I'll just briefly talk about, as Dr. Devadatta mentioned, that we are seeing more adolescents who have come in post-COVID. There has been a history of COVID, and most of them have generalized swelling. There's a poor cardiac function. There could be an effusion, and there could be almost like a polyserositis kind of a picture. We also see in dengue, but because post-MISC, what we have been seeing is that these are the patients now having hypotension or having respiratory distress or need for oxygen. These are the ones who are indicated to be admitted to the ICU. As our hospital protocol at the Children's Hospital is that we do not give IVIG on the pediatric floor. So some of these kids who may not have been that sick but needed IVIG were also brought to the pediatric ICU. So our challenges were mainly close monitoring of these patients for cardiorespiratory status, making sure their albumin wasn't too low, because low albumin is associated with worsening edema and worsening pulmonary edema. So overall, as we have now talked about in ICU for the past 15 years, that if you are more than 10% fluid overloaded due to any reason, whether by fluid therapy, whether by leakage, you have a high chance of morbidity and mortality. And then on top of it, when you have a cardiac dysfunction, especially of the kind where you have STT changes because of coronary aneurysms, ischemia, I think that puts you at a further risk. I'll let Dr. Asrar add to it.
Thank you, Dr. Kalani, and thank you to the esteemed panel. It's really amazing to have such involvement. And Dr. Devadatta, thank you so much for, and Dr. Kalani from coordinating from abroad. I actually herald Dr. Devadatta's sentiment. And we've had an infant who needed infliximab, had coronary involvement, and unfortunately developed morbidities related to the coronary artery dilatation. And we've had the other extreme, we've had other issues as well. I have one slide to show, just to share some of the difficulties. As pediatricians, if you're out there and you're wondering, a patient comes to you, what do you do? And what can you do when you have a patient coming through the door? Mr. Tawfiq, thank you very much. If you could just put this up on, brilliant. That's so kind of you. So this is an example of a case, a 7-year-old admitted with a 3-day history of fever with diarrhea and vomiting, and also was post-strep swab positive with the highest CRP. Some of my pediatric colleagues, as usual, said, this is one of our usual cases, maybe a sepsis, and maybe toxic shock, who knows? Let's just treat supportive care. Let's give early antibiotics, and let's see how things move along. Despite this, and in this child, the child developed a macular papular rash. There was a history of COVID previously as well, though on arrival, COVID negative. And one of the difficulties, maybe you're having the same difficulty as me. We can't get the IgG result for the COVID IgG. So we don't know, could this be a post-COVID phenomena, etc. So you just have to do your best. And unfortunately, this child continued to have his spiking fevers. And then about 3 days later, we were called, the PICU team were called because the child was getting sicker. His heart rate had worsened. He was now hypotensive with a gallop rhythm and cold in extremities. Now it's okay because the pediatricians can call a PICU in-house. But if you're not in-house, if PICU is not in-house, in the UAE, what will you do? I'm sorry, there's no interaction here, because this is, we're talking through the streaming system. But I really do feel for many pediatricians who call me on the other side of the phone and say, we have a child who's sick, who's hypotensive, but he's awake. And what do you do? So I will just give you, it'd be nice to have the interaction we don't have. And just for the sake of time, basically the child is awake. So one of the other challenges is how do you optimize blood pressure. Also, we have signs here of cardiac dysfunction, and as we later on did the echoes, we did see diminishing cardiac function, 40% ejection fraction initially. And you know, sometimes the children are quite well worked up when we get a call. The BNP is usually undertaken, CRPs are usually high, procalcitonin and ferritin. And as in this case, the ferritin and the fibrinogen was also high. And I noticed from Dr. Debata's slide, fibrinogen is low in toxic shock and high in this scenario. So we ended up giving 5 mils per kilo of volume, just enough to keep the child ticking over. Then one of our team, we mildly sedated the child, local anesthesia. We got a central line in. Prior to the central line going in, what can you do as a pediatrician? You can give inotropes peripherally through the best line that you can get peripherally, okay? But one thing, you must dilute the inotrope by 10 times. So dilute the inotrope, give you some time, and then if you can, call a colleague within your facility, and the child at this age, fortunately, we don't see as many infants. As I said, coronary dilatation is the issue. Here, we have problems with myocardial dysfunction. So maybe somebody from your own anesthetist can come and give you a hand. An ultrasound that they would use in an outlook, they can pinpoint the arteries, the veins, and do the and get the inotropes in. And so this is what we did. We got the inotropes.
And just to add to it,
yes, Dr. Pravan.
Choice of the first inotrope, as per now PALS 2020 guidelines, is epinephrine. So there's no confusion about it. Let's not talk about whether you will do dopamine, dobutamine, nor epinephrine, anything. Epinephrine, easily available, safest to do it 10 times dilution and run it through a peripheral IV. That is the best life-saving thing you would do before the kid even gets to the ICU. Yeah, Asrar, sorry to interrupt.
Yeah, no, that was a really great interruption. And I like we have the interaction here. Dr. Praveen, there might be other points as well, because these are quite difficult cases. You know, pediatricians are calling us and saying, you know, we need help. But it is possible with the expertise locally, you know, to make an effect. Do you not agree, Dr. Praveen?
Yes, I totally agree. And I think one more thing, as soon as the patient hits the ICU, and sometimes it's the hospitalist who's taking care of it, and, you know, intensivist hasn't got there, same plain principles of A, B, C, airway, breathing, circulation apply. MISC is nothing different from that. It's a shocky patient with a cytokine storm. And the cytokine storm, which is leading you to all of these rashes, high ferritins, low albumins, high triglyceride levels, all of those are going to get fixed with suppressing the cytokine storm by methylprednisolone or IVIG or further infliximab, those kinds of things. And as soon as you have started the initial therapy of giving small amount of fluid bolus, not large, and this is one thing, because you do have a leaky capillary issue here. And if you give too much fluid, you can possibly cause more fluid overload and lead to intubation. So that is one thing that I think we have learned, that giving small amount of aliquots of fluid boluses, considering the cardiac dysfunction also, I think you can get away very nicely with starting a low dose inotropes and keep monitoring the urine output, and don't plan to have 2 to 3 ml per kg. 0.5 ml per kg per hour urine output is enough and gives you a good, nice balance of intake and output, as long as you are continuously monitoring the cardiac status, the respiratory status, the saturations, and then we try to get the central access.
And what's key, Dr. Praveen, also is the drugs used for providing a mild bit of sedation. We use ketamine in this case, and it was very, very good, 1 milligram per kilogram. But Dr. Praveen,
and ketamine is least hemodynamic disturbance, tends to maintain your blood pressure, also raises a little bit of epinephrine level in the body. So ketamine is the safest sedative in a shocky patient.
Dr. Praveen, one of the difficulties is you have an awake patient and you have a family that's very upset, and you have a needle and you have a central line to put. It's a real challenge. Any tips for our pediatricians What can we do? in this
I think one of the things that has worked really well for me is there has to be one person who can take care of the family and one more person to take care of the patient at that time, because as soon as or else how I will split the role is, I will first take the patient's relative outside and say, give me 10 minutes. I'm going to go in, stabilize, and be back. And it will take one needle stick because I have to get the IV. And these are the kinds of things that is necessary evil. And I think counseling goes a long way. And sometimes the family says, no, I want to stay with the patient and I don't want to stay outside. That's the challenge that we get, where I think one of our nurses, senior nurses, all of these have a great role to play, because if they're hand-holding the mom or dad and just sort of reassuring them, then the doctors can get to work, because you can't work in the presence of the family, which is already shirking that as soon as you put the needle on, they start shaking. So what we try to do is reassure them, take about 10 minutes from them and say, I will come and get you. And I will take you back to your child so that you can interact. I mean, that counseling has worked really good for us.
I absolutely agree. And the difficulty we had was this now patient was day 3, 4. And they were saying, well, you've had a chance to change the course of the illness. Things are getting worse. What are you guys doing? So, it's a challenging situation.
All that counseling, I think those challenges are, if you go over the course of the illness in general and talk to them that on an average, 4 to 5 days worth of this therapy will make it reverse, and very few kids will get into a reversible phase, although the truth cannot be hidden. But we have to say that usual courses like that we do get response in 3 to 4 days. So please be patient with that. And you may have come at the worsening of the illness. It might get a little worse before it gets better. And some of these lines tend to work.
Dr. Dabata has got a point.
Thank you. Just wanted for discussion. In this case, like you said, the blood pressure is low, but how much that is, we are not measuring the invasive blood pressure, it is a non-invasive BP. So how much, my question would be like, how much of that would be actually reliable? We do see the trend, but at that point of time, I think more of the peripheral features of shock, clinical features, urine output, those would be more important. And if Dr.
As well as
Kalpana
non-invasive, non-invasive people, all these added together.
These. Sir,
Yeah.
if you could just elaborate on that.
Yeah. I believe the trend is extremely important. Child's been in hospital for a number of days. So in this case, we had the value of the trend of multiple readings and seeing things worsening. And I think early intervention is very key as well. I think this is an important point, Dr. But the patient's been inside the hospital, and trying to get the diagnosis early and think about MISC early as well. And we heard how the Americans are saying that every patient who is query Kawasaki is actually MISC. And I think we should be high on our index of suspicion. Another important point, I think, with Dr. Praveen, I think you will agree, if you ever have to intubate these children, intubation itself is also a major stimulus, and you have to give drugs to intubate. That can also affect the LV, can aggravate LV dysfunction as well. These children are extremely challenging for intensivists, let alone pediatricians.
And the agents that we use, generally ketamine, fentanyl, these are some of the cardio-stable drugs that can be used, and use a muscle relaxant because this is a hefty adolescent child, and you're not supposed to just shove in the tube by sedation. Sedation plus muscle relaxation, controlled environment, and intubation, most of these kids can be managed successfully.
Then of course, the important concept is also NPO as well. You're thinking the child is deteriorating, keep your child NPO as well, get the central line in, minimal bit of sedation, under invasive technique of using a ultrasound probe. I think these things will all help. Unfortunately,
Asrar, just one thing also I would like to say is, before we jump to intubation, please always consider the NIV measure the proper size fit of the mask. And many of the kids who we have just shortly supported with NIV, mild dose of inotropes until the IVIG, I mean methylprednisolone and IVIG, whichever we use, started showing effect, and we are able to wean off. So not necessarily jumping to intubation is one thing I think we should consider.
Yes, and even on this group, our team have presented use of non-invasive ventilation, with Dr. Sarab and company. Kindly, we did a workshop on that. And vapotherm is something which is not even a mask; it's the high flow system. It's been we found it very useful in this older age group who are slightly compliant.
Yeah,
and that's very helpful.
And so with all due regards to Dr. Devadatta, the cardiologist who may or may not be available at 2 a.m. Now, what we have done is many of the ICU doctors are learning to assess ultrasound. With ultrasound, you can assess lung water, cardiac dysfunction, presence or absence of pericardial effusion, and size of the inferior vena cava. If it's collapsed, you need a little more fluids. If it's dilated, you need a little bit more inotropes, especially if it is associated with poor contractility. And mark my words, 5 years later, most of the intensivists will be good at doing ultrasound also. And you're not required to give a proper ejection fraction, percentages, and all those, because cardiologist's job is definitely, to give you a precise answer of the cardiac function. But during the middle of the night, knowing a poor cardiac contractility, it doesn't take a very big expert to say that cardiac contractility is good or bad, because simply the heart is contracting like this versus contracting like this. Even I can tell, not being a cardiologist, that this one is better, this one is less. And you will see the ultrasound pictures on that. Pictures worth 1,000 words, and we can do that.
We had a session. Dr. Sakar was there with Dr. Iman. One question was there, the point of in Algeria they are doing. Discussion was after 5 years, the stato will be replaced by this device, which
You're
is
right.
Yes. Dr.
A smartphone and a butterfly probe.
Yes.
Dr. Asrar and Dr. Kilnani, I have a question now. Is there any predictors to say that to the general pediatrician or to the emergency doctor that this patient might need ICU admission? To give an advice that this patient with MISC, he might need admission to the ICU.
Anyone, because as a routine, every patient that we suspect MISC, we get an echocardiogram. So anyone who is showing coronary dilatation, poor cardiac function, pericardial effusion, that's one criteria. But chemical criteria wise, if you have a very high ferritin, which tends to be an inflammatory marker, which does equate to almost IL-6 levels, which we don't routinely do, but it is a good inflammatory marker along with the CRP. So patient who has a very sky-high CRP, sky-high ferritin, and having a sick look. And I think this sick look needs to be defined. Poor perfusion, generalized edema, and any evidence of respiratory distress. Because these are the three things. Poor perfusion means some amount of cardiac issue, and the respiratory distress, just pure, simple tachypnea, and patient being anxious. These are some of the clinical criteria along with chemical criteria that I would say consider to be in ICU. If our hospital for IVIG itself, we admit them to the ICU because there could be a reaction, there could be monitoring for 24 hours. Yeah.
Dr. Diari, can I add something?
Leukocytosis or leukopenia? Yeah, please.
Dr. Diari?
I think so. Yeah.
Yes,
leukopenia.
Dr. Diari?
Yes, please, Dr. Waleed. Go ahead.
Yeah. I would like to add this, which is very objective factor, is the absolute lymphocyte count. If you have any patients with absolute lymphocyte count less than 500, even if the patient looks like a rose to you, make sure you have bed in the ICU.
I agree.
It has been,
Oncologists have
it has been shown
guided us on
that
this. Right.
less than 500, it has 3 folds more that patient will be admitted to the ICU, and 2 folds more that this patient will have kidney injury. So if anything, I will have to look and to pick is I will look at the lymphocyte count. Less than 500, make sure you have backup bed in the ICU.
And Doctor, I would just like to make one statement, and this is where I think Dr. Asrar will agree with me also. Hector Wong has been doing a lot of research on genomics, and this question comes up all the time. Which is the patient that's going to live? Which is the patient that's going to die? Why both patients with the same severity, one died and one lived? There are lots of such answers that are going to come from the genomics as to the susceptibility of a particular patient based on their genetic markup. And I'm not saying based on genomics. I don't even want to know someone's genomics because I don't want to reduce my effort for one versus other. But I think this is a very, very fascinating information that's coming up, that when you do genomic analysis of a certain group of patients with equal severity of illness, like a septic shock, one doesn't do well, one does well, and given the same exact treatment. So there's just a thought that I want to leave you all with. We don't have any double-blind randomized studies, but there's lots of research going on.
Right. Before we move on to the research aspects, which,
may I just add one important comment? I think age is very important criteria. I think Dr. Dabata also had mentioned earlier about the infants, and I really worry about the infants with MISC. Please, Dr. Kapner, over to you.
Yeah, no, I just wanted Dr. Ghassan to let us know, because Tamam Hospital has come up with their own guidelines for treatment management. So it would be interesting to just see that before we address the issue of prognosis and the research. And then I think it would be time to close the panel.
Yeah, we can encourage it. We can encourage the time. Discussion is very good. We have time.
Okay, asking Dr.
I
Ghassan.
like you.
Thank you, Dr. Surab.
Great. Let me just to share my slides with you. I will be talking about the management. This will include, perhaps you'd like me to talk about the investigations as well, or the management as the patient.
Your voice, Dr. Ghassan.
Sure, doctor. Whatever you think is important for us to know, we are here to listen to you.
Yes, please.
Last session is good. Everything you can show.
It is unlimited.
Yes, yes, yes. That is why we have kept the most important the last.
Are you sharing any slides, Doctor?
I'm trying to, but...
Okay. Okay.
Kalani, nice to see you.
In the meantime, there are two audience questions. I think I'll just read them out. One from Dr. Mustafa, who says he has noticed a lot of times children diagnosed with MISC developing bradycardia after treatment. What is the cause of this bradycardia? Is it IVIG or corticosteroid therapy or other causes? Second is from Dr. Bhandari, who feels that he has seen many cases presenting with very high CRP, PCT, high LDH, high procalcitonin, responding well. Can it be mild variant of MISC? So are there any mild variants of MISC?
Yes, of course they are. And other question, Dr. Devadatta can answer, the bradycardia one.
The bradycardia, if I could, I'm sorry.
Yeah, please.
Please
If,
go ahead.
the bradycardia, I have seen this frequently in my patients, and the reason is the steroids. Once we taper or we stop, the bradycardia resolves. So the issue of the steroid is causing the bradycardia, not the IVIG.
Is that documented? Is that that fact that steroids are related to bradycardia?
Yes.
Are there any published studies? Okay. All right.
Actually, our experience has been contrary. We have seen more of tachycardia, especially sinus tachycardia. And we didn't come across much incidences of bradycardia. But it could be part of the myocardial inflammation, or it could be part of inflammation of the conduction tissues as well.
True.
So we need to keep an eye on that and do a regular ECG to see if there is any heart block or other conduction issues developing.
Actually, you know, we started to see this bradycardia after improvement and being on steroids, and there is improvement in the ejection fraction, and there is no blocks. And the moment we stop the steroids, you know, bradycardia resolved. It has been documented that steroid can cause bradycardia, and we have witnessed this in our patients.
Sorry, can you see my slides or not yet?
Yes.
We can, but
Make it slideshow, please. Make it full.
Yeah, it's taking part of the screen only. Yeah, slideshow would do it. Yes.
Sorry for that. We are coming to the right slide now. Okay, so basically, when we encounter a case with maybe suggestive of MIC, so on the left corner, as you can see here, this is the child. He might go into the case definition of MIC, and with all the talks about how reliable is the case definition in terms of filling here. So once the patient goes into this direction, the next question is to, if he's not filling into any of those, so probably we need to think about something else and to continue the evaluation as per a standard of care, but we still need to monitor for the possibility of MIS features and the epidemiological link with SARS-CoV-2. Now, if the patient fits into this direction, where the rash, the inflammation, the fever, is the any other causes? Again, this questionable things about the possibility of MISC. So if other things need to be considered and evaluation, then again, we consider evaluation for other overlapping diagnosis of non-MISC, which could be infectious and non-infectious causes. Now, if the other causes could not be excluded or cannot reach a certain thing that can explain the current presentation, then we label the child as being a child under investigation for MISC. And we start the investigation here. The thing that is very important now, if the child is coming with a life-threatening condition where the shock is of unknown etiology, and I totally agree with what Dr. Walid mentioned and our colleagues, that we have to be a little bit aggressive with those patients and we need to approach them as being as an MISC until proven otherwise. Hence, we do the whole panel related to MISC, and I would suggest also starting the treatment for MISC, awaiting these results. It's not necessarily to wait until you get the final panel out, but it would include the tier 1 and tier 2 investigations. Now, if the shock of unknown etiology, the patient relatively stable, he's not in shock, then here we start the diagnostic MISC by doing the first line approach, which called the tier 1, where we do the CRP, the ESR, CMP, plus minus the SARS-CoV antibodies plus the PCR. And then we move to the next when the results are back. And what are the results? Usually it is the CRP and the CBC that tells a lot, because having a high CRP more than 5 or an ESR more than 40, and at least one of the lab criteria, which include either, as Dr. Walid mentioned, an absolute lymphocytes less than 1,000, so it's a lymphopenia, or a thrombocytopenia, low sodium, neutrophilia, or hypoalbuminemia. So probably this child likely to be a case of MIC. Here we introduce the tier 1, tier 2 investigations, which include completing the panel that would include the troponin T, precalcitonin, ferritin, coagulation profile, D-dimers. The cytokine panel, we do here IL-6 and of course serology, ECG and echo. Now, if the labs are not consistent, I mean the CRP and ESR, we still need to keep MIC at the back of our mind, and we know that the patient is relatively stable. So proceeding with the further evaluation and keeping the MIC and the link with our SARS-CoV-2 in process. Now, these are the clinical criteria that need to be taken into consideration when you talk about MISC. So here the rash, the GI symptoms, the mucosal involvement, the conjunctivitis, and the neurological symptoms. As we know, MISC is different from Kawasaki by having also a CNS where patient can come with altered mental status, encephalopathy, and even focal neurological deficit. For the treatment, I will skip this. So here, once we have a child who is hospitalized with MISC, we categorize our patients into 3 categories. And the classification is based on clinical and the need for inotropic support. So basically, we have a mild case of MISC, we have moderate cases, and we have severe cases. And these are, the classification will be the basis for selection, the aggressiveness of treatment, initial protocol for the treatment for our patients. So when we talk about mild cases and is this patient going to be admitted to PICU or a regular floor, this is another debate. However, in mild cases, you don't expect that patient, he doesn't have any need for vasoactive requirements. They have minimal or no respiratory support and or minimal organ injury. Now, what do we mean by minimal or no respiratory support? It's different, but I believe having less than 2 perhaps liter per minute for those who are less than 12 years and more than 6 for 12 might represent a need for, it represents kind of inquiring for respiratory support. And here the mild case might move into the moderate case. Now, if the patient classified as mild case based on these things, what we do, we start those patients on IVIG 2 grams per kg, alongside with 2 milligram per kg per day with methylprednisolone, aspirin for all patients, 3 to 5 milligram per kg, and here we can add the low molecular weight heparin based on the contraindication of using the aspirin plus minus other criteria that has to do with the D-dimer levels or the age of the patients, as well as the presence of central lines. And most of those patients less likely to require inotropic support unless they have something in the heart that would push us to use the enoxaparin as prophylaxis. Of course, the proton pump inhibitors for patients, and we start most of our patients on broad spectrum antibiotics awaiting culture results, and these antibiotics will be discontinued once the cultures showed no growth. For patients who have a moderate presentation of the MISC, and here we classify them based on having a VIS or vasoactive index score, alongside with increased or significant supplemental oxygen requirement and or mild organ injury. Those patients, of course, likely to be in the PICU because they would require some kind of inotrope plus minus vasoactive agents. So our protocol says that those patients will be treated with dose of IVIG 2 grams per kg, and we are using here a 1 single dose of, we call the pulse steroid with 10 milligram per kg per day for 1 day. This dose then switched to a regular dose, which is 2 milligram per kg per day. The chances of using low molecular weight heparin prophylaxis and aspirin actually would be high in those patients, unless we have a contraindication to use the aspirin when we have a severe thrombocytopenia or other contraindications. And the broad spectrum antibiotics, as mentioned, all the patient will get it awaiting the results of the cultures. Severe case, again, the VIS score usually more than 10, patient likelihood maybe they will have a non-invasive versus invasive mechanical ventilation, severe organ injury alongside with ventricular dysfunction. For those patients, we do IVIG, of course, for all patients, 2 grams per kg, but those patients will be pulsed by using a high dose of methylprednisolone, 20 to 30 milligram per kg per day, and those could be up to 3 days. Depends on the improvements of the patient and the whole thing. Likely those would require both aspirin and low molecular weight heparin or enoxaparin, PPIs alongside with the antibiotics. Those patients will be monitored during and after the therapy, and we evaluate for response to decide if we need to intensify the therapy according to response. So intensification happens by defining the patient, the fever not resolving, at least for 24 hours and more post-treatment. If the ferritin remains high, more than 1,000, worsening echo findings, and sometimes even to the assertion of pediatric infectious disease to decide if the patient really not improving according to the general condition. And this can be seen as well in terms of the findings. For example, the rash, the conjunctivitis, the general condition of the patient when he's not moving. So probably this patient is not responding to the initial or the first line treatment. Then we move to intensification of therapy. For both those who were treated as mild case we may go for a pulse steroid or may elect to go for a biologic. Most likely, as per our experience, we go for pulse steroid and then move to anakinra if required, because most of the time these cases are mild and less likely that they would progress into a very severe course. For moderate cases that they did not respond to IVIG plus the pulse steroid, then we go for a higher dose of pulse steroid. Instead of 10, we go to 30, or we decide to go for anakinra, and both approaches are acceptable. For the patients who have severe manifestation with a very bad condition, so most likely we do anakinra immediately, or we decide into going for infliximab for refractory cases. My understanding that infliximab can be used in most cases where MIS-C, except cases who present in form of macrophage activation syndrome or HLH-like, where the infliximab should not be used. This is basically the algorithm that we are following, and I would like to say that the approach to patients with MIS-C all the time, it's a multidisciplinary approach. It's not single physician. It's not only the intensivist or the pediatric infectious disease. Here we have the cardiologist, rheumatologist, clinical pharmacist, hematologist. Many people actually contribute to the care of patients until he, move from the severe case, from the acute status into the stabilization. And we end up, tapering whatever we used on those patients over a period of time that usually designed based on the clinical presentation, the severity of the patients, in terms of aspirin, in terms of steroids that continued. And the tapering period is, as I mentioned, is different from one patient to another. It might go for 2 or 3 weeks, sometimes even longer. Those patients also, as I mentioned, they will be followed once they are out of the ICU to the regular floor and after discharge, followed by both infectious disease and our cardiologist. So basically, this is what we do. This is our algorithm, and if somebody has a question regarding this.
Dr. Ghassan, thank you for this really guidelines. And my comments here, we have our own guidelines at Al Jalila Children's Hospital, more or less, the same. The difference only that, I believe, MIC is very aggressive disease based on the underlying hypothesis. This is very bad cytokine storm. So for the mild, first of all, the comments here, the use of aspirin. I don't use aspirin, neither high dose or low dose, except if the patient clinically looks like Kawasaki disease, like conjunctivitis, the lips, the picture of Kawasaki disease, then we do a low dose aspirin from the beginning. Or if the patient has dilated coronaries, we use low dose aspirin. Other than this, we don't use aspirin at all. We use enoxaparin as prophylaxis or treatment according to the condition of the patient. If he has high risk factors for thromboembolic phenomena, or if the patient has central line, left ventricular dysfunction, or patient developing clots, then we increase to a treatment dose. This is regarding the aspirin and enoxaparin. Regarding the moderate and severe, to be honest with you, usually with the moderate, I am seeing the patient is trending down, I start with high dose pulse therapy. The moderate and severe, the first dose will be high dose pulse therapy, and usually I go with 30 milligram per kg. Over 1 hour, maximum is 1 gram. And for the moderate, we'll evaluate the next day. If the patient responding, we will go to the 2 milligram per kg per day methylprednisolone, or equivalent to the equivalent to Dexa or prednisolone. For the severe kind, we give the first dose of the high dose methylprednisolone, and usually I go with the 30 milligram. And if the patient really sick, we'll start anakinra right away on him. We will not wait. Our goal here is to hit hard from the beginning. We will not leave things for the chances. So we'll start with the anakinra. If the patient really in shock and requiring intubation or multiple agents of inotropes or high doses, etc., we'll start high dose and anakinra. And then the next day we will sit and see the progression and the improvement. Usually we give minimum 3 days of IV high dose methylprednisolone. Sometimes we go to 5 days high dose methylprednisolone, and accordingly we switch to oral and we taper over 3 weeks. Anakinra, after improvement, we will decrease to 2 milligram per kg per day, and we are doing our best to wean him off before discharging the patient. More or less it is the same. However, our approach is more aggressive.
German style, hit fast, hit hard.
Exactly. We are also Germany.
Yeah.
There's a comment.
Heat hard and de-escalate.
Hit hard and hit fast.
Heat hard and then de-escalate after getting the reports.
Yeah, hit hard from the beginning.
And hit fast.
Yeah, but we are hitting the time now is 3:30 now.
Yes,
There are two comments here, Doctor. One from Dr. Mihir Sarkar, who has written that role of IVIG in patients without organ support is controversial, conflicting results among different studies. And the other one from Dr. Ranjan, who says that he's come across certain pediatric hematology cases which are being mistakenly treated by pediatricians as MISC.
Dr. Sarkar is online with us.
Yes.
He can join and give comment.
Maybe he's not as a panelist, that's why, but he's written his comments. So
yes.
You know, my stand on this, IVIG, you know, it is the standard for treating of MIC plus the steroid. And this is the standard goal of treatment for Kawasaki disease. And to me, MIC is nothing but a severe variant form of Kawasaki disease. So the only move from this is we don't give second dose of IVIG as we used to give with Kawasaki disease if there is no response, what we call the IVIG resistant treatment. Initially, when we did not have much experience and people didn't have much studies, we used to give 2 doses of IVIG, but now they are staying away from repeating the second dose of IVIG and just go to the biological treatment in addition to high dose pulse therapy.
Just few days back, article came, those who are resistant in place of second dose of IVIG give infliximab. Of course, infliximab 2008 came. Since 2008, it is yes, Doctor.
Agree with you. We are at Al Jalila. We use anakinra, to be honest with you.
Actually, yes. Actually, recently there was a very amazing 2-day conference on Kawasaki disease conducted all over the nation and world, almost webinar by PGI, arranged by PGI Chandigarh team, led by Dr. Surjit Singh, Professor Surjit Singh sir. An amazing workshop, and there we came to know that Dr. Jane Burns, who's like the pioneer in Kawasaki disease research in USA, she and her team were giving more of, especially in infants, there has been the concept of intensification of therapy. When infants are being diagnosed, they are given infliximab and IVIG, and because IVIG causes reaction sometimes, so they are giving infliximab first, followed by IVIG. So that's kind of a paradigm shift is there.
Was introduced this in 2008. She is the head of Kawasaki in California. In 2008, she introduced. Now we are getting this thing.
To be honest, Dr. Ghassan and Dr. Walid, it is nice now in the same country you have your guidelines and your protocol, and in Jalila there is, I am sure that Dr. Asrar and SKMC, they have a different one, although it might be the same.
Dr. Diari, I think the whole
really,
issue,
we are proud that we have
MIC is a dynamic, disease. It's just like
yes.
SARS-CoV-2, and the new, research comes out to change the whole thing. So, as Dr. Walid mentioned at the beginning, some people they were using the IVIG only. Now they moved to pulse steroid, the use of biologics. So I think At some point, we might have a universal guideline, just like in Kawasaki
But
disease.
no, what was my comment that even in COVID, you see, Dr. Ghassam, all the European and American, their systems collapsed. But while we here, we adapted our guidelines and we were much, much better than them in the rate of mortality and these things. Really, I am proud of that.
Dr. Diari, I would like to commend you on this statement. And this is what I have been telling my students and my residents, and we have to generate our guidelines, not to be copycaters, because what's going on in UAE, not necessarily similar to New York, not similar to Germany. So we have to stop copy-paste guidelines, what other people they have been doing. It is time.
And it has been proved. It has been proved that we are much, much better, our guidelines, than them.
This is absolutely true. I would like, because it has been said many times, infants, the MISC is more severe than adults. We conducted a study in Al Jalila Children's Hospital, and I think it will be the largest study in the world. This is a prospective cohort study, phenotypic, genetic, and the clinical characterization of MISC in the Middle East. We included 45. I don't know, we have time or not, Dr. Diari?
Yes, sure, doctor.
Yeah, sure.
Yeah.
This is the research. This is probably the last part of our, if we can all share, even Dr. Asrar, if he's still with us, he can, because I feel that in SKMC, they have also some research going on.
Yeah, okay, let me, if I can share the screen now.
I also wanted to say
In the
something.
meantime, yes, Dr. Devadatta, you wanted to say something.
Yes, I just wanted to ask Dr. Ghassan that what are the indications for giving enoxaparin in your protocol? Because in Indian protocol, we are usually starting with aspirin in the mild and moderate cases also, and restricting enoxaparin to those with proven thrombus, those with severe dysfunction, or those with giant aneurysms. So, what is the rationale for using the enoxaparin in milder cases also?
What I know that if there is a contraindication to use the aspirin, is the only way that you go for the enoxaparin. We don't use it routinely in mild cases. So if there is any contraindication, sometimes because of severe thrombocytopenia, you may end up not using the aspirin. So you have to use something just to prevent thrombosis. And in this case, we might go for enoxaparin. For severe cases, most of the time they are in the PICU, they are having central lines, they have a D-dimer, most of the time is 5 times the normal, where the indication for enoxaparin becomes a must. So moderate and severe, probably everybody would agree that they might likely to would require the enoxaparin, but mild cases, no, of course not, unless we have a contraindication to use the aspirin.
Thank you.
I think this is a good point, because I think mild cases, to me, in our guidelines, we don't use enoxaparin and we don't use aspirin, just IVIG, straightforward. For indications of enoxaparin, if the dimer is more than 2.5, if there is left ventricular dysfunction, if there is central line, if there is risk factor, for example, obesity or family history of thromboembolic phenomena, etc., we give prophylaxis dose. Once there is a clot, we increase to high dose treatment, and we monitor this by anti-T10 factor. But definitely there is a role for enoxaparin, because from our experience at Al Jalila, not a quite good number, but a reasonable number of children developed clots and DVTs and clots at the central line. Actually, we have a child right now, and I'm really surprised. She's Indian, admitted a few days ago, and D-dimer was, I think, 3 or 5. No, D-dimer 5 or 8. So I started her on prophylaxis enoxaparin. Though she has been on enoxaparin, she developed 15 centimeter DVT, clots in her left leg. We know MISC, thromboembolic pathogenesis is there. One of it is pathology in patients with COVID-19. Hello?
Yes, doctor. You will tell us about this genomic and phenotypic.
We conducted a prospective study at Al Jalila Children's Hospital, genomic and phenotypic characterization of MIC cohort from the Middle East, and I'm really pleased to announce this for the first time. This is before submitting to the. We finalized the manuscript. You will be the first one to know about this study. We recruited 45 children who has met the diagnosis of MISC according to the CDC, and 25 control, which means the children who had COVID-19, but either asymptomatic or mild symptoms, but did not have MISC. And we look at the clinical, how can I move this? Slide share, okay.
Slideshow, doctor. Is it on slideshow?
It's not moving in my computer.
Mr. Fadi, Mr. Tawfiq, can you help?
It's not moving.
This is on his computer.
Not moving on my computer.
Looks like just a picture of PDF, not a presentation.
Oh, really?
Minimize it. You can minimize it, and then you can.
Yeah, you are moving now.
We are moving, right?
Yes, yes.
Okay, good. And the age distribution, the average is 9 years old, the average 7 years old, majority 65%, 9 years and younger. A male to female ratio almost the same, 51 to 50. So there is no much difference. Interesting majority, patients of origin majority here with MISC among Arabs comparing to other ethnicities. And this should not be a reflection of the population in at least Dubai and North Emirates. This is a clinical, before the clinical picture, GI involvement and mucocutaneous involvement were the most common systems involved in our series, 80% each. So the GI and the mucocutaneous 80% each. We find also cardiac involvement in our series 49%, which is interesting. 30% neurological. Interesting, 19 patients admitted to the ICU either because of low hypotension or shock, which is really significant. And this may be a reflection that we are accepting patients from other hospital who are really sick. But this is consistent with the literature finding that among children with MISC, 42% will go to the ICU. We found 19 patients out of the 45. They have, we did whole exome sequencing, and we found 19 children had genetic variation predisposing them to the immune genetic inflammation or immune dysregulation, mainly interferon pathway and other inflammatory pathway. So it was 42%. If the child younger than 3 years of old and developed MISC, 75% most likely they will have genetic variation that predisposing them to this immune genetic pathway. So this is really interesting. So MISC in early childhood, the likelihood to find genetic variation is really common versus more than 3 years, and this is really significant findings. As I mentioned, the genetic variation more common in Arabs than non-Arabs, and statistically significant. What also we found that children with genetic variation, they are more resistant to treatment. So we have to escalate our treatment. Though it is a small study, but it can give us enlightening about most probably there is a genomics role in developing this MISC because of the autoimmune dysregulation. This is an eye-opener for further studies, but really it is interesting study, and we need more further studies to elaborate on these findings. Thank you.
Yeah, thank you, Doctor. I think
also, Dr.
Yes.
Debadat also, others also, they have to join.
Sure.
I think
So just one last question to Dr. Debadatta. In those who are showing cardiac changes, what has been the follow-up? Like, do these children require follow-up like cases of Kawasaki as we used to do? Do they respond faster than them? What is your protocol for follow-up?
Actually, we have kept them on a follow-up. Like in mild cases, we are following them up as per KD guidelines only at discharged. After discharge, 1 week after discharge, then at 1 month, then at 3 months, then at 6 months, then after 1 year, provided things are going okay. For moderate aneurysms, it is every 2 to 3 months after the first month of checkup. And obviously for giant aneurysms, we didn't get any at all. So our experience was actually very good because most of the moderate aneurysms within the first month, they became significantly decreased in size. And they are, I think within 2 to 3 months, they came down to like mild size. And yes.
The first case from UAE is reported by Dr. Ghassan. In that, the patient had big aneurysm. And you say you didn't
Giant.
Giant aneurysm.
No. Surprisingly, we got a lot of giant aneurysms in KD over the last 3-4 years. But this would be where this will.
If I can add, I think internationally there are other 3 cases. All of them are infants where they were diagnosed with MISC and aneurysms. So probably, as Dr. Walid mentioned, the age contribute much into the cardiac manifestation.
Absolutely.
Kawasaki and MIC overlaps in terms of cardiac involvement. And I don't think that MIC is an exclusion in terms of having giant aneurysms anymore, especially if you are dealing with the proper genetic background along that side with the age. We can see cases every now and then with giant aneurysms.
And as I mentioned, those younger than 3 years, 75% in our findings, they have genetic variation. So maybe also this put them at higher risk of cardiac involvement. In addition, most probably, if we look into these cases, maybe we'll find the delay in diagnosis and the treatment.
There is one question from the pool regarding Dr. Habibullah. He's asking, after giving pulse methylprednisolone, do you continue on oral, and for how long if we are giving steroid?
As Dr. Ghassan mentioned, it depends. We are dealing with moderate or severe. If we're dealing with severe, we continue the treatment, and usually we taper over 3 weeks. So it depends on the course of the patients. Once we discharge, we taper over 3 weeks. For moderate, most probably we stop before we discharge the patient. And if we have to extend, maybe 10 days or 2 weeks. So it's variable. But the severe form that we give more than 1 dose of high pulse therapy, usually we give steroids and we taper over 3 weeks.
So at the end is MISC.
Or Rabia.
Yeah, yes, Doctor.
Another question from Dr. Rabia. Some children presented with behavioral problems like confusion, hallucination, and agitation. Is it related to the steroid or it is related to the COVID or MISC itself?
This is as a presentation or after?
No, probably after, because she's mentioning as a steroid, after steroid. Is it related to the steroid or to the COVID itself? So the presentation was not, the presentation either MISC or COVID, but once started steroid, they developed this agitation and...
You know, most probably coincidental finding, this steroids, because CNS involvement, not uncommon in patients with COVID-19. Behavioral changes also an issue. Psychological changes an issue with patients with COVID-19.
Thank you. By that we
I had 2 cases that they have optic neuritis also.
From what Dr. Walid, is it safe to say MIC is nothing but Kawasaki after COVID?
It is, you know, this is actually, I wrote review articles. I wrote review articles and got accepted in the Journal of Rheumatology. We reviewed almost 500 cases from each. And from our findings that MISC is a severe spectrum or variant of Kawasaki disease. Now we are conducting a study, just finalizing at Al Jalila Children's Hospital. We had almost 54 cases of MISC and around 70 cases of Kawasaki disease from Dubai Hospital and Al Jalila. We are analyzing them, and the finding more or less that MISC is a severe spectrum of Kawasaki disease. And we know, you know, Kawasaki disease, most probably there is genetic predisposition for this, and this is true for MISC. And they share the common pathway, which is the cytokine storm, and the treatment is almost the same.
Similar.
Big conclude.
Yes, doctor.
So,
thank you.
Thank you. It is a very, nice discussion is going. People, over 400-500 people are still with us, but we were supposed to conclude it at 3:15. I would like to thank Dr. Hassan, Dr. Walid, Dr. Devadatta, Dr. Asra, Dr. Parveen, Dr. Diari, Dr. Kalpana, Dr. Joshi for being with us. I would like to thank all the speakers, panelists, chairpersons, moderators for making this conference a success. Dr. Jundi was supposed to give the vote of thanks. So he waited so much, he left, he had some other appointments. So I would like to thank Mr. Tawfiq. Really, no, you don't find such a good sponsor. I would like to thank our viewers till now staying with us and really tolerating us. Mr. Tawfiq has given us this promise. He will have a gala for part 1 and part 2. All part 1 and part 2 we will have a gala meeting together. So soon we will announce. I would like to thank the management of NMC for giving this CME accreditation. All viewers, all DPC members who are actively participating, of course, especially Tawfiq, Fadi, and all executive committee members, especially Dr. Kalpana, Dr. Diari, of course, Dr. Joshi, our past president, really helping us. The Dubai Pediatric Club meetings are good because of the academics discussion. You will never find any webinar having 2 hours discussion. Never. I would like to thank all of you. I would like to thank everybody. Any comments?
Just one.
Yes.
One small addition, the future direction of DPC in the next year. As we discussed, we will be going towards more inclusivity. So we would include more pediatricians who would like to be, with us as moderators, as panelists. Those who are interested can approach us and we will try to accommodate them. So that is the one announcement I wanted to make. And thank you all. It's been a very interesting day of really an academic feast due to all the distinguished speakers we had. Thank you all.
Thank you very much.
Thank you, Dr. Hassan. Thank you. Thank you, Dr. Walid, Dr. Asra.
And soon we'll put it in the YouTube. Thank you all.
Wallahi, I would like to thank you, Dr. Sohrab, from the bottom of my heart for being so enthusiastic all these years and make all the meetings successful, along with Dr. Kalpana, the organizing committee, our great moderators, chairpersons, my friend Diari, and also this is a good gesture that you invited my friend Dr. Ghassan to this conference. And I can't say more about you, Dr. Sohrab.
Thank you. Thank you.
I agree.
Thank you all. Thank you.
Thank you, Dr. Dibata. Thank you, Dr.
Thank you.
Thank you. Thank you.
Really, Dr. Dibata, the 12 o'clock last night, I
Yes.
told her she accepted. Really, we are
Thank you very
grateful.
much. Thank you very much.
It was a pleasure and honor. Thank you so much. Thank you.
Thank you.
Thank you. Bye-bye.
Bye.
Okay.
Bye.
Bye-bye.